Some live-in-a-box cases and 35 plus challenging cases which will be presented by our dynamic Indian operators. A lot of stress is there on imaging modalities and physiology in the management of coronary artery disease. There are also topics on structural heart disease and newer of active learning. There will be 22 international faculty, 66 Indian faculty of high repute, and 250 digital panelists participating in this year's meeting.
Dear all, welcome to TCT India South Asia 2020. Unfortunately, we can't meet in person this year due to the global pandemic. We have created a virtual conference that we hope will provide learning opportunities for one and all. I'm very excited by the content, including lectures from world-renowned faculty and live case demonstrations. We hope everyone is doing well and staying safe. We look forward to seeing you again soon. Take care.
Welcome to this unique, first-of-a-kind experience with ETCT India 2020. This year, we may not be holding our hands together, but I'm sure our hearts and minds will definitely join together for this unique cardiology experience. Commendable effort, Dr. Srinivas Kumar.
I'm super excited to be part of TCT India South Asia 2020, which is coming up this coming weekend. We're really excited to put on a program that's going to include case examples, tips and tricks, didactic lectures, and essentially ways that you can improve your interventional practice. I hope everybody's staying safe and looking forward to joining everybody online for the virtual event this coming weekend.
I'd like to welcome all of you for this fun, adventurous next 3 days at TCT South Asia, starting Friday, July 31st, with live cases as well as terrific lectures from Antonio Colombo, Greg Stone, and international stalwarts from all across the world, with showcase of terrific intervention as well as new technology, IVL, shockwave therapy, ROTA.
There will be 7 live cases spread across from various parts of the country, some live-in-a-box cases, and 35 plus challenging cases which will be presented by our dynamic Indian operators. A lot of stress is there on imaging modalities and physiology in the management of coronary artery disease. There are also topics on structural heart disease and newer interventions and innovative therapies.
It's my proud privilege and honor to welcome you all for the TCT India South Asia meeting, which is scheduled to be held on this weekend. Srinivas, the FACTS Foundation, and the organizers have put together a wonderful program. We all look forward to join you on the virtual platform for the first time in the history of the program. Congratulations, Srinivas. Best wishes, and we all look forward to meet you on the virtual platform. Thank you.
Welcome to TCT 2020. We welcome all the delegates to have an excellent academic feast for the next 3 days. The message for the younger generation cardiologists in 2020 is we should develop other skills and hobbies during tough COVID times. And the most important skill we should all have is investment skills we should learn in COVID times, because all of us have become cardiologists and we're already academically excellent when compared to other doctors. And I request you all to develop investment skill. And that's a message for 2020. Thank you. Bye. Have a good time.
I encourage attendees to join this in large numbers, because maybe this is the only way academic exchange could happen in the current times of the corona pandemic, at least seeing the way it is proceeding. I wish Dr. Srinivas a grand success for the meeting, and I hope that people have a good take back from the same. Thank you.
I will request all of you to block your time and be there at 3 p.m. on Friday, 31st July, where Antonio Colombo will inaugurate this session.
Whenever I'm in India, I feel the hospitality, I feel the friendship.
And we are very thankful to all the cooperation and active support from all the colleagues across the country. Special thanks to the CRF TCT faculty.
Congratulating Dr. Srinivas Kumar and the rest of the organizers for TCT India and South Asia 2020, and everyone should have a great time at this meeting. I welcome each and every delegate and participant. We should all have a very enjoyable experience and gain a lot of knowledge from this wonderful meeting. Look forward to seeing you all, and goodbye. Thank you very much.
And in this tough times, we request all of you to stay home, stay healthy, and join for this meeting on July 31st. Thank you. Dear friends, greetings from Fax Foundation, TCT India South Asia 2020. We are very happy to inform you that this ETCT will be from July 31st, 1st August and 2nd August 2020. This year's academic feast consists of 33 hours of active learning. There will be 22 international faculty, 66 Indian faculty of high repute. Dear friends, greetings from Fax Foundation, TCT India South Asia 2020. We are very happy to Dear friends, greetings from Fax Foundation, TCT India South Asia 2020. We are very happy to inform you that this ETCT will be from July 31st, 1st August and 2nd August 2020. This year's academic feast consists of 33 hours of active learning. There will be 22 international faculty, 66 Indian faculty of high repute, and 250 digital panelists participating in this year's meeting.
Dear all, welcome to TCT India South Asia 2020. Unfortunately, we can't meet in person this year due to the global pandemic. We have created a virtual conference that we hope will provide learning opportunities for one and all. I'm very excited by the content, including lectures from world-renowned faculty and live case demonstrations. We hope everyone is doing well and staying safe. We look forward to seeing you again soon. Take care.
Welcome to this unique first-of-a-kind experience with ETCT India 2020. This year, we may not be holding our hands together, but I'm sure our hearts and minds will definitely join together for this unique cardiology experience. Commendable effort, Dr. Srinivas Kumar.
I'm super excited to be part of TCT India South Asia 2020, which is coming up this coming weekend. We're really excited to put on a program that's going to include case examples, tips and tricks, didactic lectures, and essentially ways that you can improve your interventional practice. I hope everybody's staying safe and looking forward to joining everybody online for the virtual event this coming weekend.
I'd like to welcome all of you for this fun, adventurous next 3 days at TCT South Asia, starting Friday, July 31st, with live cases as well as terrific lectures from Antonio Colombo, Greg Stone, and international stalwarts from all across the world, with showcase of terrific intervention as well as new technology, IVL, shockwave therapy, ROTA.
There will be 7 live cases spread across from various parts of the country, some live-in-a-box cases, and 35 plus challenging cases which will be presented by our dynamic Indian operators. A lot of stress is there on imaging modalities and physiology in the management of coronary artery disease. There are also topics on structural heart disease and newer interventions and innovative therapies.
It's my proud privilege and honor to welcome you all for the TCT India South Asia meeting, which is scheduled to be held on this weekend. Srinivas, the Fax Foundation, and the organizers have put together a wonderful program. We all look forward to join you on the virtual platform for the first time in the history of the program. Congratulations, Srinivas. Best wishes, and we all look forward to meet you on the virtual platform. Thank you.
Welcome to TCT 2020. We welcome all the delegates to have an excellent academic feast for the next 3 days. The message for the younger generation cardiologists in 2020 is we should develop other skills and hobbies during tough COVID times. And the most important skill we should all have is investment skills we should learn in COVID times. Because all of us have become cardiologists and we're already academically excellent when compared to other doctors. And I request you all to develop investment skill. And there's a message for 2020. Thank you. Bye. Have a good time.
I encourage attendees to join this in large numbers because maybe this is the only way academic exchange could happen in the current times of the corona pandemic, at least seeing the way it is proceeding. I wish Dr. Srinivas a grand success for the meeting, and I hope that people have a good take back from the same. Thank you.
I will request all of you to block your time and be there at 3 p.m. on Friday, 31st July, where Antonio Colombo will inaugurate this session.
Whenever I'm in India, I feel the hospitality, I feel the friendship.
And we are very thankful to all the cooperation and active support from all the colleagues across the country. Special thanks to the CRF TCT faculty.
Congratulating Dr. Srinivas Kumar and the rest of the organizers for TCT India and South Asia 2020, and everyone should have a great time at this meeting. I welcome each and every delegate and participant. We should all have a very enjoyable experience and gain a lot of knowledge from this wonderful meeting. Look forward to seeing you all, and goodbye. Thank you very much.
And in these tough times, we request all of you to stay home, stay healthy, and join for this meeting on July 31st. Thank you. Dear friends, greetings from FACTS Foundation, TCT India South Asia 2020. We are very happy to inform you that this ETCT will be from July 31st, 1st August and 2nd August 2020. This year's academic feast consists of 33 hours of active learning. There will be 22 international faculty, 66 Indian faculty of high repute, and 250 digital panelists participating in this year's meeting.
Dear all, welcome to TCT India South Asia 2020. Unfortunately, we can't meet in person this year due to the global pandemic. We have created a virtual conference that we hope will provide learning opportunities for one and all. I'm very excited by the content, including lectures from world-renowned faculty and live case demonstrations. We hope everyone is doing well and staying safe. We look forward to seeing you again soon. Take care.
Welcome to this unique first-of-a-kind experience with ETCT India 2020. This year, we may not be holding our hands together, but I'm sure our hearts and minds will definitely join together for this unique cardiology experience. Commendable effort, Dr. Srinivas Kumar.
I'm super excited to be part of TCT India South Asia 2020, which is coming up this coming weekend. We're really excited to put on a program that's going to include case examples, tips and tricks, didactic lectures, and essentially ways that you can improve your interventional practice. I hope everybody's staying safe and looking forward to joining everybody online for the virtual event this coming weekend.
I'd like to welcome all of you for this fun, adventurous next 3 days at TCT South Asia, starting Friday, July 31st, with live cases as well as terrific lectures from Antonio Colombo, Greg Stone, and international stalwarts from all across the world, with showcase of terrific intervention as well as new technology, IVL, shockwave therapy, ROTA.
There will be 7 live cases spread across from various parts of the country, some live-in-a-box cases, and 35 plus challenging cases which will be presented by our dynamic Indian operators. A lot of stress is there on imaging modalities and physiology in the management of coronary artery disease. There are also topics on structural heart disease and newer interventions and innovative therapies.
It's my proud privilege and honor to welcome you all for the TCT India South Asia meeting, which is scheduled to be held on this weekend. Srinivas, the FACTS Foundation, and the organizers have put together a wonderful program. We all look forward to join you on the virtual platform for the first time in the history of the program. Congratulations, Srinivas. Best wishes, and we all look forward to meet you on the virtual platform. Thank you.
Welcome to TCT 2020. We welcome all the delegates to have an excellent academic feast for the next 3 days. The message for the younger generation cardiologists in 2020 is we should develop other skills and hobbies during tough COVID times. And the most important skill we should all have is investment skills we should learn in COVID times. Because all of us have become cardiologists and we're already academically excellent when compared to other doctors. And I request you all to develop investment skill. And that's a message for 2020. Thank you. Bye. Have a good time.
I encourage attendees to join this in large numbers because maybe this is the only way academic exchange could happen in the current times of the corona pandemic, at least seeing the way it is proceeding. I wish Dr. Srinivas a grand success for the meeting, and I hope that people have a good take back from the same. Thank you.
I will request all of you to block your time and be there at 3 p.m. on Friday, 31st July, where Antonio Colombo will inaugurate this session.
Whenever I'm in India, I feel the hospitality, I feel the friendship.
And we are very thankful to all the cooperation and active support from all the colleagues across the country. Special thanks to the CRF TCT faculty.
Congratulating Dr. Srinivas Kumar and the rest of the organizers for TCT India and South Asia 2020, and everyone should have a great time at this meeting. I welcome each and every delegate and participant. We should all have a very enjoyable experience and gain a lot of knowledge from this wonderful meeting. Look forward to seeing you all, and goodbye. Thank you very much.
And in these tough times, we request all of you to stay home, stay healthy, and join for this meeting on July 31st. Thank you. Dear friends, greetings from Fax Foundation, TCT India South. Dear friends, greetings from Fax Foundation, TCT India South Asia 2020.
Dr.
We are very
Kumar
happy to inform you
for
that this
making
TCT
this meeting happen. Level-free approach, including treatment of diffuse coronary disease.
So, it's always also a pleasure to speak after Dr. Antonio Colombo that actually introduced some of the concepts that I would like to stress.
My
partner for 20 years is the international cardiologist.
Everyone is doing
Next
well
to
and
him is
staying
Atul,
safe. We look forward to seeing you again soon.
nurse and
Take care.
technician. And then we have Raj from Abbott. We have Vinit
experience.
and
TCT
Vipul
India
will be running the
2020.
OCT. The elderly
This year,
lady,
we may not be holding
80-year-old,
our hands together.
came last night, highly
sure
unstable.
Our hearts and minds will definitely join together for this unique cardiology experience. Commendable effort, Dr. Srinivas Kumar.
I'm super excited to be part of TCT India South Asia 2020, which is coming up this coming weekend. We're really excited to put on a program that's going to include case examples, tips and tricks, didactic lectures, and essentially ways that you can improve your interventional practice. I hope everybody's staying safe and looking forward to joining everybody online for the virtual event this coming weekend.
I'd like to welcome all of you for this fun, adventurous next 3 days at TCT South Asia, starting Friday, July 31st, with live cases as well as terrific lectures from Antonio Colombo, Greg Stone, and international stalwarts from all across the world. With showcase of terrific intervention as well as new technology, IVL, shockwave therapy, ROTA.
There will be 7 live cases.
Can somebody unmute Dr. Ramesh?
Some live in a box cases and 35 plus challenging cases which will be presented by our dynamic Indian operators. A lot of stress is there on imaging modalities and physiology in the management of coronary artery disease. There are also topics on structural heart disease and newer interventions,
Dr. Ramesh.
innovative therapies.
It's my proud privilege and honor to welcome you all for the TCT India South Asia meeting, which is scheduled to be held on this weekend. Srinivas, the Facts Foundation, and the organizers have put together a wonderful
Good morning, Dr.
program.
Bhatti here.
We all look forward to joining on the virtual platform for the first time in the history of the program. Congratulations, Srinivas. Best wishes, and we all look forward to meet you on the virtual platform. Thank you.
I welcome
to
everyone.
TCT 2020.
This is
We welcome all the
fantastic
delegates
session
to
of
an
live,
excellent academic feast for the
from
next
Eternal
3
Heart
days.
School, Jaipur.
The message
by
for the
Dr.
younger generation
Sandeep Sharma.
cardiologists in
And
2020
we have
is
the co-chairs,
we should
Dr.
develop other skills and
P.C.
hobbies
Radhakrishnan,
during
Dr.
tough
Aditya
COVID
Kapoor,
times. And the most
Dr.
important
Ramakrishna
skill
will be
we should
moderating
all
the session
have
itself.
is investment
Great
skills
to
we should
have
learn in
each and
COVID
everyone
times.
at
Because all of us
TCT,
have become
India,
cardiologists
South
and we're
Asia
already
2020,
academically excellent when
which is
compared
a
to
completely
other doctors.
virtual
And I
meeting
request
for
you
the
all
first
to
time.
develop investment skills.
Great
And
to
that's the
have all of
message
you, and
for 2020.
we look
Thank
forward
you.
to learning from each
Bye.
other at
Have
this
a
session.
good time.
With that,
I encourage
Dr. Sharma, please go ahead and
attendees to
introduce your
join this in
patient.
large numbers, because maybe this is the only way academic exchange could happen in the current times of the corona pandemic, at least seeing the way it is proceeding.
So we'll
I wish
start with Dr. P.C. Rath and then we'll go to Jaipur, sir.
And I hope
Okay, first you will go to Dr. Rath.
have
Is it
a
so?
good take back from the same. Thank you.
Just put it to block your time there at 3 p.m. on Friday, 31st July, where Antonio
Hello.
Colombo will
Hello.
inaugurate the session.
Good afternoon, everybody. Can you hear me?
The hospitality, I feel Yes, the we can. friendship.
Yeah.
Yes, sir.
Can you see my
Yes, sir.
slides?
We're able to hear you.
And
Can you see my slides?
all the colleagues across the country.
Yes, not.
Special
Yes, sir.
thank you to
Yes, yes.
CRF,
Yeah.
TCT faculty.
Just going to present a very interesting case of Liam Savage, a COVID patient with acute limb ischemia. This is a 62-year-old lady, diabetic and hypertensive, admitted with severe COVID pneumonia in her COVID ICU, and she has severe respiratory type 1. And on day 12, they noticed that she is having severe pain in the right lower limb,
Times, we request all of you to
and
faculty.
she had a arterial line, femoral arterial line, and from 7 days they put it to monitor the frequent, they do the KBG frequently through this line. And in 15 days or so, there was a foot drop, and Doppler showed no flow in the femoral or popliteal segment, confirming the diagnosis of
Dear
arterial
friends,
thrombosis and acute limb
greetings from
ischemia.
Facts Foundation, TCT India, South Asia.
And this was a grade 2B.
We're very happy to
acute limb
TCT
ischemia.
will be from July 31st
Patient was,
to 2nd August.
when he was, patient actually was, so
This
we
year's
took
academic
the
week
patient
consists of,
for a angio with all precautions, protections,
active learning,
and we did it from the
66
left
Indian
side,
faculty of
frontal side injection. You can
digital
see
analysts participating
the external iliac is totally occluded.
Dear all,
Thomas,
welcome to TCT India
and
South
this
Asia
reforming in the femoral, mid
Unfortunately, we
femoral,
can't meet in
and
person
again
this year due to
reforming
the
in
global
the
pandemic.
oblique
We've
artery,
created a virtual
indicating
conference
that
that will
multiple
provide
level
learning
of
opportunities for one
thrombosis
and all.
cannot be
We're very
explained with the
excited by
femoral
the
line
content,
alone.
including
And
lectures
she's a
from
COVID
world-renowned
patient.
faculty and
They are
live case
known to have
demonstrations.
hypercoagulable state.
We hope everyone is doing well and staying
After
safe.
seeing
We look
this,
forward to seeing you again soon.
we asked the surgeon to
Welcome
take over
to
and
this unique
take out the
first-of-a-kind
clots.
experience
But
with
the patient was very
India
sick, not
2020.
suitable for general
This
anesthesia.
year, we may
The
not
patient
be holding
was on
our
anticoagulant,
hands
so
together. Our hearts and minds will definitely
spinal
join
anesthesia was ruled out.
this unique
It was very oblique, and the surgeon, the vascular surgeon, didn't want to
I'm super
do
excited
under
to
local
be part
anesthesia.
of TCT India South Asia
So
2020.
we
which is
decided
this coming
that,
weekend. We're really excited to put on a program that's going to include
surgical
case
option was
examples,
not
tips
there.
and tricks, didactic
We
lectures,
decided
and
to
essentially ways to
embolize the
improve
patient.
interventional practice.
And,
I hope everybody's
we
staying
put a,
safe and looking forward to
6
joining everybody online for the virtual
Reference
event this
catheter.
coming weekend.
I'd like to welcome all of you for this fun, and with connected race, next 3 days at TCT South Asia, starting Friday, July 31st.
And next day,
live cases as well as terrific lectures from Antonio Colombo, Rex Stone, and international stalwarts from all across the world,
is totally uploaded.
with showcase of terrific intervention as well as new technology,
And after that is
IVL, shockwave therapy,
So at this
Rota.
time, we had this Penumbra. We thought we'll use this Penumbra devices. Penumbra 6 is usually useful in the arterial thrombosis. We put a 6 We put a first 8 catheter, crossover catheter on the left side, so that we took the Penumbra catheter.
My privilege and honor to welcome you all
And
to the TCT
first
India
we did
South Asia
the
meeting, which is
Profunda. First, it was total of
this weekend.
first week.
Srinivas, the Facts
Worked
Foundation,
out all the
the
cross
organizers have put
on
together a
Profunda,
wonderful
and then we can see
program.
this.
We all look forward
Now
to
the flow
joining
has
on the
started in
virtual platform
Profunda,
for the first time in the history
and
of the
then
program. Congratulations,
we picked up
Srinivas. Best wishes,
Penumbra
and we
catheter
all
down
look
up
forward
to the
to meeting
popliteal
on
artery.
the virtual platform.
There,
Welcome to
and the
TCT
doctor was there
2020.
itself,
Welcome
so
all the
we-
delegates to have an
from
excellent
there we
academic
started
feast for the next 3 days.
taking out the
The
clots.
message for the younger generation
And
cardiology
Penumbra
in
catheter,
2020
once you
is
take it,
we should
put your
develop
face
other
with the
skills
switch
and
on,
hobbies during tough
and
COVID
after
times.
multiple
The most
suction, you
important
can see
skill
all
we should
the
all have
posterior very
is
nicely
investment
seen,
skills we should learn in
partly
COVID
anterior
times.
seen.
Because all of us have become
And after
cardiologists
that,
and we're already
until
academically
the patient
excellent
is
when
given
compared to
infusion,
other doctors. And I
Antityl
request
and
you all
steroid
to
was
develop
given
investment
for
skills. And that's
48
the
hours to
message
prevent
for
hypertrophic angina.
2020.
That is
Thank
routinely used
you.
by the
Bye.
vascular
Have a good
surgeons.
time.
And
I
we
encourage
infuse 2 units of
attendees
blood.
to join this in large numbers
After that,
because
we
maybe
check
this is the
the
only way
48 hours
academic
later. By that
exchange
time,
could happen
immediately after
in the
the
current
pain
times
subsided,
of the
and we could feel the
pandemic.
pulse in the
At
dorsalis
least
pedis,
seeing the way it is
and we
proceeding.
checked with
I
Doppler.
wish
You can
Dr.
see the flow is
Srinivas
clearly
success for the meeting.
in dorsalis pedis and posterior artery flow is good. And we can see she had a foot drop,
Request all of you to
and she was first pain disappeared. Then after 48 hours, the movement in the ankle joint improved. It was not the toes was not moving at all. She was not able to move, and there was a little discoloration there. That also improved the anesthesia.
special thanks.
And with this procedure, we could salvage the vein. Probably in time, I hope so that those also will improve, or she may lose 1 or 2 toes. But the vein is salvaged.
Everyone
So of course,
have a great time at
I
this
think the
meeting.
learning
I
in this
welcome
case,
every
COVID
delegate
induced hypercoagulable
and,
state
participant.
results in
We
variety
all
of
have a
spectrum of
very enjoyable
complications.
experience
Catheter
and
guided
very
intervention
lot
for
of
threatening
knowledge
limbs,
from
safe in
the
patients
Look forward
whose
to
are
seeing you all.
most of the patients with COVID pneumonia are high risk for anesthesia. So probably catheter interventions is a safe option.
And join
Adjuvant thrombolytic therapy paired to mechanical thrombectomy improve the chance of success. In this case, the clot bottom came down drastically, and after giving 24 hours kinetic rest, and we could suck out the by using this Penumbra device, we could take out the clot from the popliteal artery, and the flow was established to go away. And most importantly, when you do this type of patients with COVID,
person this year due to the global pandemic. We have created a virtual conference that we hope will provide learning opportunities for one and all.
Good afternoon,
We're
everyone.
very excited by the content.
Can you hear me?
Lectures from
Yeah, yeah.
world-renowned
Good afternoon, Dr. Sharma.
Yeah, good afternoon, everyone. And
We hope everyone
I
is
welcome
doing
you
well and
all
staying
on
safe.
behalf of
We
Veteran
look forward to
Hospital,
seeing you
Jaipur.
again soon.
And
Take care.
first of all, I would like to thank
Dear friends, greetings from Facts Foundation, TCT India South Asia
Session.
2020.
Initially, I had planned to do it live, but because of COVID pandemic, that patient was not willing to stay back or was not willing to come back for the case. So we did this case on Monday, 27th of July, just 5 days back. And this case had many learning points, so thought this is the ideal case to show for this meeting.
Indian faculty of high repute and 250
So about the clinical profile of the patient, he's a 65 years old male who's a non-diabetic,
Welcome to
normotensive,
TCT India South
non-smoker,
Asia 2020.
and he got
Unfortunately,
admitted
we
at
can't meet in
outside
person this
hospital
year
with
due to
a
the global
acute
pandemic.
MI on
We have created a
23rd
virtual
of
conference
June
that we hope will provide
at
learning
outside
opportunities
hospital,
for one and
2
all.
kilometers from
I'm
here.
very excited by
And
the
there
content,
he underwent
including
angiography,
lectures from
which
world-renowned
revealed a three-vessel
faculty and live
disease
case
and
demonstrations.
100% occluded
We hope
right coronary
everyone
with
is
a
doing
heavy
well and
calcification
staying
in all
safe.
three vessels.
We look forward to seeing you again
And
soon.
there he
Take
underwent
care.
primary PCI with thrombosuction and
This
2 overlapping
unique
DS.
First of a kind
And
experience
subsequently he was doing
with
apparently
ETCT
well and in
India
between a few episodes of angina.
This
And
year,
he came
we
to
may
us
not be
this
holding
week,
our
in the
hands
beginning of
together,
this week.
but I'm
And
sure our hearts and minds
the ECG
will
had just
definitely
serial
join
changes of
this
recent
unique
inferior MI.
launching
Ejection fraction was quite good, it's at 50 to 55%, no mitral regurgitation.
I'm super
And
excited
other lab
to be
reports were
part
within
of
normal
TCT
limits.
India South Asia 2020.
On the
which is
basis of
coming up this coming weekend.
this clinical background,
We're really excited to put on a
we
program
review the
that's gonna
angiography
include,
first.
case examples,
And this
tips
is
and
the
tricks, didactic
semi-selective
lectures, and
injection
essentially
because
ways that
the
you can
stent
improve
was
your interventional
right from the
practice.
osteomore. It
I
was
hope
protruding
everybody's
2 to 3
staying safe
millimeter
and
into the
looking forward to
aorta.
bringing everybody
So it was
online for the virtual event
so it
this
was
coming
nicely
weekend.
patent stent,
I'd like
which
to
were
welcome all of you
almost a month back.
for this fun, adventurous
And here you can
next
see
3
it's
days
a very tight,
at
heavily
TCT
calcified,
South Asia,
right from the
starting
osteoproximal
Friday, July
segment to the
31st,
mid-distal segment
with
of the
live
LAD.
cases
And
as
distal
well
LAD
as
looks quite
terrific
good, and there is
lectures
a
from
tight
Antonio Colombo,
osteocalcification of the
Blackstone,
diagonal,
and
moderate-sized
international
diagonal.
stalwarts from
And
all across the
circumflex has a
world,
moderate disease 6 to
with
70%.
showcase of terrific
On the basis of this
intervention
angiogram,
as
we
well
had a
as new
discussion with the family,
technology,
and because the
IVL,
LED diagonal on
shockwave
OM, whether you should
therapy,
go for the
rota.
There will be 7 live cases spread across from various
LED diagonal on OM,
Some
whether
live
you should go for the
cases.
cabbage or the
35
PCI.
plus, challenging
And
cases
syntax,
which
residual
is
syntax score
presented
was 27, 28.
we are
And
lot of
we discussed in the
stress
heart
there
team,
on, imaging
and we decided to go for the PCI. So I would like to have a comment from the expert panel and the chairperson. How would like to go ahead with this intervention if you go for, because the LED is heavily calcified.
This weekend, Srinivas, the Facts Foundation, and the organizers have
And the
put
distal
together a
long
wonderful
segment.
program. We all look forward to join you on the virtual platform for the
I'll show
first
you
time
the-
in the history of
And
the
now we'll
program.
replay the angiogram.
Congratulations, Srinivas. Best wishes, and we all look forward to meet you on the virtual
RCA
platform.
was
Thank you.
nicely
Welcome
patent.
to TCT 2020. We welcome
And
all the
it is
delegates
heavily
to an
calcified
excellent
right from
academic feast
proximal
for
to
the
mid-distal
next 3
segment, and
days.
diagonal also had a
The
disease, very
message for
tight,
the younger generation
99%,
cardiology in
and OM has a
2020
moderate
is
disease.
we should develop other
So,
skills and
what
hobbies
should be
during
the strategy
tough COVID times.
for the?
And
We had
most
planned for the
important
LED even
skill
bifurcation
we should all
for
have
this setting,
is investment
and
skills
the
we should
plan
learn
was
in COVID times.
because it was
all of
very
us are
tight
become
lesion in the
cardiologists
proximal
and we're
mid
already
segment.
academically
So I thought
excellent
I
in
must
compared to other doctors.
cross with the
And I
workhorse
request you
wire
all
and
to develop
take
investment
OCT
skills,
run,
and there's a
and
message
subsequently go for the
for
plaque
2020.
modification,
Thank
rotablation.
you. Bye.
But
Have a good
OCT catheter
time.
was not going
I
across. It is
encourage
such a heavily
attendees
calcified,
to
tightly
join
stenosed
this
vessel.
in large numbers
The
because
OCT catheter was not
maybe this
going
is the
across.
only way academic
Then I
exchange
planned
could
for
happen
crossing with
in
the
current
field of fine
times
cross,
of the corona
and this is wire
pandemic.
going across
At least
the
see
LED,
the way it
and
is
with
proceeding.
the
I wish Dr.
fine cross catheter.
Srinivas
In the
a
fine
grand
catheter,
success for
fine
the
cross
meeting.
catheter is down.
And I
You can
hope
clearly appreciate when fine cross catheter is being advanced, the guide was backing out.
from the same.
So by keeping the microcatheter there, this is the
and be there.
O14. This is the rotafloppy bar being negotiated into the LED till the distal segment, and now this microcatheter is being withdrawn. The guide sucking a little bit. And subsequently, we started with the rotablation.
Special thanks to the CRF TCT.
Hemodynamics was quite stable. Initially, rotablator 1.5 millimeter was taken and started rotablating the proximal segment because the disease started right from the osteoproximal segment, and mid-distal part was very tightly, very heavily stenosed, and also it had 2 bends or a little bit of tortuosity. So it was a quite complex, heavily calcified lesion, and the rotablation, while rotablating the proximal segment, hemodynamics were quite stable. We didn't have any significant compromise in hemodynamics.
Request all of you to stay.
And at this segment, you can clearly see the rotablator burr is getting a little bit of resistance at this mid-distal part where there was heavy calcium and also there was acute bend. So it becomes a little tricky at this. If you press it too hard, it might cause a perforation. But for all the new interventionists, it's very important to have a patience and just gentle packing movement and little bit of support from the guide catheter by your left hand, you just keep a little push from the guide catheter and the nice packing movement and little bit of your push and gentle packing movement. Eventually, you are able to cross the lesion. So you can see the how now it's able to cross it, and this was 1.75 burr, and able to cross the lesion and a little bit of polishing. Now the question comes, should I go for the 175 burr? But I would, at that point of time, I need to image the vessel first, because it is, we need to have complete information how much calcium is there, and what is the extent, and what is the kind of, it was a circumferential calcium. Now you can see after rotablation, the vessel is quite big, and 2 deep calcium, and also in the ostium of the diagonal is heavily calcified. Now this is the workhorse wire. This is run through wire coming up, and
This year, we may
over
not
that
be
wire,
holding our hands
we
together.
did the first
I'm
OCT
sure
run.
Our hearts and minds
And
will definitely
I'll
join
show you the
together
OCT run.
for this unique cardiology experience. Commendable effort, Dr.
You can clearly see initially there's a little bit of salt from the blood, and this vessel is a very
2020, which is coming up
diffused disease, heavily
We're really
calcific.
excited to put on a program
You can
that's
see
going
a
to
lot of
include
calcium.
case examples, tips and
This fact,
tricks,
so that,
didactic lectures,
if
and
you,
essentially ways that you can improve. your
there's a
interventional
flap
practice.
because of the rotablation and the dense calcium. You can clearly appreciate
Everybody online
the heavily
for this event
calcified.
this coming weekend.
I'd like to
And there is a
welcome
dense
all of
calcium
you for this fun, adventurous,
multiple places, right from
next
90
3
degree,
days
at some places
at
it's
TCT
around
South
270 to
Asia,
360 degree
starting
calcium.
Friday, July 31st.
Big chunk
with
of
live cases
calcium at
as
multiple
well as
places,
terrific lectures
and
from
almost
Antonio
diffused disease.
Colombo, Greg Stone,
And this calcium is
and
right from the distal to the
stalwarts from
proximal
all
segment
across
of
the
the
world,
vessel. There is a
with
few flaps
showcase
caused
of
by the
terrific
rotablation,
intervention,
but there's a lot of
as
calcium
well
at
as new
multiple places.
technology, IVL,
So
shockwave
I would like
therapy,
to, if we can have a
7 live
interaction, have an opinion of expert panel after this view of OCT.
challenging cases which
First, let's have a OCT analysis. This is the very heavily calcified, diffused disease, stenosed, and there are a few flaps created by the rotabur. And we can clearly appreciate there's a dense calcium, and it's deep into the medial layer.
Proud privilege
It's
and
not
honor
only
to welcome
superficial,
you
but
all
dense
for the
calcium
TCT India
involving
South
the
Asia meeting
medial layer.
scheduled to be held on
And
this
there are few
weekend.
flaps
Srinivas, the Facts
caused by the
Foundation,
rotabur.
the organizers have put together a wonderful
So to go next,
program.
I would like to
We
have
all
opinion
look
of the
forward to
expert
joining
panel
on the
or
virtual platform
chairpersons.
for the first time in the history of the
The
program.
next step, what should be it? Whether
Congratulations, Srinivas.
I need
Best
to upgrade
wishes,
my bird to
and we all
175
look
or
forward to
go with a
meet you
high pressure
on the
NC balloon and break the lesion,
Welcome
or
to
should I
TCT
use a scoring
2020.
balloon and
Welcome all
break the
the
lesion,
delegates
or
to
third
an
one is a
excellent academic
IVL,
feast for the next
just like
3 days.
rotatrepsy, and
The message
use
for
a
the younger
shockwave
generation
and break this deep
cardiologists in
calcium.
2020 is we should
Dr.
develop other
Dagupati,
skills and hobbies during tough
what's
COVID
your
times.
choice next?
And the most important
Next, what should be
skill
my
we
next
should
step?
all have is investment skills we should learn
Hello?
in COVID times. Because all of us have become
Hello?
cardiologists
Yeah.
and we're already
Yeah, Dr. Rat,
academically
please.
excellent when compared to
It's
other doctors.
it's
I request you all to develop
diffuse
investment
long
skills, and
segment
that's a message
calcified disease.
for
Yes, yes.
2020.
And
Thank
you have made
Bye.
the
Have a
channel.
good time.
I think you have to, I think intracoronary lithotripsy
Yeah.
because
not
maybe
very
this is
suitable
the
for
only
this
way
type of
academic
lesion.
exchange could happen.
I think
in the current times
either you have to upgrade
of
your
pandemic.
rota
At
bulb,
least
or
this
you
is the
can
way it
use
is proceeding. I wish Dr.
balloons also to
Srinivas
dilate and make the passage for the stain to go.
people
Yes, yes.
have a good
So,
NC balloon is a good choice.
from the same.
You can
Yeah.
try with NC balloon
all of you to block
and try to expand this
3 p.m. on
calcium
Thursday, 31st July, when Antonio Colombo will
Yeah.
inaugurate this.
So Dr. Dagupati, you also you agreed to the same. Should we go ahead with the high pressure NC balloon or a scoring balloon to crack the calcium and what about the side branch? Do you consider side branch is a significant one, and should we do it as a dedicated bifurcation or as a provisional?
I mean, I think it is always better to do it as a provisional unless the side branch lesion is more than 10 millimeters. And it's not a bad idea, since you have an OCT, to also analyze the side branch if you have it. And I agree with Dr. Rath that NC balloon would be the optimal right now, or angiosculpal cutting balloon as well.
Yeah, great. So it was the same. I also did with the NC balloon at high pressures, and then subsequently with the scoring balloon angiosculp at high pressure. But I would like to preserve my diagonal branch, which was very tight, 99% with a lot of calcium right at the ostium. And unless I do a rota, I won't be able to cross this branch. So I try to preserve and keep the strategy same as a provisional for the stanting, but at least do a rota and make some space for the intervention. So this is crossing the with a feeder wire because it was quite little angulation in the origin of the diagonal. So we cross with the your fielder fine cross and then exchange with the rota wire and started burying with the 125 burr. And with a little bit of a packing movement, I had been able to cross the diagonal ostium and subsequently did the burying for the mid diagonal also, which is also heavily calcified.
Faculty, 66 Indian faculty of high repute, and 250 digital panelists participating in
so the 125 burr,
yes.
And
Dear all,
because for the LED I use 1 to
South Asia
1.5. But for
Unfortunately,
diagonal,
we can't meet in
definitely
person this year due to the
it was a moderate
pandemic.
size. So
We have created a
your
virtual
safer side,
conference that we
125
hope to
burr
provide
did a
learning
very good
opportunities for
job.
one and all.
And,
I'm very excited by the content, including
And to my surprise,
lectures
after
from world-renowned
burying the
faculty
diagonal
and live case
branch,
demonstrations.
the flow improved
hope
very
everyone
much
is
in the
doing
diagonal
well
branch,
and
and the
staying
ostium
safe.
was
We look
not
forward to seeing you again soon.
like a dissected.
Take
It was a very
Welcome
clean, and after calcium had been ablated, it was looking very nice. And then we rewired the LED.
This
The
year,
workhorse
we may not be
run through
holding our
wire
hands together.
after finishing the rotablation in the diagonal branch
Hearts and minds
and
will definitely
rewired the
join
diagonal
together
also.
for this unique cardiology experience. Commendable effort, Dr. Srinivas Kumar.
This is rewiring
I'm
for
super
the
excited
diagonal.
to be part of
Went
TCT
through
India
easily
South
after this
Asia 2020,
rotablation
which is
for the
coming up
diagonal.
this coming weekend. We're really excited to put on a program
you
that's
can
going to
appreciate
include
that,
case examples,
angiographic,
tips and tricks, didactic lectures,
picture,
and essentially ways that you can improve your
is looking
interventional
quite good.
practice. I hope everybody's
Remove
staying
this,
safe and looking forward to
rotavar
joining
and-
everybody online.
It's looking quite nice. Diagonal ostium
I'd
was
like
very
to welcome
tight.
all
Now
of
it's
you
reasonable
for
and
this
it's nicely opened up without any dissection.
adventurous
Then
next 3
I
days
tried with the
at
pre-dilatation
TCT
with the
South
NC balloon.
Asia,
And
starting
initial
Friday,
dilatation was
July
at 2.75 into
with live
15 NC
cases
balloon at
as well as
24, 26,
terrific
28
lectures from
atmosphere.
Antonio Colombo, Greg
Started right from the
and
distal to
international
mid-LED and
stalwarts
then
from all across the world
into the
with
proximal LED.
showcase of terrific intervention
But you can
as
see the
well as
paste
new
at multiple
technology,
places in the mid and the
IVL,
proximal part of
shockwave
the LED
therapy,
and also at the
rota.
osteoproximal LED. There was dense calcium. So it was
Some live
like
in
a
box cases and
very
35
heavily
plus
calcified
cases which will be
LED lesion.
presented
Then again there is a dilatation by the 3 millimeter NC balloon again at a 24, 26, 28 atmosphere
physiology.
just to prepare the bed for the
There is also
mid-distal LED stand.
structural heart disease and newer
And
interventions,
it was
innovative therapies.
given an
It's
optimal
my proud
dilatation
privilege and
because
honor to
unless you
welcome
prepare
you
the
all
bed,
for
you
the
will not
TCT
be able
India
to
South
open up the
Asia meeting,
stand
which is
subsequently by the
scheduled to be
post
held
dilatation.
on this
So it's
weekend.
very important to
Srinivas
have a good
Facts
preparation of the
Foundation
bed
and the
for
organizers have put together a
optimal
wonderful
deployment as well
program.
as for a
We
future
all look
prevention of
forward
the
to join you on the
events.
virtual platform for the first
So,
time in the history
during
of
this
the
whole
program.
procedure, patient maintains good
Congratulations,
hemodynamics.
Srinivas. Best wishes.
And
we
after
all
dilating
look
this
forward
mid-distal
to meet you
lesion,
on
we
the
had
virtual
gone with
platform.
this first stand.
Welcome
with
to
the
TCT
333 stand
2020.
in
We
the
welcome all
mid
the
to
delegates
distal
to have an
LED.
excellent academic
And
feast for the next
the
3
intention
days.
was to keep the
The
overlapping
message for the
segment
younger
below the level
generation
of
cardiology
diagonal,
2020
because if you
is
keep
we
overlapping
should
segment
develop other skills and hobbies
on the
during
diagonal,
tough
then
COVID
it's very
times.
difficult to preserve
And
the
most
branch.
important skill
So
we
it
should
was
all have
deployed at
is
12 to
investment
16
skills which
atmosphere
we learn
and
in COVID
pull the
times.
balloon a little back
Because all
and
of
went
us
up
have
to
become cardiologists and we're
18,
already
20 atmosphere.
academically excellent when compared to other
And,
doctors.
then we
And I request
sized
you all
the
to develop investment
proximal
skills.
stand.
And that's a message
It was 33,
for
so
2020. Thank
Dear friends, greetings from Facts Foundation, TCT India South Asia 2020. We are very happy to inform you that this ETCT will be from July 31st, 1st August and 2nd
24, 26 atmosphere at multiple places in the mid and osteoproximal LED. And after the scoring balloon, it was looking quite okay to stand.
66 Indian faculty of
and,
high repute and 250 digital panelists participating in
because the OCT revealed too much of calcium,
Dear
so
all,
we could
welcome to
anticipate
TCT India
how much
South Asia
resistance
2020.
was there
Unfortunately, we
while
can't meet
doing
in
a
person this year
pre-dilatation
due to
with the
global
NC and
pandemic.
scoring balloon.
We have created a virtual
Lot of-
conference that we hope will
You can
provide
see
learning
the waist on
opportunities
the
for
upper
one and
part of
all.
the
I'm very
vessel,
excited by the content,
but
including
still we had been able to
lectures
do
from
it quite
world-renowned
reasonably,
faculty and
the
live case
dilatation.
demonstrations.
prior
We
to
hope everyone
putting
is
up the
doing
stand.
well
After
and
scoring
staying
balloon, it was
safe.
looking
We look
quite
forward to
okay.
seeing you again soon.
And
Take
then
care.
I went ahead with
Welcome
3.5 to 33
this unique
DS
first-of-a-kind
overlapping with the
experience
previous stand.
with ETCT India 2020.
That one looks okay.
This year,
And
we may
this
not
is
be
the
holding our hands
3.5 to
together.
33 in the proximal
sure
LED and
our
overlapping with the
hearts and
previous stand.
minds will definitely join together.
Just
for this
this is the
unique
diagonal wire was removed
cardiology
because it was looking
experience.
okay, and just to avoid the wire
Commendable
interruption.
effort, Dr. Srinivas Kumar.
And then
I'm
little
super excited to
just
be part of TCT
little bit
India
of
South
pull
Asia
back
2020,
just to cover
which
the
is coming up
ostium,
this coming
and
weekend.
then the stent was
We're really excited
deployed.
to put on a program that's going to include case examples, tips
stent
and
was
tricks,
deployed at
didactic
12 to
lectures,
16
and essentially ways that
atmosphere.
you can improve your
It was looking quite
interventional
okay.
practice.
And this
I
whole
hope
procedure
everybody's
was done
staying
from
safe and looking forward to joining
right
everybody
lead to the
online
approach
for
with a
the
6
virtual
French sheath
event this
only.
coming weekend.
I'd like to welcome all of
With the
you
1.5 bar
for
and
this fun,
the
adventurous next
different
3
how they can
days
easily,
at TCT South
negotiated for 6
Asia,
French catheter.
starting Friday, July 31st.
And subsequent to
With
the
live
deployment, we can
cases
see the
as
residual
well as
waste in the
terrific
proximal and
lectures
mid
from
segment of the
Antonio
LED.
Colombo, Greg Stone,
And for that,
international stalwarts from all
we
across the
started the
world,
post dilatation.
with showcase
That
of
is
terrific
quite preserved and it's flowing very
as
well.
well
And
as
the
new
ostium looks okay to me.
technology, IVL,
If you look at the
shock
angiogram
wave
at the baseline,
therapy,
it was a very
rota,
bad
There'll be 7 live
99%
cases
right
spread
the
across
ostium
from
to the
various parts of
proximal mid segment.
Some
But
live
is
in
nicely
box
flowing. So we kept it as a provisional,
35
not to do
plus,
with anything.
challenging cases which will be
And this is the
presented by
3.5
dynamic
balloon.
Indian
We started right just inside the
There are
distal
lot
edge
of
of the distal
stress is
stand
there on,
and went up to
imaging
very high
modalities,
pressures.
physiology in the
In the low down is 16 to 18, then
topics
in the
on
mid
structural
segment
heart
and
disease, newer interventions,
proximal
innovative
segment.
therapies.
It's my proud
We,
privilege and honor to welcome you
gone
all
up to
for the
26,
TCT India South
28
Asia
and 30
meeting, which is
atmosphere.
scheduled to be held on this weekend.
The 3.5.
Srinivas, the Facts Foundation and the organizers have put together a wonderful
Looks a little
program.
better.
We
And
all
then
look forward to
subsequently,
join you on the virtual
further
platform
dilated.
for the first time in the
It
history
looks
of
better than
the
before,
program.
but still there is a residual waste. Then
Congratulations,
we have
Srinivas.
taken a
Best wishes,
375 NC
and we
balloon.
all look forward
And
to
with
meet
that,
you on the
we
virtual
get gone.
platform. Thank you.
Welcome to TCT 2020. We
But high in
welcome
the
all the
mid and
delegates
proximal
to have
segment.
an excellent academic
Now it's in
feast
the
for the next
overlapping
3 days.
stand.
The message for
standard
the younger
segment.
generation cardiologists in
Around
2020
20,
is
24
we
atmosphere,
should develop
26
other
atmosphere.
skills and hobbies
With the
during tough
375.
COVID times. And the
And,
most important
with dilatation
skill
with
we
the
should all
375
have
balloon, it made a big
is
difference.
investment skills we
And,
should learn in COVID
Yeah,
times.
we could see the
But as we know, there are cost constraints, and even actually in the United States, it is only available as a part of research. We do use it in peripheral arterial disease that has been approved quite some time ago, and hopefully the lithotripsy balloon will be approved in maybe in January or February in the United States. But that said, I think you have demonstrated the imaging is very important. People actually sometimes don't use imaging and may not size the vessels appropriately. And I have seen, I think sometimes we do mistakes of placing a 2.5 millimeter stent in the proximal LED. You actually showed that the vessel is large, it is heavily calcified. You did, image guided rotablation and post dilation after the rotablation as well with the angiosculpt, and then post dilated the vessel appropriately. And agreed, Dr. Rath has a good point that someone has to be careful when you're post dilating at such high pressures, that there could be a perforation, obviously. Make sure there are covered stents. And with OCT, you demonstrated that that's what actually Illumin 3 has shown as well. And now we are doing Illumin 4, where actually if you achieve good apposition and the minimal stent area is more than 6 square millimeters, by OCT it could be even more than 5.9 would be enough. But I was more than 6 millimeters square. The results are very good. And your area was much higher than that. And I also want to make a point about your bifurcation strategy. I agree that the main artery is the most important, and you kept the side branch open, and you left it with an atherectomy alone. There was no angiographic evidence of dissection. And if you do an OCT, sometimes we may find non-flow limiting dissections. And what do we do with that? I think if it is more than 270 degree arc of dissection and thick flap of dissection, those you have to cover, but otherwise you don't have to. And OCT really helps in that view as well for those non-flow limiting dissections, how to assess and what should we do with them. People used to think or we find a lot of unnecessary things on OCT, which is not true. And I have to congratulate you for getting an excellent result on this patient. Dr. Rath?
Thank you.
That's a very good case, I think. Thanks to Dharma.
Yeah,
Thank
you very much, and nicely pointed out, because the session was OCT guided or imaging guided PCI. So I thought it's an ideal case to show and how deep is the calcium, how big is the extent of calcium, so that accordingly you can devise your strategy, whether it's a rotablation or rotablation plus lithotripsy or rotatripsy kind of a scenario. So this was an ideal case for the rotablation plus lithotripsy. And definitely, Dr. Daggubati has rightly pointed out, this also helps in kind of assessing the side branch and how much calcium is in the side branch. Had it been kind of a OCT for the side branch along with that LED. And that we got a very nice comments and inputs. And with further, if any comment from any of the panelists?
So I think that's I don't see any questions coming up. Dr. Sharma, thank you very much once again. And I thank my co-chair, Dr. Rath, also as well.
I think one more case I have to show now. Next, one more case is there.
Yes.
Thanks once again from Madeline Hospital, Jaipur. Thank you. Thanks for the opportunity. Thanks, Dr. Daggubati and Dr. P.C. Rath. Thank you.
Thank you very much.
Just going to show my next case. And that is a 39-year-old lady who came 10 days back to the OPD with some vague chest pain, no comorbidity. ECG echo was normal. So I said that I told her to come back with treadmill, but the same night she came to the OPD with worsening chest pain, and that was the ECG. First ECG was absolutely normal. Mind you, she doesn't have any risk factors, 39-year-old. So after seeing it's top I was in thousands, 4,000 to be specific. And then we decided we will do angiogram. As the angiogram you see. Proximal LED block, mild disease in circumflex. Also in other the guiding chart you can see that diagonal origin also is the disease there. The long segment disease extending beyond the diagonal in the mid part of the LED. You can see it very clearly. Syntax score is 18. You have 38. Question was PCI versus CABG. Of course, PCI and precision being part. Question was whether to stain the ostial LED or left main LED, because angiographically, if you see ostium of the LED, is small area which is free from disease. Angiographically, I will show you the view, just show the next slide. And of course, diagonal whether to intervene or not, provisional or planned, I'll go ahead and show it. That is the, you see this picture, ostium of the LED looks very small area free from disease. You can find the stain there. So no need to stain. That's what angiographically we felt. There is no need to stain the left main. You can probably stain the proximal part of the LED to the mid LED beyond the diagonal. Next. This is the other view. This view you can see that LED diagonal ostium is fixed. So anyway, we decided to do a OCT. Sorry, the picture was very clear. Somehow it's not clear here, but I'll just focus on ostium. Just show the fixed image. Yeah, that is the ostium of the LED. You see there's a plaque rupture there, which is in OCT very clearly seen, and that's clearly appreciated in the ostium of the LED. And after seeing this, we decided to stent it from left main across the LED and diagonal. The diagonal, the D1 origin had mild disease that was seen in OCT, not significant disease. Anyway, we protected the diagonal, and initially dilated and put a stent 2.75 by 23 stent from in the middle part of the LED. Keep the stent, proximal part of the stent, beyond the diagonal so that the other stent, when you're putting it, doesn't both it doesn't cross near the diagonal. And go ahead. Just go ahead. After putting the stent, there is pinching in the diagonal, you can see it. So we decided that we will dilate. We dilated with a 2 millimeter balloon. And then we used a 3.523 stent again. And both stents are interposed little proximal beyond this, the diagonal origin part is avoided. And then just the left main to LED stent. And we dilated the proximal part of the stent, 4.5 balloon. That is the angiographic result. Next. Just to see the angiographic result, it looks very good. And we covered left main to LED, and that diagonal origin also is spared flow is good. And after this, that is it. And we did the OCT also, it shows well opposed stent. Diagonal origin is flow is very good, and stent was very well opposed, and there's no compromise. This highlights next the importance of imaging. Especially in this case, we could find out that the cause of this unstable symptoms, acute coronary syndrome, was because of the plaque rupture. Stent strategy here, we were not sure whether to stent the only LED or stent the whole left main to LED. OCT gave us clear direction that ostium of the LED is affected, so better to stent from left main to LED. Diagonal origin of VSS, and we realized that it's not much disease there, so we just ballooned it because of the plug set, there's some pinching, only balloon, it opened up, and we also did the OCT after that to see that stent optimization came, we did it of course. So in this case, the most important thing we got it by OCT is that where to put the stent. That is what we got. And that's open for discussion now.
Thank you very much, Dr. Rath. I think it's an excellent presentation and a demonstration of a very complex case actually here, and how OCT has helped you really. Thank you.
I think, sorry sir, I just joined because I had presentation in another hall. Hope both live in case box presentations went well. Now we move on to other sessions. Any other questions or comments in the previous session? Dr. Ramesh sir? Thanks for coming early to join us, sir.
Thank you. Thank you very much, Dr. Srinivas Kumar. Very nice to see you.
Yeah. Always there to help us. So now I think we go. Any other questions or comments in the previous things we can ask once the other panelists, then we can go on to the next session. There are no further questions. I think we'll move on to another important session of STEMI ACS, which is happening. And I request next session chairpersons also to join. Arun, are they there already inside logged in?
Sir?
Yeah, Harshit, tell.
Help you with the next session.
I see Dr. Aditya Kapoor, Dr. Thomas Alexander, Harish Mehta, and Dr. Brian Pinto has also joined. Thank you very much for all your support. And just to mention that our yesterday's things also went very well. The day one, about 1,000 plus delegates have logged in, and Antonio Colombo's session evoked a lot of discussions. And we have presented a brief video also. I think, I don't know whether you people could see it or not. We will again circulate it. I think with this yesterday's news, I think very thankful to Dr. Aditya Kapoor who helped in making the program and many other aspects too. Whenever we ask for anything, they are always ready. Thank you, sir. And I see Dr. Thomas Alexander again joining. He's an expert in this field of ACS and STEMI. He runs the STEMI India program. I thought he would be the optimal ideal person to chair this session. And I think Dr. Rakesh also will be joining. And we will... Over to you, Dr. Thomas, sir. After your few comments, by then Ramesh will join. We can have his lecture.
Thanks, Srinivasan. It's great to be here, and I think with all of us stuck in different parts of the country, I think it's great that we can interact with each other. Ramesh, nice to see you too. I think STEMI is an area that is rapidly changing its character in the last few months. And I think the way that we approach the management of STEMI, instead of taking them straight to the cath lab, what are the other options? How do we manage them in the lab and after they come out of the lab? I think these are huge issues that are confronting us. And maybe at the end of this, we will have some discussion on how do we manage STEMI in the COVID era. So without taking too much time of that, let me introduce Ramesh. Ramesh, I think requires no introduction at all. Ramesh is going to talk to us on the eternal question that we have. Do we do just the culprit, or do we do the culprit plus every other significant lesion in a patient with STEMI? And if we decide to do a multivessel angioplasty, is it going to be staged or during the index event? Ramesh, over to you.
Thank you very much, Thomas and Dr. Srinivas Kumar, Dr. Aditya Kumar, and really very nice to see all of you at the TCT India South Asia 2020 virtual, and really appreciate the opportunity given to me. And I'm going to share my screen now. So I hope you can see my screen. And I think Dr. Srinivas Kumar has asked me to give this talk, which I also gave in last year at TCT India, as this is come with some new information now, and we'll add that. So I think I hear some interference.
Yeah.
Please.
Could I request everyone to mute their microphone, except, of course, Ramesh.
Thank you. So the culprit versus multivessel intervention during STEMI, whether we should treat them all or not. And interventions are usually incomplete and ischemia may still persist. That is our problem that we have. And we are always trying to see how best is to treat these patients. And so about 40 to 75% of the patients have multivessel disease in STEMI. And in fact, actually, while I was doing chairing the live session half an hour ago, I received a call from my other outlying hospital to transfer a patient with an inferior wall STEMI, where the interventional cardiologist did a balloon to the right coronary artery, and but the patient has multivessel disease, and TIMI-3 flow was established to the right coronary artery, and to transfer the patient for further care to our center, whether to do multivessel PCI or actually consider bypass surgery. And so they do have worse clinical outcomes. And when should you intervene? This is really the most important question. I think we'll touch base and maybe have a panel discussion on that. Is it based on data, and how do you decide? So multivessel disease, we see that the 1 year mortality in people who have triple vessel disease is 7.8% versus a person who has single vessel disease is only 3.2%. So this is really a big difference of absolute mortality of 4% higher in people with the triple vessel disease, and as compared to a single vessel disease. And as you see, the double vessel disease falls somewhere in between, and from the Cadillac clinical trial. And we have a lot of data as well from Manish Patel from Duke, and with non-IRA disease and versus without non-infarct-related artery disease in about a huge patient registry of about 27,000 patients, that there is increased mortality in people who have multivessel disease. So as I mentioned, how should we do it? There's a heterogeneity of patients. Not all patients are equal. Not all vessel lesions are equal. Complexity of patients differ. So I wanted to ask you, how often do you fix a non-culprit vessel? I think this is where if you take a poll, it would be exactly 20% from each other. And you can see that there will be some people will say never, and some people might say always, and all the others will fall into that. So what are the strategies towards non-infarct related arteries? Currently, we have just be conservative medical therapy, do the infarct-related artery and send the patient home, bring the patient back for a stress test or some sort of ischemia-driven revascularization. The intermediate is non-infarct-related artery, which is staged. That could be whether at same hospitalization or at a different hospitalization, a different visit, that is still considered as staged. And aggressive is actually performing all multivessel disease PCI acutely. So the benefits are here, the pluses, the complete revascularization, and the aggressive one, no residual ischemia, no additional angiogram of PCI, and it is cost effective actually to think about it. And but the problems could be more contrast radiation, unstable condition, and a thrombogenic milieu, and a potentially unneeded PCI. So that's what you have to think about. On the other hand, if you see conservative medications, proper indication for revascularization, stable condition, and a heart team discussion can be done, which is going to be done in our patient. And the negative points will be significant residual ischemia and more cost and risk, and a non-conclusive ischemic testing. And intermediate would be that where complete revascularization, no residual ischemia, and a stable condition, and a heart team discussion can happen in this patient. And but unfortunately, still have to do repeat coronary angiogram, more cost, and potentially unneeded PCI. So ideally, aggressive PCI should be based on angio or FFR is always a discussion, and the multivessel disease, in a non-intermediate stage, whether it should also be angio and FFR, whereas conservative is purely based on ischemia and symptom-driven. So comparing angio to PRIME looked at this, and culprit looked at this as well, and we'll also talk about complete in the end. So the problems with the registry data is they're small, mostly single center, historical, and do not reflect contemporary PCI practice, and confounding factors, whether they are how sick they are, and that cardiogenic shock plays a different type of role, and we know with the culprit shock that only culprit vessel PCI is recommended in cardiogenic shock. So, and those patients are all excluded in these studies, and different in treatment strategies and outcomes. So as you see here, this is several randomized clinical trials, and many of them are small number of patients, including the culprit, which people quoted a lot, and 296 patients. And we look at, the NAMI Primalti was about 627 patients. And so should we do it at all? And if so, when should we do it is the question, and how long should we be able to stage it? In the PRIME, definitely it helps that, patients without primary outcome, there are, more worse outcomes are seen with the no preventive PCI, and whereas as well as in culprit as well, complete revascularization, the MACE rates are low. So again, as I said, look at the bottom line, the number of patients are 230 patients in each arm, and in the PRIME, and about 150 in each arm in the culprit trials. So then the meta-analysis came. I'll show you a couple of meta-analysis, and it said that it did say that meta-analysis showed a 41% reduction in MACE, 52% reduction in recurrent MI. All these are relative reductions, and 49% reduction in repeat revascularization, and a trend towards lower cardiovascular mortality with all favoring complete multivessel PCI. The guidelines have been moving, and we don't exactly know where it will fall at the same time. Guidelines are being written now this year, and ACCHA guidelines from Class 3B in 2013, they moved to Class 2B with the level of evidence B in 2015. And whereas ESC, as you know, like Americans are a little bit slower in coming to the guidelines because they want more evidence, and whereas Europeans move much faster. So it went to actually 2AB, and now they also came back to saying in 2014 as a Class 2B recommendations. So this is data that in primary 234 patients in each, and as I showed you that there is a trend towards lower MACE rates in people who underwent multivessel PCI as well. And so it is mainly not driven by refractory angina, but it's mainly driven by non-fatal MIs in these patients. All of these MIs were spontaneous, and the periprocedural MIs at the time of subsequent revascularization procedures were not counted. So what would have happened, similar to ischemia when we talk about it, there are spontaneous MIs that happen, but periprocedural MIs also happen when we do a procedure, and how do those count in these patients is not very clear on what long-term impact do they have when you do non-infarct related arteries in early on in the scenario when it is not really causing any angina or anything. So the stenosis in the people who had multivessel disease, obviously nobody actually makes a big deal when it is a 95 to 99% stenosis. The most problem becomes actually when people have 50 to 74% stenosis or between less than 75% stenosis. So you can see that the event rates are much higher in people who have 99% stenosis, obviously, and also much more than 75% stenosis is the next one, and very low event rates are seen in people with less than 70% stenosis. So I think this is where if you want to fix 50 to 75% lesions, even with FFR, and we can always support ourselves with the FAME2, but I think this is a place where we can try maximal medical therapy first. And how do you select the stenosis tool? I think it is mainly chosen as an angiographic rather than anything else, and we might be upgrading them as angiographic. We want to stent it. We might say it is more than 70%, and some people might actually miss on the other hand, where we might be thinking that they are not significant, and they in fact may be significant. So you have to depend upon some sort of imaging or physiological support to use the multivessel PCI. So in multi-randomized clinical trials, we also look at other diseases. Most of the clinical trials did support, small trials have supported multivessel PCI is better in terms of reduction of non-fatal MIs. So do all non-IRA lesions with more than 50% stenosis need to be treated? And as I mentioned, you can get less residual ischemic burden, and STEMI patients are known to have more vulnerable plaques, as we know. And some group of people might say potentially no, angiographically not accurate in determining ischemia or vulnerable lesions. FFR or image-guided strategies are not yet fully investigated, and different FAME showed that FFR negative lesions, and remember, when both these trials differ, was actually 0.75, and less is left alone. And 0.75 and more were left alone. So you have to think about what value of FFR you want to use. If you want to differ, it is not 0.8. And if it is less than 0.75, go ahead and intervene. If not, you can leave it alone. So post-TME patients also receive DAPT and lipid-lowering therapy as well. So in that said, so let's look at FFR-guided therapies, and FFR was compared with DNAMI-3 and Primalti and compare acute. So in these two studies, and DNAMI-3 Primalti showed benefit for early FFR-guided revascularization in again 600 patients in 300 in each arm. the primary endpoint was all-cause death, non-fatal MI, and ischemic-driven revascularization. So as you can see in the red is complete revascularization, less event rates, about nearly 14% compared to 26% with non-infarct related, no preventive PCI. And so in compare acute as well, we show that MACE event-free survival is much better in FFR-guided complete revascularization in the blue here, 7.8%, whereas in the red color is the infarcted artery treatment only. It actually had more event rates at about 20.5%. So where do you think the guidelines will go? As I said, we are still waiting for ACC, AHA, SKY guidelines, and whereas Europe has moved from class 2A to class 2A with the level of evidence B, that revascularization of non-infarct related arteries should be considered in STEMI patients with multivessel disease before hospital discharge. So at least that they were able to say when to do it before hospital discharge. Then we had on October 10, 2019 at the American Heart Association, we presented complete trial, which we were also one of the centers that we did. It is a huge study looking at about 4,000 patients, and mean age is 61 years of age. And this is a good study to evaluate multivessel PCI in presence of STEMI without cardiogenic shock. And as you can see here, the baseline characteristics, and about 20% of them are diabetics, and the complete revascularization was able to be achieved. 80% were done by transradial. That is very important. As you can see, thrombus aspiration has come down to 24%, being in line with what has been the recent trials total has shown, and the taste has shown as well. And you can look at all the things and the number of disease residual vessels. It was mostly 2-vessel disease as 76% of them, and 3-vessel disease was about only 1/4 of them. So the presence of the disease was mostly in circumflex artery and actually also in LAD. So it is the left system that is much more involved. So what did the trial results show? That actually there is a definitely improvement in cardiovascular death or myocardial infarction in complete revascularization, which is at 7.8% versus 10.5% at the end of a 3-year follow-up. So these results were presented, as I said, at American Heart Association last year. And following this great improvement that complete revascularization shows a long-term benefit, as you can see here. Early on, the difference is very mild, but as we go along over 4 years, there is definitely a great reduction in the primary event rate by complete revascularization. And one of our current fellows has done a meta-analysis, and he has shown, including all the other studies, and including COMPLETE, which is the largest study, that now the multivessel vessel PCI is favored by reducing reinfarctions by about 36%. So I think this is where we are right now. And in summary, it's a multivessel disease presentation in STEMI is a common clinical problem. These are heterogeneous group of patients. Many studies are small, non-randomized and old, but currently with the COMPLETE trial, you can actually say complete revascularization could be done. But as we know, the answer is when to do it is still not so much clear as whether to do it as a stage during the hospitalization or after bringing back as a different visit. So at least in our presentation, we always recommend the patients to be re-intervened before they go home if they have multivessel disease, rather than just bringing him back for a second visit. So, and the timing, as I said, is important. And about FFR, I think please use FFR for your benefit as well as for the patient's benefit if the lesions are borderline. Anything more than 40 and less than 70%, we do FFR in these people. And culprit shock raises major questions about multivessel PCI with shock. So you have to think about how to deal with these group of patients, and they suffer more renal failure as well. The challenges will be actually reimbursement and appropriateness use criteria and also ischemic testing, where some people may not believe the ischemia or FFR in people who have multivessel disease PCI, but this has been studied in small registries and we know that FFR is of value. Thank you very much. I hope I made it crystally clear as it is shown in these slides. I think if you don't know after this talk, I'm sorry. We still have to wait for probably some more evidence with FFR-guided therapies in multivessel PCI. Thank you.
Thank you, Ramesh. I think often the question of culprit-only angioplasty is worded in a way that would you treat the culprit and then treat the rest of the lesions conservatively versus doing a multivessel at any stage. And I think that debate is gone. I think if there are significant lesions, there is definitely evidence to say that you need to treat those lesions. The questions that really arise are, what is the timing? Is it during the index procedure? Is it during the index hospitalization? Or is it during a period of time? Now, if you look at the complete data, the curves actually diverge after 30 days. So you have a window actually up to 30 days to decide when you will do this. The question that you again raised of FFR or using QFR in these patients to decide what to do. I think FFR during the index procedure again is a challenge to do. I think many of these patients are hemodynamically unstable at that time. To do an FFR study may be difficult. So I think again, if you were to decide on FFR, it is to bring the patient back. The data is very clear as to when, the ESC guidelines are very clear. They say during the index hospitalization. So it's clearly not, often not during the index procedure, though there is certainly a cost benefit. And in a country like ours, where there are cost constraints, we might decide to do it during the index procedure. I think there is also, Ramesh, you're going to say something. Ramesh, you need to unmute yourself. You're not hearing.
Yeah, sorry. In the United States, actually, the only reason they're brought back on a different visit is we get paid second time. So if you do it in the same visit, only the professional component is paid and not the hospitalizations.
Yeah, so I realized that the guidelines, the US guidelines were written specifically for this. It was much later that I realized that the initial US guidelines were purely because of the reimbursement. And it's the reverse when we look at our population here. And sometimes, especially some of our comprehensive insurance patients who come from government health insurance scheme, they have a fixed amount that is reimbursable, and to come for a second procedure is often difficult. So we might even push our luck a little bit in somebody who's unstable and try to complete the procedure. But I think with the complete trial, I think we are now much closer to making a decision on revascularization and when to do this revascularization. So let me ask for comments from anybody. Please unmute and join in the discussion.
I see Dr. Ashok Seth sir also joined now, and welcome, sir. Thanks for joining us. Thanks for your service. As Dr. Thomas sir said in Ramesh, we actually would like to finish everything in the same admission, because hospitals would charge patient if they come for second time for the different. Again, it will be burdensome for patient. We think the reverse in our country. That's what Thomas sir was mentioning. So we would bill it as one procedure. And though we stage it, still patient is charged for only 2 vessel PTCA like. That is our strategy. Anyway,
I think which is appropriate.
Yeah.
Which is
appropriate. Obviously, if it is appropriate, there is no question of not doing it if it is not appropriate.
Right.
Go ahead.
I think many of the recommendations, I think it's really something that is geography specific. Some of the signs may not be very much different, but I think some of the recommendations could be geography specific.
That's true.
Are there any other comments from anybody on the panel, any of the chairpersons?
I have a question for you.
Yes.
When you do these vessels, if you do it at the same sitting, there's always a risk of overestimating a lesion because there's a lot of vasospasm happening. So have you found any difference of doing it the same day or waiting for a couple of days? Then you might realize that the lesion is not as bad as it looks, the non-infarct related.
Yes, so we did a registry called Advance with the FFR, and in fact, actually it did not show that there is any, I'm talking about just purely FFR itself. FFR values were reliable in multi-vessel PCI after the primary PCI is performed. The non-infarct related artery FFRs were very reliable. And that has been evaluated actually at that time. And following, we brought the patients back and for the PCI, and we did FFR again. So those values, when they compared, they were same. And so absolutely, you need to give nitro to make sure that there's not much of spasm. And as we know, the cause of slow flow in our non-infarct related arteries is because during the STEMI, there is a thrombogenic milieu, and we do see slow flow. So we have to make sure that the flow is established and there is a good nitro given, and then do the FFR estimation.
Harish, if I can just add to what he said, I have a very dramatic case of doing a right in a lady. Finished that, the LAD diagonal had such a critical lesion. The patient was unstable, so I brought her back after 3 days for bifurcations, stenting. I found there absolutely no lesion.
Correct.
So I think we all have cases like this.
I would urge, I just want to add one thing, and that's very important to understand. Doing other lesions at the same sitting, they have, we know that there's generalized vasospasm. Quite often at times where another interventional cardiologist has made a decision to do a second lesion later on, it often happens that when you see that angiogram, you don't think it's significant, you do a nuclear testing at 6 weeks' time, there is no ischemia, and that patient would have undergone a multi-vessel PCI in that index hospital admission, which would have been unnecessary. So FFR is not easy to perform, I must say, during PCI, but staged PCI within the 30 days with a prior exercise nuclear scan for not just borderline lesions, for what may look like a significant lesion in the other vessel, is also guideline directed, because you may find that there is no ischemia on exercise testing in another lesion.
I think we'll move on, sir. A lot of discussion can happen because we deal with common these conditions. We have to also catch up with them. I'm happy to share with all of you now, after the initial inertia of our Indian cardiology colleagues, we have now 1,000 plus logins now to hear from all of us. I think it's very heartening to note that there is more interest coming up in such meetings too. I think we'll go to next talk, sir. I think Thomas Alexander, sir, we can invite Aditya.
Aditya, let me invite you to this, the next talk. I think this is going to be something that's very interesting. I think most of us are now just getting onto the upslope or peak of COVID patients now. And though many of us have not treated many COVID patients in the cath lab, I think this would be something for us to listen to, because sooner or later we're going to run into these issues. Aditya.
Thank you, sir. So I'll just share my screen. Am I audible?
Yes, yes.
Yeah, you're audible. Can I request everybody else to mute their microphones, please?
So at the outset, thank you, Srinivas. Thank you, Dr. Thomas Alexander, sir. So my brief in the next 15 odd minutes is to cover variable cardiology presentations in the current times. So due to brevity of time, I'll focus on 2 or 3 things: acute ST elevation MI, ACS and its mimics, decompensated heart failure, and sometimes arrhythmias can also present in these COVID patients. So first case, just hypothetical cases: hypertension, diabetes, dyslipidemia. Patient had chest pressure for 2 days, no conventional risk factors for COVID: cough, fever, chills, no recent travel or sick contacts. Patient's troponin was high and the COVID was positive. Now this was the ECG at presentation, shows ST elevation in the precordial leads. X-ray showed an infiltrate, and the echo shows, these are still frames, concentric hypertrophy. There was some apical hypokinesia. And this is not a uncommon thing for us who have seen such patients in the COVID times. The coronary arteries showed no significant obstruction. The second case, non-ischemic cardiomyopathy, known case of ejection fraction was around 35%, hypertensive diabetic, no history of travel or contacts, symptomatic for 2 days, saturation were 88%, troponin was high, COVID positive, X-ray again showed those classical infiltrates. ECG showed a sinus tachycardia where there is a borderline QT and some STT depressions in the lateral leads. Patient in the ICU had a QT dependent TDP, was shocked, ultimately revived. Early intubation, a bedside PA line was put. So decompensated heart failure can also get aggravated in these times. And of course, we all know arrhythmias can present in these patients. So patient who had rapid atrial fibrillation. Another patient, interestingly, again COVID positive, borderline renal functions, troponin was high. And if you see the ECG in the bottom panel, shows a high-grade AV block. Another patient, high troponin, saturation was fine, bad LV, hypertensive diabetic, so comorbidities were there. ECG on presentation shows a sinus tachycardia with an aberrancy, rapid hemodynamic deterioration with pulseless electrical activity. So the idea of showing these cases is that often we'll have such cases, as Sir rightly said, in the current times, in the times to come. And in patients presenting with what appear to be classical cardiac symptoms, underlying COVID always has to be kept in the differential diagnosis, even in the absence of classical symptoms like fever or cough. All such cardiac patients who come to the ED need screening for COVID, especially for the safety of the healthcare workers to prevent inadvertent exposure. So I think most hospitals now have this system in place, a triage where you receive all patients who come to the hospital, a classical holding area where the patient is taken up while the COVID report is awaited, a destination facility where he is transferred once the COVID negativity is confirmed, and a dedicated COVID facility where he can be transferred if the patient turns out to be COVID positive. So what we follow, and I'm sure most of the institutions would be following, is a screening strategy in the triage area based on history, symptoms of breathlessness, cough, fever, etc. And based on these, the exposure risk can be categorized as low risk, or if the patient has got above symptoms, he is on oxygen, there is abnormal X-ray if it is available, he is classically characterized as a high risk. But notwithstanding all these historical factors, again at the cost of repetition, we all know this, due to the significant overlap of cardiac symptoms with COVID presentation and with current times of possible community spread, history of contact, travel, fever, cough may not be very discerning. So practically speaking, what should be the best screening strategy for all these myriad cardiac presentations in the current time? As I said, ideally all patients who are being considered for admission to cardiology units need to be lab tested for COVID before proceeding for a definitive admission or therapy. The advantage of such an approach is, of course, to avoid a retrospective diagnosis of a positive COVID once a patient is admitted to the general institution, so that inadvertent exposure to healthcare workers is avoided. Till a few weeks back, when the TrueNAT was not available, logistics often precluded a rapid turnaround time because the RT-PCR test was only available after about 12 to 24 hours. But now with the TrueNAT, we have a 2 to 3 hour turnaround time so that rapid triaging is possible. And once this triaging has been done, briefly to describe when to intervene in a case of acute coronary syndrome, I think I have more learned experts than me who are in the panel, and this can be discussed subsequently. So it is obviously individualized and needs to be balanced between the risk of exposure to doctors and healthcare workers to COVID, overutilization of PPE, and the perceived urgency of the procedure. So it has to be a joint decision between the patient, his relatives, and the healthcare teams. By and large, for ST elevation MI, still, we all know, recent guidelines also reiterate that PCI remains the gold standard, but taking such patients for PCI obviously means that stringent precautions, PPE cover, etc. needs to be adhered to. So that might interfere with time constraints, if they are there, in stable patients with STEMI, one can send the COVID test and perform fibrinolysis in the isolation area if PCI is not being considered, and transfer to the further facilities, either the dedicated COVID facility or the destination ward once the report is available. In stable patients who are more than 12 hours, I think my personal belief would be that obviously thrombolysis should not be considered. It is always better to consider a PCI in such patients and await the result of the COVID test before actively considering PCI in these stable patients beyond the thrombolysis window. In unstable patients with STEMI, hemodynamic compromise, ongoing ischemia, if proceeding to the cath lab is considered very, very urgent, obviously it should be done under full PPE cover. For non-STEMI, again, important carry-home message that troponin leaks are fairly common in COVID patients. They reflect type 2 myocardial injury. So don't over-rely too much on troponins. Go by the clinical picture. Even the ESC latest guidelines say that troponin leaks, BNP rise can occur. Level of these biomarkers correlate with COVID disease severity and mortality. Levels of these biomarkers should always be interpreted as a quantitative value, not as a binary value of positivity or negativity. And in the absence of typical chest pain or ischemic changes, elevations up to 3 times upper limit of normal do not require downstream activation of your cath lab systems. So that is a very, very important thing in these non-STEMI-like patients who have got a troponin or a biomarker leak. In stable non-STEMI patients, initially a conservative treatment, anti-ischemic treatment can be done till further decisions are made based on the COVID report. In unstable non-STEMI patients where the instability is thought to be due to ongoing ischemia, if proceeding to the cath lab is decidedly urgent, what we do, and I'm sure everybody does, is send the COVID report, test, and the procedure can be done under full PPE cover so that the patient is given the benefit of an intervention if it is required. Cath lab rules, basically about 7 or 8 important carry-home messages. This is, I think Dr. Thomas Alexander also had this document. It was released about 2 months ago. If the patient is to undergo an urgent procedure, COVID report is still awaited. There is no clarity about the COVID. Again, full precautions, PPE cover, there is no question about it. Patients who are severely compromised from the respiratory point of view, ARDS-like picture, they should preferably be intubated prior to arrival in the cath lab because intubation is an aerosol generating procedure. Avoid, as far as possible, intubation in the cath lab. Defer all non-urgent procedures to reduce the load on the healthcare resources, use of PPE, etc. Goes without saying that all your cath lab members, cardiology team members, including paramedical staff, should be absolutely familiarized with current protocols of donning and doffing of the PPE. This is very, very critical. Fragmenting the staff into teams so that you minimize the number of scrubbed operators is very, very essential. And of course, develop specific institutional protocols for vigorous cleaning of the lab once the procedure is done. A brief word about disinfecting the lab, because often we as cardiologists are not very particular about how to do it. Again, these guidelines are there. Either UV light, lipid solvents, they can be used, but they do inactivate the COVID organism, but chlorhexidine is by and large ineffective. So we use hydrogen peroxide spray, misting or fogging, and instruments can be cleaned with hypochlorite, and the floors and the walls can be cleaned with chlorinated disinfectant with or without hydrogen peroxide spray. So to conclude, this acute COVID-19 cardiovascular syndrome, this has been labeled as the acute COVID-19 cardiovascular syndrome. It can have a multi-spectrum presentation, acute ACS-like picture, which can be obstructive or non-obstructive coronary artery disease. It can present with arrhythmias. It can present with decompensated heart failure. Pericardial effusion tamponade, myocarditis has also been reported. And of course, we all know thromboembolic complications are of course common in these patients. So all these spectrum of cardiovascular conditions can be encountered in a COVID patient. The emergency triage for ACS would of course be based on the symptomatology. If it's a high risk, based on breathlessness, cough, fever, hypoxia, etc., strong clinical suspicion, shifted to the dedicated COVID facility. 12-lead ECG in the emergency. If it's a frank ST elevation MI or a non-STEMI, the patient can be shifted to the isolation or the holding area pending the COVID test report. And if PCI is considered in STEMI patients, again, stringent precautions regarding PP and other precautions which I elaborated upon. Fibrinolysin can be considered in patients in whom delayed and anticipated in the PCI. For non-STEMI, remember, don't treat the troponin. You can manage initially conservatively. If it's an ongoing ischemia with hemodynamic compromise, the patient goes to the lab, of course, with all these precautions. And once the COVID test comes, the patient can be shifted to the dedicated COVID facility or to the destination ward. So the message is, biomarker release, we should understand, we all know it can be frequently seen, and COVID has taught us that troponin is perhaps not very cardiac specific now. It is disease specific. It is a marker of adverse events in COVID. Elevated levels remain stable in COVID survivors, while in non-survivors we have seen in our COVID facility, there is a gradual and progressive increase. So even in the COVID patients, monitoring the troponin is not a bad idea. It gives you an idea about how the patient is going to do in the long run. It's a continuous inflammatory surge, and progressively rising troponin indicate a bad prognosis. But again, if we get a cardiology referral for such a patient, we should always understand that elevated levels are perhaps not due to the ACS, but due to a direct inflammatory injury of the COVID organism on the myocardium. So it should not generate downstream activation of the cath lab in all cases, as I discussed. For imaging, do not perform routine imaging in patients with suspected or confirmed COVID-19 until and unless it is mandatory. So only, now it is clearly decided that point of care cardiac ultrasound or a focused cardiac ultrasound should be done as short as possible. Transesophageal imaging by and large should be avoided. While PCI is still the best, fibrinolysis may be an optimal strategy with least resource implications in the current scenario. But of course, I think I had a discussion with Dr. Alexander also some time ago, and primary PCI, if possible, should always be done with all precautions. Poor candidates for fibrinolysis include a delay presentation, larger infarcts, or ongoing hemodynamic or electrical instability. These guys should always be given the benefit of an angioplasty if possible. In the current scenario, initially, there was some impression that PCI may be done to the culprit vessel. But now, I think Dr. Ramesh also elaborated upon, maybe to keep the procedure time, we don't want the patient back in the cath lab again and again. So judging on the clinical scenario on the individual case, maybe you would want to complete the procedure in one single setting. That remains to be discussed. When possible, bedside procedures like IABP, pericardiocentesis, TPI, they should always be done bedside rather than shifting the patient to the cath lab. Regarding a brief word about antiplatelets, there was some initial data that since the coagulation parameters are deranged, the antivirals, they could increase the serum concentration of ticagrelor. They could interfere with clopidogrel, although there was not much data with prasugrel. Now there is substantial data to believe the remdesivir and the other drugs which are used, they do not interfere with the antiplatelets. In fact, ticagrelor has some ENT1 inhibition, and it is said that maybe it could be helpful in patients who are having COVID pneumonia. By and large, what the guidelines say that those who are on dual antiplatelet therapy and at least more than 3 to 6 months after the PCI, perhaps getting rid of aspirin and maintaining a monotherapy may be a good idea. If on statins and ACE-ARBs, this has to be continued. There is no fear in continuing ACE-ARB. And if you are considering hydroxychloroquine or azithromycin, keep an eye on the QT. Cautious use of antiarrhythmic drugs, especially if you want to do rate control like for atrial fibrillation, etc. So to conclude, careful patient selection for urgent and emergent procedures again needs to be very, very carefully considered in all cases.
we might want to reschedule or defer all non-urgent elective procedures so that resource containment for the acute cases which need more attention is always important at this particular time. Staffing modifications and try to keep the exposure as low as possible to keep all personnel as safe as possible is the need of the hour. Thank you for your attention.
Thank you, Aditya. I think that was a very extensive overview of how to approach ACS patients during this COVID epidemic. Let me just one point, maybe of some use to people who are managing these patients. In terms of STEMI, our policy, we still do about 50 to 60 primaries a month in our hospital, which is about 30% less than our usual numbers, which is about 80 to 90. What our standard procedure is there's an unequivocal ST elevation in the emergency room. We do a screening CT, and we have a CT machine in our emergency room. So we run it through there, and if the CORAD score is less than 2 or less, we take a swab and shift the patient to the cath lab straight. If the CORAD score is 3 or more, then we would consider thrombolysis as a first option in these patients. This is for definite ST elevation, not for the non-STEMI, STEMI sort of population. So maybe comments from everyone. Comments from people as to how they're managing their patients, because I think all of us will learn something from each of these experiences. Rajiv? Yeah, go ahead.
I think CT scan plays a very important role in triage, especially since we don't have the immediate result of the CT. Yeah. So CT scan test, that's what we do when we take them up for a primary angioplasty. We first do a CT scan of the chest, and if we find that the CT scan is not that bad, then we take him up for an angioplasty. Otherwise, he goes for thrombolysis.
Yeah, I think this is a reasonable quick test while your other tests come through, and a CORAD of 2 or less. I think that Aditya said about you take your precautions, obviously, but at least there is a certain amount of comfort. Any other comments from?
Sir, I request you to proceed, sir, because we have other sessions coming up. Like Greg Stone, Ajay will join again. We have important.
Thanks, Srinivasan. Maybe let me now invite Dr. Ashok Seth for the next talk. I think this is an area that, again, is so important of support systems in managing patients with STEMI. Ashok.
Yeah, just a moment. I'll just get to the share screen, what's up, and just a moment. Yeah. Let me just share the screen. So can you see my screen now? Let me just unmute myself.
Yeah.
Oops.
We can see it, sir.
We can see our screen. But yeah, go ahead.
You can see my screen, but you won't be able to hear me. I've got to unmute myself. Have I unmuted myself?
Yeah, we can hear you, Ashok.
Okay. Sure, I will go. I was just being sure that you've unmuted. So I'm going to talk about the mechanical failure or cardiogenic shock. Could be a mechanism or a diversity between hyperperfusion and congestion. You have a warm and dry patient, you have a warm and wet patient, but you have also cold and dry and cold and wet patient. And that, of course, is the two important aspects, and a spectrum varies in between these. There's pulmonary congestion, there's vascular edema, there's JVP increase. On the other hand, you can actually have oliguria, cold, sweaty extremities, mental confusion, dizziness, and of course, is the cold and wet patients which are actually have the worst sort of prognosis. We want to understand that these are the patients who have systolic blood pressures less than 90, either for a period of 30 minutes or being maintained on inotropes, just about staying at 90. They have oliguria of less than 30 ml per hour of urine output, They have rising lactates gradually going up to greater than 2. They have a cardiac index of less than 2.2. And these are the patients who have the worst outcomes. 80% of them would die without any mechanical circulatory support, and that's where we want to make a difference. So when you understand that, we will understand the fact that we have 4 types of mechanical circulatory supports available to us. Intra-aortic balloon pump has been time tested and available to all of us. There's, of course, the impeller, there's tandem heart from the left atria to the systemic circulation via going across the interatrial septa, and there's the ECMO. Now we want to understand that short-term, these are all short-term mechanical circulatory supports. We have to understand that these are to be used in patients where we start believing that otherwise their survival would only be 20% or they have a high mortality greater than 80%. But also it is a bridge to recovery. These patients should be such that they should be able to recover. These are temporary mechanical circulatory supports, and they either recover their heart function over a period of time or have an illness which recovers over a period of time, or you know that there would be a bridge to either VAD or transplantation. So we have to keep that in mind when we institute mechanical circulatory support. You don't want to be a dead end without inability to withdraw mechanical circulatory support because there are no other options left. Now, I won't go over the physiological changes which happen with these mechanical circulatory support devices, but just to point out importantly that intra-aortic balloon pump does increase coronary perfusion and increases cardiac output by a small amount of 0.5 liters per minute. Now, it has other advantages to the heart. It decreases afterload. We well realize that decreases myocardial oxygen consumption. When we come to impeller, of course, we are decreasing LV wall stress, we're decreasing LV work, we're increasing cardiac power output, we're decreasing myocardial oxygen consumption, and we can get up to 3.5 with the impeller CP and up to 5 liters of support with the impeller 5. Now, when we consider tandem heart and ECMO, we've got to understand that in tandem heart, we've actually taken the blood from the left atria from going across the interatrial septum, from the venous side going across interatrial septum and taken from the left atrium, and then pushing it into the into the aorta. We actually do both in ECMO, where it's venous going to the arterial system, and in tandem heart. We do actually increase the afterload. We also increase the left ventricular wall strength and the left ventricular wall work because we're beating against the heart. We're pushing blood against the heart into the systemic circulation. So we increase myocardial oxygen consumption, but we can support the body to a great extent with actually up to 6 liters of flow. So if you compare all these mechanical circulatory support, what comes to light and understanding is of the user-friendly devices which provide the best form of hemodynamics and also benefits to the heart, of course, becomes an impeller, which is easy, bridge to recovery, shorter learning curve, not too difficult to implant, is a 13 French or a 14 French device, has fast implantation and explantation times, and does not cause hemolysis. The only downside of impeller at the moment is that it is expensive, at least in India. And this, of course, reflects the various flow rates that we can actually get with mechanical circulatory support devices. And of course, you see that the impeller can provide up to 5 liters of flow. And of course, VA ECMO can actually support the... So when we get to the severe shock or cardiac arrest without any heart function, we actually need biventricular support. VA ECMO seems to be the best option. Otherwise, iBiomed impeller is the one to go for both protected PCI and in cardiogenic shock due to reversible cardiac situations. We have a number of there are a number of studies which have evaluated mechanical circulatory support in these settings. I won't go through every one, but just to make you understand that IABP Shock 2 study was unfortunately a study which relegated IABP to a level 3 in the guidelines because it did not show any benefits of IABP versus conventional therapy, which is no IABP, in patients undergoing primary PCI in cardiogenic shock. But we have to understand that while it showed no differences, IABP showed no differences, and that's why it became a class 3 indication and it's not routinely recommended in IBP shock. There are other studies which tell you that if you institute IBP early, you can improve long-term survival. And if you actually institute it prior to PCI and cardiogenic shocks, you do improve survival. And there's not just one. There are multiple small data, both randomized and non-registry data, telling you that. And unfortunately, in IBP shock, 83% of the patients received IBP post-PCI, not pre-PCI. And there was a 10% crossover to IBP during this point. So we've got to understand that IBP is available to all of us. We have experience with IBP. We can't relegate it to class 3. It's still a very useful tool in our practice, but it should be upfront and not after after doing a PCI and cardiogenic shock. So it brings me to Impella. By this time, everybody knows how Impella works. Of course, it sucks out blood from the left ventricular cavity and pushes it into the aorta. Simple submersible water pump principle. And of course, we do a lot of protected PCIs with Impella in the present circumstances. But because we're talking about cardiogenic shock, let's concentrate on that. This is a conundrum. It's a spiral which takes a patient down with, as shock sets in, there's end organ hypoperfusion. That also leads to poor coronary perfusion, there's ischemia, there's hypotension, there's further end organ damage, there's lactic acidosis, which further depresses the myocardium. And with all that, the spiral of cardiogenic shock takes a patient down and downwards. And all we need to do is break the spiral much early on, from the very early signs when we see the lactates rising, when we start seeing the signs of hypoperfusion. And that's when we institute the support devices, we actually stop this downward spiral. So it's clearly been seen, again, for the same reasons, that early institution of support devices does help to prevent the spiral going down. And if I take you again back to the studies which were done on this, it will actually demonstrate the very fact, sorry, I'm going backwards, that in all these data, including the Detroit Cardiogenic Shock Initiative and the CSI registry, which is going on in the United States, which decreased cardiogenic, which improved the survival in cardiogenic shock to up to 75%. Mind you, it's a registry, it's not a randomized data. What has actually been seen is early institute of mechanical cardiac support at the right time in these patients. Otherwise, they go down to a state where they cannot be brought back from and have a high mortality. So coming to that, of course, we understand the Impella increases cardiac power output. This is the new indicator for cardiac index. It's the cardiac power output. And of course, on the other hand, decreases left ventricular end diastolic pressure and volume, and therefore increases oxygen supply and decreases oxygen demand. I won't go through the types of Impella, but CP is the commonly used percutaneous Impella, which gives us 3.5 liters of flow per minute. Now, Impella 5 is one used by the surgeons and is not percutaneous, it's through a cut down. And of course, Impella is a percutaneous right-sided Impella, and it's been found, by the way, got approved very recently for pulmonary embolism and shock related to pulmonary embolism, and therefore as a support device in this COVID situation. Interestingly, I have to reminisce about this aspect of mechanical cardiocirculatory support. We were the first ones in Asia to start using Impella in 2007. And so therefore, I think it's always nice to reminisce about some of the great achievements that one has done from Asia. This was again a patient in cardiogenic shock who was on an intra-aortic balloon pump in Jaipur, who we airlifted. He had been advised bypass surgery many years ago, but had severe triple vessel disease. He was in cardiogenic shock. As you can see here, the aortic pressures were 77. Systolic, his PA pressures were high. We had introduced Impella into the country the previous day, and we actually did this triple vessel revascularization on Impella support. This is April of 2007. We actually then went ahead to do 15 more cases of Impella. This guy actually recovered and went home in 5 days' time. And we were also the first ones to transmit Impella ever to the main arena of the TCT. I think we can tick mark our Indian expertise in this manner, that these were the first ever live transmissions of Impella. TCT main arena and then TCT coronary theater, where we showed some really the cardiogenic shock. This guy was the first patient arrested just prior to the transmission, and we came on by resuscitating that patient. He was in cardiogenic shock, and we transmitted him. And this is what Jeff Moses said, a beautiful demonstration of the most treacherous cases from into the main arena. Anyway, we reintroduced Impella in June of 2008. As you know, it went out of our hands soon after FDA approval. And from 2009 to 18, we did not have Impella. We finally were, thankfully, to Abraham, managed to introduce Impella and actually use it for cardiogenic shock, as is seen in this patient. And we regularly now use it for cardiogenic shock patients, or a cross between protected PCI and the high-risk PCIs and cardiogenic shock. So here's a patient who actually has angina. He's got severe triple vessel disease, but has unstable angina, goes on to cardiogenic shock. Hemodynamically now gets supported by intra-aortic balloon pump and inotrope, maintaining pressures of just around 90. He is therefore transferred to us with an EF of 30% and on IABP for revascularization. He's already had an angiogram at another site and actually shows only surviving vessel. And if you see that vessel, it's not a very healthy situation in an 83-year-old. So if we insert the Impella and just to go through, that's his vessel. That's the only surviving vessel, heavily calcified by tortuosity in 2 different planes, showing you that this actually is very difficult to revascularize. Of course, we take multiple. This was a very difficult revascularization for anyone. It meant that we somehow got a rotor wire across, but nothing else would go across. Obviously, nothing else can go across, not even a 1.5 burr, which actually would get stuck. It took nearly 15 minutes of burring, and then we changed over to rupturing at least 6 balloons into that purposefully to create a small space for the rotational atherectomy to go across. We then burred for another 15 minutes with a 1.5 burr and finally managed to get a 1.5 burr after close to a total of 30 minutes of burring time. As you can just see, it crosses off. And we only could manage that in the last remaining vessel because of the Impella 3.5 support. And this is when it shows that it just goes across. And after that, of course, we go with a 1.75 burr. That was rotablated. We then put in multiple stents, dilated with OP and ultra high pressure balloons, as what you would see here, and we finally restore the vessel and keep the patient alive. So that was the final, as you saw, restoration of a vessel. We finally lost one of the branches, which we got back subsequently, but we finally had a great result. But this was a 4-hour procedure. It was only possible because of Impella. We therefore decided that we needed to create our own risk factor profiling for the patients, especially more for protected PCIs than cardiogenic shock, to be able to use mechanical circulatory support device. So in January of 2010, at the CHIP CTO meeting, which I conduct every year, we had the India Masters Conclave, and we created the India Protected PCI algorithm for the use of Impella as a mechanical circulatory support. This was over a 5-hour period. Most, as you can see, a number of thought leaders from India are here and some from abroad who created this algorithm. And we now actually not just publishing it, we prospectively putting this into analysis in our own practice in India. Well, another mechanical circulatory support device for protected PCIs, maybe I won't talk too much about it, IVAC 2 in the interest of time, which we started using earlier on this year. It's cheaper than Impella, but not as effective, provides 2.5 liters of flow, but can be attached easily to an intra-aortic balloon pump, and therefore it has a simple mechanisms of action. It therefore is able to provide 2.5 liters of support, where there's a pump which sucks out blood and is functioned by the intra-aortic balloon pump, sucks out of the LV, just pushes into the aorta. I think we did this case in January of 2020. Yeah, and here, of course, this is a device. And we did a double vessel revascularization in a 20% ejection fraction patient with safety. I must say, it's not as good as Impella. I think it's a poor man's support device and does a job, but it's not cheap even by any standards of India, and still costs around 8 lakhs of rupees. And this is what we had. Anyway, that was fine. But ECMO, I think ECMO is something that every center, every tertiary center should know how to use in the cath lab, in cardiogenic shock. It's a cardiologist tool, and one should actually have a shock team and an ECMO resuscitation team to be able to institute ECMO within 5 to 10 minutes, 5 minutes to 7 minutes in the cath lab, and 10 to 15 minutes anywhere in the center. We have an ECMO resuscitation team for our center where we can put patients in cardiogenic shock or in the CCU on ECMO at any time, be it ICU or CCU. But for cath lab, we certainly believe our time should be 5 to 7 minutes, and this is how we are able to do it. This 66-year-old lady who was up for a TAVR on for a degenerated bioprosthetic valve, which was very severely stenosed, and she actually had an ejection fraction of around 50%, but the valve had a area of 0.3. You can see that this is a severely stenosed valve. We did a balloon dilatation only with a 16 millimeter balloon when a 23 millimeter valve was going to be, and suddenly after pacing cessation, we felt that the blood pressure would pick up, and we watched it for 20 seconds, 30 seconds, 40 seconds, and the systolic pressure remained at 60, and suddenly she went into ventricular tachycardia and fibrillation. And from there on, it was an incessant ventricular fibrillation. A storm, multiple shocks, nothing would get her out of it. There was no perforation, there was no occlusion. It was related to severe aortic regurgitation. The valve just tore, and she actually not just went into a shock, she went into a VT-VF storm. And that's the sort of patient that we have to actually get out if we are Impella, if we are ECMO, if we have expertise in institution of ECMO. After 15 DC shocks with the storm, once we checked there was no coronary osteal pinching, we actually instituted the ECMO in 5 to 7 minutes within the cath lab. We put the patient on ECMO support straight away. We then, in a still heart, implanted the valve. Occasionally the ECMO malfunction, and you can see it's a still heart. We're unsheathing the valve. We had all these problems. There was all these surgeries done on a spine which were obliterating our visuals, but we finally did here we had to massage it because the ECMO had malfunctioned temporarily, and then we actually got her again, and that's the deployment. And fine, after 30 minutes, there was a return of spontaneous circulation, and then the VT storm started abating. She was on high dose iron. Well, the mean arterial pressures remained low. So 25 minutes of cardiac arrest, the valve started functioning. We then actually saw that, you can see the effect right here, that she has at least no gradient, though she has keeping the mean pressures low. She gradually, her heart was, by this time, was 20%. Severe acidosis, 12 lactic acidosis of 12 lactates, gradually improving over a period of time, pH of 7.1 gradually improved over a period of time. Perfusion of vital organs improved. We had, of course, the next 9 units of blood transfusion, 20 units of FP, which is normal, colloids, and kept the patient alive over the next 48 hours. The stunned heart started recovering, and over the next 48 hours, she recovers, and then a week later, she goes home. And a week later, she goes home absolutely fine and still continues to do fine. What I want to state is that this is a shock team is essential for our tertiary centers. We need to save lives. We can't just sit back and say, we don't know what to do next, and it's only a teamwork. We got to get as good with the multiple inputs of multiple specialists to create the shock team which saves lives. And that's what we actually tend to train people. And of course, the CHIP India CTO meeting it concentrates on these very aspects of hemodynamic support, mechanical circulatory support. And we, of course, hope that we'll either have a virtual or on-site meeting on the 16th, 17th of January 2021 as per the schedule. With that, I must end here, and thank you very much for listening to me, and thank you very much for this invitation to the TCT India 2020.
Thank you, sir. Sure. Dr. Ajay also has already joined and heard you. Thank you, Ajay, for waiting, and Dr. Gregstone is also waiting to join.
I'm sorry for having kept anybody. I try to stick to time. Thank you.
I requested Dr. Brian to finish his presentation briefly. I requested him to show only one case. I agreed for it, and we quickly finish off and then go to the next session. Over to you, Dr. Brian. Can you get Dr. Brian Pinto on the...
Thank you.
Thank you, sir. Thanks, sir.
Yeah, thank you, Srinivas and Ashok. That was a wonderful presentation. All you guys have already educated us quite a lot. So mine's a simple case. but I think it's worth it's worth looking at because it gives us some idea about what's happening in the COVID era. I just want to bring back to you: is imaging necessary in every high-risk case? And are we going to revisit slow flow, no flow a little bit? And this was the aim of this case. Now, we had this patient whose renal function was not adequate. His creatinine was 2.9, and he was in a bit of slow flow right from the beginning. He's a 51-year-old guy. Previously had an angioplasty done. His creatinine was 2.9, as I mentioned, hypertensive and diabetic. And he presented to us with unstable angina. His LV ejection fraction was low. He recently was admitted for a COVID-19, from which he recovered with the standard treatment as well as 2 doses of tocilizumab. And he had gone home. But again, he presented 7 days later after that infection to the ER with complaints of severe angina and breathlessness. So this was his presentation. His angiography from 2014 showed a borderline lesion in the osteoproximal LAD, a circumflex which was 90%, and an OM which had been stented, and there was a plaque in a dominant RCA. So this was his 2014 angiographic report. Some of his biochems, as you can see over here, just mentioned by Aditya, that HS troponin has to be watched very carefully. His troponin was 1762, and he had these resolving changes on his X-ray and on his CT. So we repeated the COVID test, which was negative this time, and this was his EKG. I just mentioned to you that his EF was about 20 to 25%. Now, looking at this EKG and the COVID test and the CT scan, we decided to go in. This was his initial right coronary shoot. Nothing like what Ashok has shown you already, but a simple case. At the same time, a lot of slow flow in this right coronary artery. Also, you can see that he has a stent in the OM. You can see that over there, and I'm presenting one of the shoots from which I used a guide catheter because I wasn't getting a very good shoot into the left coronary system. And so I have a few points for all of you over here. And in the interest of time, I'm not going to put up the questions and make you answer. But these are the various strategies that I thought we should think about. One is, would you use imaging? Would you all do, and this was what Ramesh also alluded to, would you do all the lesions at the same time? What would be your antiplatelet strategy in this situation? Would you approach it femoral or radial? And would you consider CABG as an option in this patient? CABG was something that we put up to him because we looked at his diabetic history. We also looked at triple vessel disease, that the creatinine was high, and he was getting ongoing pain. We discussed this with him and with a surgeon, and we thought that an interventional strategy in his situation was appropriate. I also wanted to put up to you that the hydration was very important in this case. We hydrated him for approximately 6 hours prior to this procedure, realizing that his ejection fraction was low. We kept a watch on that, but we hydrated him. We've been very, very insistent about hydrating our patients whose creatinine levels have been very high. And we have now come to a conclusion that hydration is the most important part. In fact, we've seen many of the creatinine values or the GFRs actually improving with hydration even after an angiography. Now, we did this right coronary on that particular point to the foro vessel, and I don't need to actually get into this. But one of the points which we really do is use a very small balloon initially. That's to prevent the slow flow, no flow. And the other thing that we always do is we use sodium nitroprusside. We give nicorandil and sodium nitroprusside in an adequate dose. And with this, we find that our incidence of slow flow, no flow is extremely low. We also keep norepinephrine ready because in any patient whose blood pressure tends to go low, we use a small dose of epinephrine sometimes, and that gets us back through the intercoronary route. So these are small points that I wanted to make. Also, one of the techniques is to bring up the stent very slowly in situations where you have a kind of slow flow, no flow. And this is important because when you do that, you kind of trap the thrombus into that place and you reduce the chances of this thing. Now we realized that after this shoot that we had a kind of a thrombus or maybe a small dissection over there at the distal edge of the stent, but with a slight bit of giving a little more of this concoction, we were able to establish that the flow was restored and the patient did reasonably well. Now the point was whether to take him up for the another important aspect is we, by and large, if we're coming back, we don't post-dilate our lesions at that point sitting, because we found that in many cases like this, when you start your post-dilatation, you again land up with that slow flow, no reflow. And we'd already planned from the previous angio that we were going to tackle his LAD and circumflex. So this was something that we brought him. We did his creatinine the next day. It had come down to 2.5, from a value of 2.9. This time, we started with the strategy that we would do both these vessels at the same time. You can see a stent which is positioned in his OM at a lower place over there in the OM branch, and so we first. Ready for any other problems, but we didn't need to really get to that. So these are the take-home messages. Is imaging important in all cases? What about ACS in the COVID era and post-COVID era? How would you approach these patients? And I think Aditya has given us some kind of information on that. There's a lot of information that Ashok passed on in terms of support, and I think we have to have that ready. ECMO is what we also have started in our hospital now, and we always have that ready. COVID infections causes lesions to progress rapidly. That's something that we're beginning to see a big number and increase of patients who are coming to us now. We suddenly have had 3-4 patients in the last 2 or 3 days who've come asymptomatic and who've been COVID positive. So we've had to wait on. And the agents of slow flow and no reflow, the magic that they do perform for you, especially if you use them preventively rather than after the thing goes on. Thank you very much for your attention.
Thank you, sir, for staying brief and giving us some time to cover up. Thank you, all the speakers and chairpersons. And I think now we'll go for another. Dr. Ajay, you would like to say a few comments in this session, or we'll go to the next session?
I think we should go to the next session just out of time, but I think there were fantastic talks. The final thing I would just really briefly say, though, is that there's a lot of interest in hemodynamic support, but it's important to apply it to the right patient because there are bleeding complications that are very real that occur from these types of cases. And I think that that's why it's important to use what device the patient needs at the given time. But let's go on.
Thank you. Thank you, everybody. Now, Harshita, can we change over? for this support and ongoing collaboration with TCT CRM. And a lot of interest for this meeting across, not only in India, even in the South Asian countries. We have colleagues joined up from Bangladesh, Myanmar, Sri Lanka, Nepal, many other countries, and we have Shaman joining from Mauritius also. Thanks everybody for joining. Over to you, Dr. Greg and Dr. Ajay for further proceedings.
It's great to be here.
It's wonderful for us to be able to do TCT India again. I know Ajay and I both would much prefer that we were actually there with you. We missed the interchange and the personal discussions and the time spent with all our colleagues, the opportunity to actually interact with people in the audience on a more intimate level. But I think we all have to make accommodations given what's going on in the world right now, and this is certainly the next best thing. So it's great to see so many smiling, happy faces of people that I know, and I hope I'll be able to provide some enlightenment over the next 40 minutes or so. I think I will go into these two talks. So if you want, there can be a few minutes of discussion afterwards. I don't know if we have much time for discussion, but I will share my screen, okay, and go right into the talks. You should be seeing my slides now, is that correct?
Yeah, we are able to see your slides. Make it full screen.
Beautiful. Perfect. So I'm going to start by talking about the ischemia trial, and I'm going to really review the basics, but then go into a little deeper analysis and talk about its clinical relevance and how you may change or not change your practice on the basis of this. It's a very complicated trial. It took us almost 10 years to complete. It was funded by the United States National Institutes of Health, and that's the government. And as a matter of fact, it was the most expensive randomized trial that the government has ever funded. And we do believe that it adds a lot of important information, but it's complicated to understand, so we'll go through some of the basics. So these were my disclosures relevant to the ischemia trial. So I would say that the question of 2020 is that we know that both PCI and bypass surgery relieve symptoms and improve quality of life in patients with stable coronary artery disease. But do they actually prevent death or myocardial infarction? And this was really brought to the front in the COURAGE trial almost 15 years ago now, where they took about 2,200 patients with stable coronary disease, did an angiogram, found the patients that the doctors would randomize, and either did PCI or optimal medical therapy. And they found that over about a 7-year follow-up, there's absolutely no difference whatsoever in death or MI, cardiac death, myocardial infarction, or any other hard endpoints. The patients who underwent PCI did feel better and required less anti-anginal medications, but those effects mostly wore off after 3 years. And I'll remind everybody that this was mostly done in the bare metal stent era. The other big trial that relates to patients with stable coronary artery disease was the BARI-2D trial. And this was patients with diabetes, about 2,400 patients with diabetes, mostly with multivessel disease, were randomized to either ongoing medical therapy versus revascularization. Now, this time it was with PCI or CABG. And they stratified the randomization as to whether or not, if the site's randomized to revascularization, whether it would be done with PCI or with CABG. And if you looked at the overall result of the study, this was a study with first-generation drug-eluting stents or bare metal stents. The overall results of the study was negative. There was no overall difference at 5 years in death, myocardial infarction, stroke, or MACE, almost identical rates. However, if you looked at the bypass surgery stratum, there was at least a reduction in myocardial infarction. And this was due to late non-procedure related myocardial infarction. In the PCI stratum, there was no differences. And the questions arose, well, is that because CABG is better, or because the CABG patients more likely were the more complex patients? They had more multivessel disease, more reduced left ventricular ejection fraction, et cetera. And so they had more opportunity to gain by revascularization. Either way, the bottom line of the trial was negative up top. And so there really wasn't much data that revascularization reduced death or myocardial infarction. But there was some emerging data that PCI might reduce at least late myocardial infarctions. Maybe not procedural MIs, which of course are increased with PCI compared to medical therapy alone, but late MIs might be reduced by PCI. And probably the best study that showed this was the FAME2 study. And looking at the 5-year results, if you remember, those were patients with ischemia-related lesions by FFR that were then randomized to PCI of the ischemia-related lesions versus medical therapy. And here you can see that all myocardial infarctions were borderline reduced, and spontaneous myocardial infarctions were also slightly reduced as well with 5-year follow-up. And you can see these curves really were spreading over time. But this was a secondary subset endpoint. It's a borderline finding. It was a trial that was stopped early for positivity, so it may have been stopped on what's called a random high, and so it wasn't considered to be definitive. So the background trial going into ischemia was that most prior trials, especially Courage and Berry 2D, the two big ones, did not show revascularization in stable CAD prevents death or MI. But there were limitations to these studies, all of them. Patients were enrolled after angiography. So it's very likely that the highest risk anatomical patients were excluded. Not many patients were put into Courage with 90% proximal LAD lesions. Most patients also had only minimal to moderate ischemia. And many studies, over 100,000 patients, have shown that the more ischemia you have, the higher the rates of cardiac death and myocardial infarction. And of course, neither of these trials use contemporary stents, physiologic guidance, bilateral mammaries, pharmacotherapy, optimal pharmacotherapy to get patients through procedures and not have stent thrombosis, et cetera. So we felt that a contemporary trial needed to be done. And this issue of ischemia was very much in our minds. This is data that's been quoted many, many times that's come out of Cedars-Sinai Medical Center, 3,200 patients in clinical practice. This is not a randomized trial. And if you could see, they have an excellent core lab there, and particularly for technetium-99 sestamib SPECT, and they can quantitate the amount of ischemic myocardium. And as you can see, the greater the amount of ischemic myocardium in patients with stable CAD, the higher the cardiac death rates. And this is actually an exponential relationship. In contrast, if they happen to take those same patients, or different patients, but they happen to have patients with those degrees of ischemia that were revascularized, you would see that there was a lower rate of cardiac death and also myocardial infarction. And the greater the baseline ischemia, the greater the benefit of revascularization. And this held up in a multivariable model, very strong. But of course, this is non-randomized data, so it's great hypothesis-generating data. It looked like about 10% ischemic myocardium is where the benefits started to emerge. So with this in mind, we developed the ischemia trial. I was honored to be one of the co-principal investigators of this trial. And we took 8,518 stable patients at approximately 400 hospitals around the world. And patients had, again, be stable CAD, have a moderate or severe ischemia, and by the site estimate initially, although it was ultimately read by a core laboratory. And importantly, these had to be patients that really had relatively mild symptoms. So the operators felt they would be able to tolerate their medical therapy and not have to cross over to revascularization because of unacceptable symptoms. We really wanted to test the hypothesis of whether cardiac death and MI was reduced by keeping patients on medical therapy alone versus revascularization. So we excluded patients with, quote, unacceptable angina despite medical therapy, ACS within 2 months, PCR CABG within a year, heart failure, either symptoms or LVEF less than 35%, and an estimated glomerular filtration rate of less than 30 mLs per minute or dialysis. And these patients were put into a parallel trial called Ischemia CKD. For time, I won't be able to discuss that today. Now, the patients that qualified for the trial, if they didn't have a GFR between 30 and 60, most of those patients underwent a CTA. And the CTA was blinded to the operators and to the patients. The purpose of the CTA was to exclude patients who had left main disease or had normal coronary arteries, at least no obstructive diameter stenosis of 50% or greater. So the idea here was, since we're only taking patients with moderate or severe ischemia, a fair number of those could have had left main disease. We wanted to make sure that those patients weren't being treated with medical therapy alone. So if you actually look, interestingly, of the patients we screened, approximately 13.5% of the patients had either no significant stenosis or left main disease. So it was about, actually, when you look at them on an individual basis, about 10% of the patients actually had left main disease, and about 15% of the patients didn't have a significant epicardial stenosis, despite having moderate or severe ischemia. So those CTs were unblinded, and then the patients were told, you know, do what you want, but this is what the CT shows. The remainder of the patients, 5,179, were then randomized to either an invasive strategy with medical therapy alone, optimal medical therapy, plus catheterization. And then based on the anatomy, either PCI or CABG, whatever would optimally revascularize the patient. The conservative strategy would keep the patient only on optimal therapy and reserve cath for failure. That is either an endpoint event or truly refractory, severe progressive or unstable angina. And the median follow-up was 3.2 years. So importantly, there was no angiogram in the conservatively treated patients. So you didn't have that so-called oculostenotic bias to exclude patients with very, very severe anatomy. And as a result, we included a lot of patients with very complex coronary disease in this trial. So these are the characteristics of the patients. Again, stable CAD, mild symptoms. About a quarter of the patients were women. You can see about 40% had diabetes. So a lot of diabetes consistent with the fact that they had to have moderate to severe ischemia. You can see the ejection fractions were very well preserved, though, about 60%. And while almost all the patients had angina, you could see that by the Seattle Angina Questionnaire, angina frequency score, the mean scores were around 80. And 80 means monthly angina. This is on a scale of 0 to 100. So these patients were having 1 or 2 episodes of angina a month, despite having moderate to severe ischemia. You could see that a full third to 35% of the patients had no angina in the last month. Most of them were just having 1 or 2 episodes a month. Only about 20% of the patients had daily or weekly angina. If you looked at the CCS class, none of the patients were class 3, and only about 4%, none of the patients were class 4, and only about 4% of the patients were class 3. So these were mostly class 1 and 2 patients. So patients could qualify by 5 different stress tests. We recommended strongly that they would have a stress imaging test, such as SPECT or stress echo or PET or MRI, because then you could really quantitate how much ischemia there was. If the patients qualified by only an exercise stress test, they had to have severe ischemia, an early positive test with a marked ST segment depression. And you can see about 3/4 of patients qualified with an imaging test, a quarter by stress test only. The core lab ultimately read that severe ischemia was present in about 54% of the patients, moderate in about 33% of the patients. About 12% of the patients did have mild or no ischemia, though. So they will dilute the trial a little bit, but not bad by site estimates. So by the blinded CTA, you could see that there was a lot of coronary disease. With at least a 50% diameter stenosis, 77% of the patients had multivessel disease, 90% of the patients had LAD involvement, including 50% proximal LAD involvement. And a few left main snuck in, those that didn't have the baseline CTAs. Now, looking at risk factor management in the trial, we really pushed hard to have both groups have excellent optimal medical therapy. In fact, a lot of the drugs were free. But despite that, I would argue that, the medical therapy wasn't so great. So if you look here, the blue is the beginning of the trial, the yellow is at the end of the trial. Looking for our goal LDL of less than 70 milligrams per deciliter. Initially, it was a third of patients. It went up to about 60% of patients. That's despite free statins. Systolic blood pressure being controlled even reasonably, not even the Stitch criteria, which we ultimately adopted, but reasonable control, about 3/4 of patients. We did good with aspirin and smoking cessation, but looking at overall high level of medical therapy optimization was only about 40% of patients, and it was no different between the two different arms. Now, this is an important slide because it shows were the study procedures actually followed out. So in the invasive group, all patients were supposed to undergo cardiac catheterization. And you can see this was done in about 95% of patients within 6 months and about 96% of patients ultimately. In the conservative group, you could see that 28% of patients ultimately crossed over and had angiography. And the reason this was because of a suspected or confirmed endpoint event in 13.8%, truly refractory symptoms in 3.9%. So about 8% of these were so-called protocol violations, crossovers for without great reasons. So not too bad. If you look at the performance of revascularization, we thought about 90% of the invasive group would get revascularized. That's what we planned for. But you could see it was closer to about 80%. If you look at the conservative group, it was about 23% that got revascularized, although many of these were after an endpoint event, about half of them. So I'll just remind you, this was 32% in COURAGE, so we did a little bit better than in COURAGE. And again, most of these were because of a confirmed endpoint event, so it wouldn't really affect the outcomes. Now, if you look at the patients who got revascularized, you might say, well, why were 20% of the invasive group not revascularized? And the reason was about 2/3 did not have significant disease on the coronary angiogram, despite the CT in most cases saying there was significant disease. Now, I suspect some of these patients did have significant disease, and had the operators performed intravascular imaging, they might have found it, or 3-vessel FFR or IFR, they might have found ischemic vessels, but they didn't revascularize these patients. 1/3 of the patients of these 20% had such extensive disease, the operators didn't feel it was suitable for either PCI or CABG. So two kind of diametrically opposed groups. Of the invasive group that did undergo revascularization, about 3/4 were PCI and 1/4 was CABG. So here's the primary outcome of the trial. And the primary outcome was this 5-point endpoint of composite cardiovascular death, MI, hospitalization for unstable angina, heart failure, or resuscitated cardiac arrest. And if you look at the end of the follow-up, total end of the study, there were 352 events with the conservative group, 318 events with the invasive group. The overall hazard ratio was not significantly different. But you'll also note that these curves are crossing. So if you remember, kind of very similar to the Excel trial, initially there's a little bit of harm with the invasive therapy. So you can see at 6 months, there's actually about 2% greater events with the invasive group. But by the time you get to about 4 years, there's actually overall about 2% fewer events with the invasive group. So you can see in that, if you look at the 95% confidence interval, it's right abutting on 0. So it's borderline significant. So overall, somewhat fewer events in the invasive group. So how do you interpret a trial like this? Well, if you are going to have an adverse event, you'd rather have it late rather than early. So you can look at basically event-free survival for the average patient. And this is a statistic called the mean restricted event-free survival time. And if you look at this, you can see the average invasive treated patient tended to be 9.5 days event-free, more so than the conservative patient. But if you look at the 95% confidence interval around that, you can see it's clearly not statistically significant. So no overall difference in the overall event burden between the invasive and the conservative group. Now, if you look at the pre-specified subgroups we found no pre-specified subgroups that really made a major difference. Coronary severity, whether 1, 2, or 3 triple vessel disease, very similar. Proximal versus not proximal LAD disease involvement, very similar. And the degree of baseline ischemia, from no or mild to moderate to severe, really no significant differences. And all these interaction tests were negative. Now, by far the most common event was myocardial infarction. That was about 80% of the events in the trial. And the myocardial infarction rates look very, very similar to the overall event curve. You can see the slight excess early, but you can also see at 4 years a trend towards less difference. So if you parse out myocardial infarction into procedurals versus non-procedurals, you can see that there's a slight excess risk of procedural myocardial infarctions with the invasive group, but then there is a clear reduction in spontaneous or non-procedural myocardial infarctions with the invasive therapy. And this was around a 1/3 reduction. That p-value is less than 0.01, so it's definitely a real finding. And it's not a huge difference. It's about a 2 to 3% absolute difference, but you can also see that the curves are diverging over time. Most of these were spontaneous type 1 events. And if you look at the spontaneous type 1 MIs, those are the kind of spontaneous plaque ruptures, et cetera. Here's the conservative rate over time. And here is the invasive therapy group over time. And here we break it out by those that had PCI versus CABG versus no revascularization. And you can see it was low in all three groups. So it seems like the operators did a pretty good job in choosing which of these three therapies to apply to their patients in terms of at least keeping myocardial infarctions at bay. Now, the cardiovascular death rates were low. You can see, despite the fact that all these patients had moderate to severe ischemia, only about 5% of patients at 5 years had cardiovascular death, no significant differences. Maybe the curves are slightly spreading to favor the invasive group over time, maybe because of those late MIs benefiting the invasive group over time, but don't read much into this. There's really very little difference here. When you look at the other components of the endpoint, there was a slight reduction, very slight, but statistically significant in hospitalization for unstable angina, but there was a slight increase in hospitalization for heart failure with the invasive group. We don't exactly know why this was, but these are about 1% to 1.5% differences, so very small over 5 years. No difference in cardiac arrest or stroke. And finally, if you look at all-cause death, you could see that the all-cause death curves were superimposable with the invasive and conservative approach. So the overall difference is 0.1% and 145 versus 144 deaths. You can be very confident that a medical therapy approach is not causing deaths in these patients. The restricted mean event-free survival time was only 3 days for death. And importantly, we did Bayesian analysis, and the probability that there's even a 10% relative risk reduction in death, which, as you can see, would be about 0.7% at 4 years, is less than 10%. So really almost identical death. So if the death rates are the same, then you could say, well, our two goals of therapy are to prevent death and to make people feel better. So what about quality of life? And our major secondary endpoint was quality of life. And we used the Seattle Angina Questionnaire summary score to first get a big look at quality of life. And you could see that there was a substantial improvement in quality of life at 3 months, at 12 months, at 36 months, and throughout the follow-up of this trial. So this was different than Encourage, where there was an early quality of life benefit with PCI, but it was lost over time. Here it is sustained during long-term follow-up. And this is especially notable because patients had only very mild angina or silent ischemia at baseline. So this was a typical patient in ischemia, and John Spertus, who led this trial, basically said there's a 100% chance that there's an improvement in quality of life at all three time periods if you look at these distributions. Now, of course, the goal of revascularization in terms of quality of life most directly is to make people angina-free. And if we look at the probability of no angina, it depended on, one, what you were randomized to, but it also depended on how much angina there was at baseline. So this is the baseline Seattle Angina Frequency Score. 0 means you're having almost constant angina. 100 means you're having no angina. So you can break it down into daily, weekly, monthly, and none. And the way to interpret these curves, the blue is the conservative arm, and the red is the invasive arm, and the clouds are the confidence intervals. If you had, let's say, angina once a week, okay, then your likelihood of being angina-free at 3 months was about 45%, with the invasive strategy, but only 15% with the conservative strategy. So a difference, an absolute difference of 30% or number needed to treat of around 3 patients to make somebody angina-free. That's a very low number to treat. On the other hand, if you had essentially no angina at baseline, silent ischemia, then both groups had about a 90% chance of being angina-free at 3 months. Notice that some of the asymptomatic patients do develop angina, about 1 in 10, but you don't get rid of angina in every single invasive patient either. So there you didn't really benefit the patients. And the same patterns held at 12 months and 36 months. So we really had a substantial benefit, and this is now with drug-eluting stents, which is why I think these curves are now sustained over 3 years, where they weren't with bare metal stents and Courage. And it's also with bypass surgery in some patients. So with the proper revascularization, even in patients with mild symptoms at baseline, we can really make them feel better over time, and that's a sustained reduction, although we don't have much effect, if any, if they're asymptomatic at baseline, at least within the last 4 weeks before treatment. So there's several important limitations of ischemia. You have to know who this trial doesn't apply to. It was an unblinded trial, but actually the magnitude of the improvement in quality of life was very similar to Orbita. And placebo effects do not usually last a long time. They usually last just a few months. Here we've got durable effects out through 5 years. Importantly, though, this trial does not apply to patients who weren't enrolled. So it doesn't apply to patients with left main disease, who pretty much everyone feels should be revascularized. It doesn't apply to patients with an active ACS or even an ACS within 2 months, highly symptomatic patients in who we know revascularization is going to improve quality of life even more, and heart failure or left ventricular ejection fraction reduction. And we have not yet looked at the impact of completeness of revascularization. If you do a better job revascularizing the patients, are the patients more likely to have a better outcome? We're hoping to present that data at TCT this year in October. So what have we learned from ischemia? That in patients with stable coronary disease and moderate to severe ischemia with preserved LVEF, a routine invasive strategy compared with an initial conservative approach does not reduce mortality. So there's no rush to do the invasive strategy, despite the fact that they have severe ischemia. As long as you know they don't have left main disease, you don't have to rush the patient and admit them emergently to do their cath. But a routine invasive strategy does reduce the occurrence of late MIs, although at the cost of procedural MIs. So like in FAME2, we're now sure about this. But because of those procedural MIs, there was no overall long-term impact on total MI, CV death or MI, or protocol-defined MACE. And then finally, patients with stable coronary disease and moderate to severe ischemia have a significant durable improvement in angina control and quality of life with an invasive strategy if they have angina at baseline. That is, even monthly angina, they're going to feel better by revascularization. But if they are absolutely asymptomatic within the 4 weeks prior to their procedure, it's hard to make somebody who's asymptomatic feel better with revascularization. So you have to let the patients know that. So finally, how should this affect your practice? Well, there was actually, I think, a very good editorial written when we published these results in the New England Journal by Elliot Antman and Eugene Brunwald. And they actually found support for an initial conservative approach. They said that thus provided their strict adherence to guideline-directed medical therapy, patients with stable ischemic heart disease who fit the profile of those in ischemia and do not have unacceptable levels of angina can be treated with an initial conservative approach. But they also found support for an initial invasive approach. They said an invasive strategy which more effectively relieves symptoms of angina, especially in patients with frequent episodes, is a reasonable approach at any time point for symptom relief. So previous to ischemia, you basically had the guidelines and the appropriate use criteria said you had to be on at least 2 angina drugs and fail them, okay? Well, now we know that that's not true, because even if you're on those and even if you're tolerating them well, as long as you're having any angina at all, you're still going to feel better with an invasive approach. So other than the absolutely asymptomatic patient, then an early revascularization strategy is reasonable. So the bottom line is you've got to understand the nuances of this trial. I think they do apply to a lot of patients with stable ischemic disease, and it gives us insights on how to manage those patients on the fringes, such as those with a lot of angina in whom you would more favor revascularization. So if you do have a patient that fits ischemia, you should talk to the referring doctor, talk to the patient, and find out what the patient's risks are of this upfront strategy, which will prevent late MIs at the risk of an early MI, but may make them feel better over time, versus a more conservative approach where at least it's certainly not going to affect their longevity, but they may ultimately have more procedures later requiring, or more angina later requiring a later procedure. So I'm going to stop there. Thank you very much.
Thank you, sir, for excellent analysis and presentation of ischemia. That's why we wanted you to do this. It already must have relieved many doubts of our doctors. One or two questions can we have before we go to next lecture, sir?
Sure.
Can we have a few questions before we go on to the next lecture of yours?
Yes, please.
Yeah. Do you think the role of CT angiogram in the assessment of stable angina would increase post this trial, and everybody who has class 2 symptoms gets a CT angio now? We were following treadmill before. Now the importance is less, and CT angio importance increases with this?
Yeah, I do think the importance of CT angio is there. If you have a patient with mild ischemia, let's say you did do an ischemia test, it's less likely that they'll have left main disease, and so you probably don't need a CTA in that patient. But if you do have a patient with at least moderate ischemia, somewhere between 8 to 10% of those patients are going to have left main disease. And we excluded the patients with the worst stress tests, those that had, for example, transient ischemic dilatation of the left ventricle or exercise-induced hypotension. They never even got through screening. And they're more likely, of course, to have left main disease. So I think before you do the ischemia approach of a conservative strategy without angiography, at least for patients with moderate ischemia, you do need a CT to rule out left main disease.
Yeah, I was seeing some of the panelists asking questions. Go ahead. You unmute yourself and ask questions.
Excellent concept, sir. My question is, ischemia trial started with the low risk group because we excluded most of the high risk group. Do you think we have an impact on the clinical practice because any reduction in the usage of stents or intervention procedures? And what is the role of FFR in this group selected?
Sure. So in terms of FFR, if the patients did go to the invasive strategy, we basically had a very strict algorithm of how they were supposed to revascularize. The goal was really complete ischemic revascularization. If they were undergoing to go a PCI, if they were undergo CABG, then the routine is still anatomic revascularization. But for PCI, it was ischemic revascularization, and we asked them to revascularize any stenoses with a visual diameter stenosis of greater than 80%, and if it was anywhere between 40 to 80%, unless there was clear ischemia in that territory on the non-invasive test, then they should use either FFR or IFR to decide whether or not to revascularize that lesion.
I have a question. You know, the 5-year results, 5% event, total event. Is it not very less compared to the your background trials like BARI-2T and other trials, trials? What is the reason that we have a very low event rate?
Well, the cardiac death rates were 5% at 5 years. So the overall event rates were more than that. But, you know, so 1% per year cardiac death, 1.5% per year overall death. And I think these are highly selected patients. They're patients who, again, had a fair amount of coronary disease, but it's stable coronary disease. And they're on overall pretty good medical therapy. And they're being very carefully watched in a close randomized trial. So again, these are not your typical average patients in practice.
Yeah, I think, you know, that's a really key point Greg makes. And also the other point is that because the median follow-up is 3.2 years, yes, the 5-year data has been presented. When we're confronted with sort of a 60-year-old person who's coming to see us, we often try to think of them in terms of what's going to happen, not just over the next 5 years, but 10 years and beyond. And so I think that that's a really important perspective, which is why I think it's great that the investigational team is applying for additional funding to be able to follow up patients for longer. But you have to recall that it's an individualized decision in the end. Greg, that was a phenomenal talk. Sorry I had to jump off. We had an emergency in the hospital, but I think it's probably time to move to your next talk because I know we got to get you out of here, but also need to move the session on.
Terrific. Thanks, Ajay. Okay, I'm going to take over the screen again.
Can I ask one question?
Sure.
Yeah. Hello.
Yes.
Sir, as we know that maximum advantage, maximum benefit was in patients who have frequent angina, daily angina or weekly angina. So how appropriate it is it to consider them stable CAD patient when they are having frequent angina?
Well, again, it also applied to patients even with monthly angina, 1 or 2 episodes a month. So, I mean, if you've got a patient with a 3-minute episode of angina once or twice a month, you know, that's a pretty stable patient. So, you know, and the point is that these patients are not dropping dead. They're not having a high rate of death. They're not having a lot of plaque ruptures. They're not having a lot of myocardial infarctions. Even though we did reduce the rate of spontaneous MIs, you can still see those rates are relatively low. So they're relatively stable patients, not as stable as patients without coronary disease, but really not bad.
Thank you.
Okay, so let me go on to the second talk, and now I'm going to speak on the current role of MitraClip in patients with mitral regurgitation. These are my disclosures. I work with a lot of valve companies, but none of them, not Abbott, that makes the MitraClip in terms of financial relationships. So when we talk about mitral regurgitation, you've got to realize that there are multiple different types of mitral regurgitation. And this is the original Carpentier classification from more than 40 years ago that is still very relevant. We basically think of primary MR where the problem is the valve itself. There's disease of the valve. And we think of secondary MR where the valve is relatively normal, but it's a disease of the left ventricle. And the left ventricle distorts the components of the mitral valve so it can't function. So with primary MR, it's described as Carpentier 1, 2, or 3A, and you can see it's leaflet perforations or clefts, mitral valve prolapse, the most common cause, and then either rheumatic valve disease, mitral annular calcification, or drug-induced MR. But for secondary MR, which is actually even more common, these are patients mostly who have heart failure and then have either a non-ischemic cardiomyopathy or an ischemic cardiomyopathy. And in these two cases, which is about 90% of the MR, what happens is the LV dilates and you get apical and lateral dislocation of the papillary muscles. So they pull away from the normal position. And of course, that's attached to the cords, which are attached to the mitral leaflets. And so the mitral leaflets are pulled or tethered. And because of that, they're no longer allowed to coapt. So it's the opposite of them prolapsing into the left atrium. They're not even able to close in the left ventricle. So again, the non-ischemic cardiomyopathy gives you this spherical LV. Ischemic cardiomyopathy, it tends to be more posterolateral regional LV dysfunction. And then in about 10% of the cases, there's atrial functional MR, where the ventricle is pretty normal. The primary problem is a dilated left atrium, usually due to chronic atrial fibrillation, and that can lead to primary annular dilatation. And what that does is it, again, leads to lack of coaptation of the leaflets. So the mechanisms are the same. These give you a central jet. This gives you an eccentric jet. Now, the surgeons classically have a tremendous advantage of treating MR, in particular degenerative or primary MR, because there are so many different etiologies. And if you look at just mitral valve prolapse or Barlow's disease, fibroelastic deficiency, which is about 85% of all the degenerative MR, there's incredible patterns depending on which clefts and leaflets are involved, how severe and redundant the tissue is, et cetera. And when the surgeon is in there, they can use all of these established techniques and all of these newer techniques to get an excellent repair. And it's very hard to match surgical outcomes for degenerative mitral regurgitation. And there's no randomized trials, that being said, of surgery in degenerative or primary mitral regurgitation. But we've got a lot of studies where if you look at the outcomes of patients who had severe primary MR and look at age and sex matched populations, they seem to be put back on their absolute normal survival curves. And we know that after a good repair, in 10 years, the recurrence rate should be less than 5% of the need for another surgery. Now, in contrast with functional MR, we don't have evidence that patients are doing well. There's no randomized trials again in surgery, but we do have a fair number of observational registries which have looked at the outcomes of patients with heart failure and severe functional MR who either are treated medically or with surgery. And this is the biggest series that's usually quoted from the University of Michigan, Steve Bowling, and 419 patients. And you can see there were absolutely no differences in overall outcomes between medical and surgery. And this is a relatively high mortality procedure because the patients have heart failure, a bad LV, and multiple comorbidities, and they do very poorly. So because of this, for heart failure and secondary MR, until recently, medical therapy was the standard of care. Whereas for primary degenerative MR, a surgical mitral valve repair was the standard of care. And so if you look here at the overall STS registry, this is the United States Surgical Registry of 87,000 patients in a 5-year period. If you look at isolated mitral valve surgery, the vast majority is done for mitral valve prolapse. The second most common cause is rheumatic disease. And very rarely is isolated mitral valve surgery ever done for functional mitral regurgitation. Only about 700 patients per year in the entire United States. So medical therapy is really the treatment of choice for that. So in comes the MitraClip, and you all know about the MitraClip. It's a very safe transcatheter procedure in which we go through the femoral vein and up to the right atrium, and then through a atrial puncture into the left atrium, across the left ventricle, and then the anterior and posterior leaflets of the mitral valve are clipped together with this polyurethane coated clip. And it creates this double orifice or bow tie repair. And this was based on a surgical technique that was developed many years ago by Ottavio Alfieri in Milan. If that doesn't relieve the MR enough, you can take it off and put the clip somewhere else. And if that doesn't work, then you can put in 2 clips or sometimes 3 clips to reduce the MR. And you just got to be careful about not producing mitral stenosis. So after some pilot work, this was first studied in the Everest 2 randomized trial more than a decade ago. And this was the first randomized trial, really, in the mitral valve space. And it was a relatively small trial, 279 patients at 37 sites. This was patients with low-risk patients, few comorbidities, because back then, for everything, surgery was considered the standard of care. They had to have 3+ or 4+ MR. And this is back at a time where we didn't even realize how important the difference was between degenerative MR and functional MR. That's secondary MR. So about 3/4 of the patients had degenerative MR, 1/4 of the patients had functional MR, and they were randomized 2-to-1 to the MitraClip versus surgery. And as you would imagine, the MitraClip was much safer than surgery. There were many fewer major adverse events, particularly bleeding, need for blood transfusions, etc. But in terms of effectiveness, the MitraClip was not as effective. There was a much lower rate of achieving 2+ or less mitral regurgitation, and there was a higher recurrence rate, although there was no difference in mortality. And this was in the very early learning curve of where we were with the MitraClip, but nonetheless, because of this, surgery remained the standard of care for patients with degenerative mitral regurgitation. Now, when you looked, though, at all the subgroups, there was only one subgroup that stood out as being potentially informative, and that was whether or not the patients had functional MR, that's secondary MR due to heart failure, or degenerative MR, that's primary MR, mostly mitral valve prolapse. And if the patients had degenerative MR, they clearly did worse with the MitraClip. But if the patients had functional MR, now the point estimates are not significantly different. If anything, they slightly favor the MitraClip, and you'll see the interaction p-values for these differences are significant. Now, remember, though, I told you that bypass surgery has not been proven to be beneficial for functional MR. So this could mean that the MitraClip may be as good as surgery, but that may be as good as a procedure that doesn't work. So we really needed trials of the MitraClip compared to the standard of care in patients with heart failure and secondary MR, which is medical therapy. So based on this study, the FDA approved the MitraClip for treatment of patients with degenerative MR who were at prohibitive risk for mitral valve surgery. There was registry data to suggest that these patients felt better, but if they could have surgery, they should have surgery. If they were too high risk for surgery, then they could have the MitraClip. And in the US, until recently, that's how the MitraClip was by far most commonly used. Although in Europe and elsewhere, the MitraClip was more commonly used for secondary MR. Now, the guidelines reflected this fact after the Everest 2 trial, and here you could see in patients with primary MR who were symptomatic, who could not undergo surgery, then you could see that TMVR made it into the guidelines. Class 2A, not very, Class 2B, excuse me, not a strong recommendation, but at least it's in there. Now, what about functional MR where the disease is the left ventricle? Okay, 90% of the time it's the LV, 10% of the time it's the left atrium. So to address this, we performed the COAPT trial. And the COAPT trial is the largest randomized trial to date of patients with any mitral valve disease. It was 614 patients with heart failure and a left ventricular ejection fraction of 20 to 50% that had 3+ or 4+ severe secondary MRs assessed by a core laboratory who remained symptomatic despite all best medical therapies and cardiac resynchronization therapy. And this is a disease, heart failure with MR, where heart failure drugs do work. They will decrease the MR in a certain percentage of patients. They will make the patient live longer. They'll keep them out of the hospital. So we're talking ACE, ARBs, and ARNIs. We're talking beta blockers, aldosterone antagonists, and cardiac resynchronization therapy if appropriate. So if a patient was still in NYHA 2 or 4 class, despite being on all the best medical therapies, then we randomize them to either continue the medical therapies and have the MitraClip versus medical therapy alone. And our primary endpoint here was all heart failure hospitalizations within 24 months, and there was a marked reduction with MitraClip treatment compared to medical therapy alone. Patients felt better almost immediately, and almost immediately we were having fewer heart failure hospitalizations. About a 50% reduction, you can see highly statistically significant. The number needed to prevent a heart failure hospitalization in 2 years was only 3 patients. So again, very effective therapy on an absolute level. And even more importantly, perhaps, when we follow these patients out to 2 years, we see a substantial reduction in mortality. This is all-cause mortality, about a 17% absolute reduction. You could see here 2 years of 50% mortality in the control group. That's, like a lot of cancers. So these are very sick patients. And while we're not curing them with the MitraClip, because we're not affecting the underlying LV dysfunction directly, we are reducing the mortality by about 17%, number needed to treat of only 6 patients to save 1 life. To try to put it into perspective, if you looked at the patients with an ejection fraction of 20 to 40% within COAPT, that is the HFrEF population, if you look at all our class 1 guideline pharmacologic agents, it takes treating 20 to 50 patients to save a life within 2 years. Whereas the MitraClip, it was 5 patients to save 1 life within 2 years, so much more effective therapy. We also reduced the progression of disease that required LVADs or heart transplants, about a 2/3 reduction in the hazard for needing an LVAD or heart transplant. And this is one of the safest procedures that we do in the cath lab. We had a primary endpoint of freedom from device-related complications within 12 months. The FDA would have tolerated up to a 12% adverse event rate, and ours was only 3.4%. So done in experienced hands, there are very few complications. Now, at the same time, a second trial was being run in France. This trial was called MITRA-FR. It was about half the size, and it on its face was very similar, but there were some important differences. They took heart failure patients with LVEFs of 15 to 40% who were symptomatic on medical therapy, although they didn't require maximal medical therapy, and they defined MR with a less severe criteria. A criteria that was an EROA of 20 millimeters squared or a regurgitant volume of 30 millimeters squared, which were the European criteria of functional MR, which allows what we would call moderate MR, they considered severe MR. And unlike COAPT, where if you look, for example, at death or heart failure hospitalization, a very robust reduction, there was absolutely no difference in death or heart failure hospitalization in the MITRA-FR trial. So what's going on? Here are some patients that don't benefit from the MitraClip. Here are some patients who markedly benefit from the MitraClip. Well, I think a lot of this can be explained by the fact that different patients were enrolled. And Paul Grayburn and Milt Packer have introduced this concept of disproportionately severe versus proportionally severe versus non-severe MR. And basically, the way we normally quantitate the severity of MR is by this effective regurgitant orifice area. But it turns out that by the Gorlin equation, the severity of MR, if you define severe MR as a 50% regurgitant fraction, half of it's going backwards, there are many things that will affect that, and many things will affect this number, one of the most important of which is how large the left ventricle is. So if the left ventricle is very large, then you need a very high EROA to be what's called severe MR, which is this blue line. If the left ventricle is very small, on the other hand, then you need only a small EROA, maybe 0.2 centimeters squared, to have severe MR. So it turns out that if you plot the left ventricular end diastolic volume versus EROA, you can see in COAPT, we had relatively small LVs because we had a cap on how large the LV could be, but we had severe EROAs of 0.4 centimeters squared. In contrast, in MITRA-FR, they had much larger ventricles and they had lower EROAs. So disproportionately severe MR, to make this simpler, is really just very severe MR. Proportionally severe MR is severe MR, and non-severe MR is non-severe MR. And very severe MR should benefit greatly from MR reduction. Severe MR should still benefit from MR reduction, and non-severe MR are unlikely to benefit from MR reduction. So in COAPT, we basically had a cloud of patients around these population mean, of course, most of which were probably very severe MR, whereas in MITRA-FR, they had some severe MRs and a lot of non-severe MRs. And these patients, these non-severe MRs with very big ventricles, really need a heart transplant or an LVAD. So the bottom line is pretty much all the patients that followed COAPT enrollment criteria benefited by experienced MitraClip implantation. And again, the MitraClip users were somewhat also more experienced in COAPT than MITRA-FR because this was the registration trial for the device in France. The operators had not been using the device for as long. So how do we decide what is severe MR? Well, this is what we used in COAPT. They had to be graded by one of three criteria. Either an EROA of at least 30 centimeters squared or pulmonary venous systolic flow reversal. That got 86% of the patients in. If you had 0.2 to 0.3 centimeters squared, then you needed one or more of these following events. And sometimes you can't measure the EROA, in which case two or more of these types of parameters could get you qualified, but that was a very small percentage. And in the COAPT population, all patients in all three tiers benefited from the MitraClip. Importantly, though, you had to have a 20 to 50% EF, and you cannot have a markedly dilated LV. So we capped the left ventricular end systolic dimension at 7 centimeters. We also excluded patients with very severe pulmonary hypertension or right ventricular failure. So pretty much if you follow the COAPT criteria, the patients will benefit. And that's what the FDA said. Last year, they basically approved the MitraClip for treatment of select patients with a severe secondary MR who remain symptomatic despite guideline-directed medical therapy. I won't read you the label, but they basically said, follow the COAPT criteria, and that's the labeled indication. And now we have that in the guidelines as well. And again, I won't go through this, but now we have moderate to severe secondary MR. And again, if the patients are symptomatic despite GDMT and CRT if appropriate, if they stay symptomatic, now they get treated with TMVR with a strong level of evidence. So finally, to clip or not to clip, who are the clip candidates? Well, for primary MR, if they've got the appropriate clinical and echocardiographic indications for a mitral clip, and if the operator believes they can get a very good repair, then it's those patients at high or prohibitive surgical risk. Now, there are trials that are ongoing now. We've gotten such good results with the mitral clip. There are trials now that are randomizing intermediate surgical risk patients to either surgery versus the mitral clip. And I'm hopeful that the mitral clip is going to prove to be non-inferior now to those patients. But we've got to wait for the results of those trials before we recommend treating intermediate risk DMR or prolapse patients. For patients with secondary MR, the control or the background therapy is guideline-directed medical therapy. And basically, the indications are symptomatic patients on maximally tolerated guideline-directed medical therapy and CRT if appropriate, who have 3 to 4 plus MR by the US ASC criteria or the COAPT algorithm that I just showed you, an EF of 20 to 50%, a left ventricular end systolic dimension less than 7 centimeters, without severe pulmonary hypertension or RV failure. What about other groups? What about those who have a slightly less MR but a non-dilated ventricle, or who are asymptomatic? Maybe you should treat them early. We just don't know yet, so we can't recommend the mitral clip in those patients, but hopefully we'll be able to do future randomized trials to prove the benefit of the therapy in additional indications. Thanks very much.
Thank you, Dr. Craig, for the excellent talk on this trial. We had controversial results before, but after advent of COAPT, now it's clear that if you identify and select the patients right, as you said, this procedure would benefit. And as Sarah has to leave, if any of the panelists and any other things have any questions on this talk, you can exchange. Then on request to other colleagues is, as the live case is also coming up, you continue to stay back, and then we'll have the other lectures after the live case. Dr. Ajay, you would say anything?
Yeah, no, I just think that these two talks both perfectly bookend the principle that, if we try to use therapies that are useful and we just indiscriminately use them for everybody, that's how we fail. What we really have to do is think about things and figure out why we're treating what we're treating, and actually use our brains to be able to take care of patients effectively. And what's really nice about these types of analyses that Greg was able to flesh out through these two talks is that by doing these analyses, you can determine which people might benefit the most and which people are not really going to benefit. And for an invasive procedure, if we're going to do it to somebody who's not going to benefit, that's almost a complication because they shouldn't have the procedure done. So I think that really nice parallels in both talks on two different areas, ischemic heart disease as well as, mitral regurgitation. It's typical of how Greg operates. He's very thoughtful in terms of and analytic in terms of his approach. But I think that we as clinicians have to take that to heart and incorporate it into our practice so we can be more effective. I know Dr. Stone has to leave for an FDA call, so I want to be mindful of his time. Maybe we'll take one question from anyone on the panel for him and then let him go to his next call.
I think Dr. Wazira from Sri Lanka, do you have anything to ask, sir? Okay, you have to unmute yourself, please. Yeah.
No, it's nothing to us. It's fine.
Okay. Dr. Yan from Myanmar, did anybody want to ask? You can raise your hand so we can, before sir leaves, we can give you an opportunity to interact with him again. Okay. Because this therapy is new, many of them are getting exposed. Now that's how I think there are not too many in this part of world about the Mitra. Though TAVR has picked up quite well now, where all of us are getting exposed to it. You do have a lot of questions in TAVR sessions, but Mitra clip is not yet approved in our country and many other South Asian countries too. I think that's why they are having less number of questions. But thanks for an excellent talk, sir, and thanks for all the cooperation and your time, sir. And Ken,
my pleasure. Congratulations again on TCT India and Ajay. Fantastic job. Kumar, everybody. Congratulations, and I look forward to seeing you in person soon.
Thank you, sir.
Bye.
Take care, Greg.
Can we get the live case on? I think Dr. Ziad also joined. Welcome, Ziad. We'll take you through live case and probably you can continue.
No, that's great. Zia is on as well. So let's see how what the live case is.
He's supposed to do an OCT guided PCI. Dr. Ajit had some mild issues, health, so he's not joining. Dr. Vijay Kumar is there along with you. Over to you. I think they have just joined in the live case stream coming up. Can you make that angio's picture coming from the screen bigger, please? Hope the other doctors from other countries don't mind, because patient is important and he has some issue also. They want to do the procedure right away. That's what they requested. That's why we took this decision. Please stay back, and we have 3 doctors, Bangladesh, Myanmar, and other places. So you make the audio feed, the video feed coming from the hospital bigger, please. Yeah.
Yeah. Right now, I can.
Yeah. Now
I can only see you. Yep.
It was coming. The feed. What happened? Yeah, just there. Doing it. Yeah. Start.
Good evening, Dr. Srinivas and team TCT.
Can you increase my sound, please? We can see you well and hear you, sir. Go ahead. Dr. Ajay is there to moderate the case, and Dr. Ajay Kirtan is there to moderate the case along with me and many other colleagues. Go ahead.
Thank you very much, and welcome to you all from Glissi Hospital, Kochi. So we have an interesting case for you today. Actually, we were planning another left main case, but this had to be done under rescue. So I will just present the case over to you. Can you show me the PowerPoint, please? Right. So this is next slide, please. Right. What's the age? 72. Right. This is a 72-year-old lady. She's quite a small lady. She's only about 45 kg. She had an acute anterior wall MI today morning. She had a pain in the morning and she reached the local hospital. Now, due to the extraordinary circumstances that we are now in, she happens to come from a containment zone. So a containment zone is one where COVID cases have been detected and these patients have to be kept under isolation. So she came from there and she reached another hospital, and because she was from a containment zone, she got thrombolized. And subsequently, she did have resolution. But 2-3 hours later, she started getting pain again, and that's why she was shifted over here. Now, can you show us the next slide, please, the ECG? Right. So, at our hospital, what we normally do is we do a CT scan to check out for infiltrates, and we do a TrueNat. And both of which were negative, and she was taken up in the evening for an angiogram, and that was what the echo showed. And I will now show you the angiogram. Can you go to the angio? So that's what the angio is. She had an old inferior wall MI about 17 years back. So the RCA is total. And if you see the LAD proximal as a critical lesion, and the circumflex has an obtuse marginal that has got about 70-80% lesion. Now the circumflex is also supplying the right coronary. Now with this particular picture, we did at that point think whether we should be considering a cabbage because this is a high syntax. But she has ongoing pain and due to the circumstances we are in, the relatives decided that they would want to go in only for a PCI. So we will now decide what exactly we should do to her because she has pain and her LV function shows an anterior wall that is significantly hypokinetic, but she is hemodynamically stable.
So this is a great case. Thank you so much for showing it. And first, it's not easy to transmit a live rescue PCI type of case. But second, the complexity of the disease is challenging. Dr. Ali Ziad and I were texting each other saying, and he wrote to me, "These guys have the real stuff." I think it's absolutely true. The challenge here also is it looked to me on the last picture like it looks like there's involvement of the distal left main as well. Am I wrong in looking at that and seeing it that way?
Absolutely. So now see here, the challenge is A, though the proximal LAD is significantly diseased, that disease is going right up to the ostium of the LAD and into the left main. The circumflex ostium seems to be spared of the disease, but you have an obtuse marginal that has a significant disease. So let me tell you what exactly we plan to do. So what I plan to do is, I thought I'll go and open up the LAD, give her blood into the LAD territory so that she remains stable. And once I do that, let me do an optical coherence tomography to find out where exactly the disease lands up to. And that's exactly what we did. Can we show, can you show me the next angio, please? So we opened up the LAD there and we got flows into the LAD. With that, she seems stable. Then I did this OCT. Now let's go to the OCT. Let's have the OCT pictures there, right at the end. Stop it there. Are you seeing the OCT? Right.
Yeah, this is great. And you know, obviously co-registration is fantastic because you can sort of really tell what's going on. Ziad, maybe I'll ask you to comment on it after he goes through it as well.
Let's go proximally slowly, please. No, not that way. Right. So, okay, 1 second. Let me just get that circle out from there. Right. Remove that one. Perfect. And then let's move. Now, if you see distally at that particular point, there is, you can see all the three layers and no significant disease. There is some disease now coming there, which is basically fibrous plaque, come proximally. At that point, there is no disease. You can see a co-registration point that's just after a septal perforator. You can see all the three layers and it's fine. Keep coming proximally. And at this point, if you see, you can still see the three layers, but your diameter has gone down. Probably that's a bridge. And keep coming more proximally. That's the septal perforator. And now stop there. Now that's where you find a little dissection, a little of red thrombus. Come proximally slowly, right, and you see again much of the plaque which is fibrocalcific, lot of fatty plaques there. Stop there, and if you come slowly there, that's what I think was the point where there was a plaque rupture. Come, that's it. So if you see your catheter is right within the intima and you see a huge plaque that's ruptured over there, come proximally. Now, what you're more interested in seeing the ostium of the LAD, and that's the ostium of the LAD. How much square millimeters is that? That's what 1.6 millimeter square. So we have to tackle the ostium of the LAD. Now let's go to the LM. I always believe when there is disease in the ostial LAD, there is bound to be disease in the left main, and that's what the left main looks like. In fact, I think there is already a small intimal disruption there. Can you go a little distally, show that distal, that intimal disruption at the 12 o'clock, 1 o'clock position? Right. And now come proximally into the left main. There are a lot of fatty plaque there, fibrous plaque.
Lipid.
Going right up to the of the LM. So,
Zia, what do you think?
I mean, I think Ronnie is clearly an expert at this. He understands the morphology. He's applying what I'm going to talk about later, which is the MLD Max algorithm. There's clearly a lot of disease. There's clearly a beautiful description of a ruptured plaque, and there's disease into the distal left main. And I think that Ronnie has led the world on this understanding of stenting across this ostium of the circumflex for the left main. So I'm looking forward for him teaching us all more about his experience to that regard. But I think clearly in this situation, for a PCI approach, you're going to need to stent across into the left main.
good. Thanks a lot, Ziad, for your comments. And I want to ask you a question. What do we do about the circumflex? If you look at the circumflex, there was an OM disease. So what I did is something a little different. So what I did is I wanted to decide whether I should go with a single stent strategy or a two stent strategy. Obviously, I thought the circumflex proximal was not significant. But what I went and I did is I went and stented the obtuse marginal. Show me the next.
So that's a wise move. That's a wise move.
And then what I did is I did an FFR to the circumflex to see actually is the proximal circ diseased, and that's the FFR. Can we have the FFR on this? And I wouldn't normally do an FFR in such cases, but since this is a live case, and I thought somebody would say that the circumflex is significant, and therefore we must go with the two stent strategy. So I just wanted to prove it out and show, and that's why. Are you seeing the FFR?
We can't see the image. We just see the wire halfway in the circ.
I'm sorry. That's the FFR, if you can see now, and that's 0.89. So we are at this point. So based on this, I decided that we're just going to go and do a crossover stenting. And I think Dr. Ziad has been the master of telling us where exactly to keep the stent, depending on his MLD Max algorithm. And we did do a calculation on that. If we can go back to the OCT and show them, it showed us that the left main is around 3.4. She's a very small lady, 40 kg. And the length is around about 38. So based on that...
No, keep going. What I was going to say is I think that one thing that's important, not only to get the sizing right, but make sure that you have enough if you're going to stent in the left main so that you can do a nice pot or proximal optimization with typically an 8mm balloon. So it's nice to hang back that far. But I really like how you did the circ first because you take that OM out of the equation. You don't have to worry about, recrossing struts and getting hung up and that sort of thing. And if you had wanted to, you could do an imaging run back through the circ, but this is a very elegant strategy that you've chosen to pursue to be able to treat this.
So what I am planning to do is I'm planning to go, give me a good injection. I'm planning to go from the left main into the LAD and go and stent there, right up to the ostium. All right, can you get ready, please, to deploy? 1 second.
And hemodynamics have been stable this whole time because clearly with the inferior infarct and an occluded right previously, and then also coming in with an anterior MI, it looks like you've been stable though, huh?
She was a little unstable until we opened the LAD. Once we opened the LAD, she became stable, and that's why I was happy at that point. Down.
If I could make a comment, Ajay, I want to just reiterate how important what Ronnie did was, and that's to predilate the LAD. Too many times people try to perform OCT to sort of maintain the plaque morphology and push it through an extremely tight lesion. This is not IVUS. You need space to actually have blood flow to create flush. And so it is the appropriate thing to predilate the lesion so you can get a good picture.
And so you can establish flow. So for both reasons, it's just lots of experience showing through in this case on multiple fronts.
So what I've done is I've just gone and stented across, but that looks good. But what I got to do is, the problem is going to be the circumflex ostium. So let's come to the RAO caudal view. And
Ronnie, what size stent did you use?
I used a 3mm stent. The reason I used the 3 millimeter was the left main looks to be around about 3.4. So I thought if I use a 3, I can go and blow it up. This is a Zyme stent. So a 3 will go up to a 4.1, and therefore that's why I thought I will go with a 3 and do a pot with a 3.5.
Yeah, and that's a very, that's
Give me
a
an
perfect
LO
strategy.
please.
And I think Ajay mentioned, I was just going to mention, Ajay, like understanding the dynamic range of these stents, like Ronnie just said, is critically important. So, the 3.5 can get to 5.75. The 3.0 can get to somewhere between 3.75 and 4. So, picking your stent in accordance with that's really critical if you're going from big changes in the vessel size.
Totally. And if you don't have a tapered stent, then oftentimes it's better to under deploy a stent distally. Make sure you don't deploy it at full nominal, but under deploy it so that proximally you have enough ability to expand your stent adequately.
Absolutely. I entirely agree with you. So what I'm now going to do is I'm going to do a pot because if you see the last shot that I did, I think there's a little bit of carotid shift into the circumflex, and of course we'll confirm that with an OCT. But and it's very, very important how we do this pot, because your distal part of the balloon should just be at the carina. So that I think is just right. So let's go in. Let's go slowly up to 3.5.
That's exactly right. You don't want that distal marker of the balloon to be in the vessel for two reasons. One is it may be oversized, so perforation, but the other is that you totally can distort the carina if you're too distal with that distal marker. So what was done there, you got to take the time to do it right. And that's also why often you need enough stent hanging back in the left main to be able to do the pot without injuring the main otherwise.
But
so, Ronnie, for an expert operator like you, we'd ask why you decided not to leave a sort of protection wire in the circumflex, especially with an occluded right.
Right. I think that's a good point, because what I thought was, since the give me another wire, please. Yes, since the OCT also showed that the circumflex ostium did not have a disease, I normally would just go and leave it like that. But what I do is I now cross with a wire to what I think would be a distal strut and then do the OCT. I may not go and open up the strut at all if there is no strut right across the circumflex ostium. But if there's a strut across the circumflex ostium, I save an OCT run.
So Ajay, just to mention, Ronnie and I have been working together really on his work to bring it to the limelight, where this concept of us sort of stenting across the left main and leaving the struts, which we, to be honest, even I, for the most part, thought was very benign. Ronnie has really changed my mind on this and shown me in serial follow-up a number of cases almost occlusive neointimal growth on top of the ostium of the circumflex with serious clinical consequence. Just beautiful images.
It's just hanging out the strut that's hanging in the middle. No, exactly.
It's just beautiful work. And, I think the dogma had gone to the fact that if you start moving towards sort of mandatory kissing balloon inflation, your target vessel failure actually goes up for injuring the circumflex. And may help us guide whether or not there's a mandatory kissing balloon inflation required in the distal left main, or whether we should use an imaging guided approach to help us determine.
Yeah, it's funny because in the past, it's kind of been guesswork. People sort of say, well, if you can kind of get through it, then, don't instrument it too much because then you'll mess it up. But then other people sort of say, well, I at least want to, it's the circumflex, have some access to it, so let's take a balloon through it. And all of those things are probably indirect measures for what exactly you can see with OCT, which is where the strut is. And if the strut is sort of in the middle and obstructing flow, then you're not going to be able to get an IVUS or a balloon through it and that sort of thing. So rather than just trying to experiment with seeing if you can put things through, perhaps it's better to actually image it, and with a technology like OCT, you can actually see exactly what you're dealing with.
And so, Ajay, I should mention, this is one of the places where I think the high resolution is particularly of value. The difference between the high resolution pullback and the survey mode is that the high resolution will not skip frames. As a result, you won't have any breakage in the 3D reconstruction of the stent, so you can truly determine where your wire is.
Right, so what I'm going to do right now is I'm going to give you another shot now of the OCT and try and show you exactly how the bifurcation of the left main looks like.
And he did it very quickly, but he switched the mode there. So most people are not familiar with driving the settings on the OCT. Frankly, most people don't use a lot of imaging, but if you're using it, be familiar with how to measure, how to adjust the lumen contours, and then changing the resolution there so that you don't get this dropout of frames.
Good. So now I want to actually let them co-register it. Keep it right at the OCT. Let them co-register it, and let's get to the hold there. Come this side. Good.
And you're going to leave that distal stuff alone, probably?
Yes, I'm going to do that. Anyway, accept it. Let's see the... Now, I want you to rotate that so that you see the circumflex ostium. Good. So you see the circumflex ostium there, right? Now let's get remove the rendered stent, and now let's get the marker to the circumflex ostium. I'm going to get the marker to the circumflex. No, please. Right. Okay. Good. And now, no. Get the marker on the L view to the ostium. Right. Let the marker onto the bifurcation. Good. So now come proximally, and let's go step by step. Yeah. Come proximally.
So two wires. You see two wires there, and then you don't have to go that far.
Okay, right. I'll do this myself. So what we're going to do is go to the left main here. Now you see the left main, you see the two wires. Now we're going to go distally. So now you see at 8 o'clock, your wire goes into the circumflex. Now,
very nicely.
And then it goes. Now, is this proximal or distal stuff? We don't know what to know. We cannot be too sure. So at this point, let's go to rendered stent. And just let's get on to the bifurcation view. And rotate that.
Beautiful.
You see that? It's exactly in the distal strut. And now this is where I'm going to tell you. Now you have a crown and a valley both across the circumflex ostium. And over a period of time, this is going to undergo neointimal proliferation and occlude the circumflex ostium. So this must be kissed. What do you say, Ziad, about this? Let's go and kiss.
Just beautiful, beautiful description. So a couple more comments from an OCT point of view. First of all, you'll notice that Ronnie took over and used the hand controller. To be an expert at this, you've got to be able to use the hand controller because we're talking about the most important parts of the procedure, and the operator should be the one handling those. A beautiful description of 54 millimeter pullback showing the wire going through the distal strut. And remember, during a provisional approach, we want to go for the distal strut, but for a DK crush, we want to go for a proximal strut, culotte distal strut. So now what we've seen is we're through the distal strut. That metal is a nidus for neointimal proliferation and is guiding a kissing balloon inflation. This strategy is being tested prospectively in the October randomized controlled trial, which is currently randomizing in Scandinavia and Europe. And we should have some clinical idea as to whether this creates a benefit in the near future. The currently available evidence is the OCT 3D or OCT BIFE study, which comes from Japan, which showed that by using the OCT, we can be much more clear as to regards to which cell we're under. However, in that 300 patient studies at that power, there was not a clinical benefit.
Mm-hmm.
But I think what's really nice also is with this is that you're getting the view of the ostium with, not having to advance anything into the circumflex. This is done via the LAD, and you can determine exactly what's going on, and based upon that, make your decision. So I think that it's just a very elegant demonstration of how to do it, and as soon as he took it over, he was able to show everything. And by the way, if you didn't do this bifurcation view, and just looked at the image on the upper right, it looked like the ostium of the circ was completely unimpeded and fine. So it will be really nice to get prospective data on this approach, because most people would have just left it alone and been fine with it and said, well, you're just going to injure it by doing this. So, I commend you not only for doing the work to look at how this can be seen, but then also studying it prospectively.
Right.
So Ajay, Ronnie, I wanted to ask you, undersized balloon, 0.7 to 1, 1-to-1 balloon. How do you decide this?
You mean for opening the circumflex ostium?
Yeah.
Right. See, the problem is, since we have not done an OCT of the circumflex, I really do not know the size of the ostium of the circ. But what I normally do is, as you now see, I'm just going to give a low pressure dilatation of the circumflex just to move the strut away. It's just,
the idea here is not to,
away. That's it.
Yeah, the
That's
idea
it.
is not to
That's
open
all.
the circ. It's just to move the strut.
And now go back to the LAD. Now that's a 2.75 balloon in the circumflex and a 3 into the LAD left main. 10, 12, right, stop, down.
And I think this is a good use of a semi-compliant balloon in these situations, because all you're trying to do is move the strut. You're not trying to dilate.
Absolutely.
And the struts can very gently be moved with 4 atmospheres. It's just like treating malapposition. You don't need to go to 20 atmospheres to push this very soft metal against the wall.
No.
And then what's really nice is by doing an OCT again, you can see exactly what you did.
Absolutely. That's what exactly I'm going to show you right now. And normally what we do is we see a good ostium of the circumflex without a strut. And I hope I'm able to show you that in the next 2-3 minutes. Give me the OCT catheter. I'll just do a shoot for you meanwhile before we take the OCT catheter and get ready with the OCT catheter. And now that's how it looks. It looks good, right? So let me just give you the OCT run on that. How many minutes more do I have?
15 minutes.
Right. Good. So then I'll be able to show you the OCT run.
Yeah, no, you'll definitely be able to show it. And while you're doing it, I also want to mention that, doing this in the setting of COVID lockdowns and containment areas and that sort of thing. I have my wife is from Kerala, and so I have a lot of family there. And I can tell you that, some of how strict this is, it's impressive that you're able to get CTs and testing and transfer and all of that, despite some of the lockdown that's over there right now. So, and then showing it live, even more credit.
Yeah, we should be thankful to Ronnie for this and elegant demonstration by OCT too.
Right, so I'm going to go and inject this and show you the ostium of the circumflex. I'm not going to go for a long injection, but I'm just going to go for a short injection and show you that. Can we go to live view? And that's it. Live
so can I just comment on what Ronnie is saying there? When you're trying to get a left main OCT, you do not need to put the catheter all the way down the artery, because the maximum flow happens early in your injection, and you'll end up with some poor flush. So keep your catheter focused, as you saw here. And so you can see that even in left main, you can get beautiful runs. That does a couple of things. Number one, it limits the amount of contrast you use. Again, you can see Ronnie is a master operator with OCT because he's been very judicious with the dye, especially in a patient using in the setting of ACS. And really it's facilitating contrast injection to get the OCT rather than vice versa.
Thanks. I think what Dr. Ziad said is exactly what we intended. We just go proximally so that we don't have to give too much of contrast to get that done. Now, let's accept that. Are you seeing the OCT screen? Doesn't matter. Forget it. We don't want a co-registration here. I just want to see the bifurcation. Right. Now come to we keep the circumflex up on the L view.
So maybe I can mention why this is co-registered inaccurately. So the OCT co-registration looks by finding the lens in the darkened part of the artery that's opacified by contrast. That's how it determines its region of interest. And what's happened in this situation is the lens has ended up in the left main where the circumflex and LED are overlapping. And that's why it can't find the lens. So it ends up looking instead for the marker, and it finds anything that's moving and Malco registers.
Good.
Let's see images again for my screen for whatever reason.
Bifurcation view rotated.
Yeah.
See, that's one of the issue. As he said, see, that's where the.
There you go.
If you look at it, don't see the dark, but if you see the wire going there and the strut has moved out of the ostium completely.
Totally.
Beautiful.
It's a pretty awesome demonstration. Now you see it wide open, the strut's been bumped over, and this was just with the gentle balloon inflation. How high did you go up on the balloon?
We just went to about 4 atmospheres on the circumflex, and then we went up to 6 atmospheres on both the LED stent and the LED balloon and the circumflex balloon. So here it's just going to be provisional with a strut that is moved out from the circumflex ostium. And normally I think I would be very happy with these results, and I would stop the procedure here.
Agreed. And also the other comment to make is, remember, sometimes there's been concern when you do a kissing balloon inflation that you can distort the carina and you can cause malapposition. This is a 4 atmosphere balloon inflation, and by OCT you can actually look more proximally, and there's not any malapposition of the stent, and the OCT allows you to detect that as well. So this low pressure inflation, kind of like a snuggle type of inflation in the sense, as all it's done is move the strut. The doing it with a kiss is good so that your LED remains protected, but you don't have to do a further pot or anything else like that at this point, and you've confirmed it.
But I would still do a pot because I don't know, it's a matter of habit that whenever I do a kiss, I go and finally do a pot with a 3.58. What is your opinion? Should that be done as a routine? I don't know, but I keep doing it.
I don't know how Z answer his. I don't do it routinely because a lot of it is more about generating a circular versus elliptical geometry, and I'm not convinced that actually changes outcomes a whole lot. Additionally, you didn't do a true, high pressure kissing inflation. It's more of a soft inflation. So I don't think you need to, but you certainly wouldn't be faulted for doing it. Let's put it that way. Z, what do you think?
If you tell me what to do, I'm not going to do it, but I'm happy about it. What about you? Yeah.
So, honestly, in this situation, Ronnie, I think you might cause more damage than good. You've got a beautiful result, fully opposed stent. And let's remember the goal of the pot. The goal of the pot is to push the struts from your provisional into the side branch. You've already shown by OCT you're wide open in that side branch. The second thing to remember with your post pot, which is critical, and that is if your post pot reaches the distal end of the carina, you will reshift the struts. And that's what you don't want to do. That's very elegantly displayed by Niels Holm and Evald Christensen. So in this regard, since you have an imaging guidance of all of the clinical endpoints that you're looking for, I would stop at this stage.
Right. I also agree with you. I would love to stop at this stage, but I think the results look good. And anyway, let me first Dr. Kirtane and Dr. Ziad. Let me introduce my team. There have been a phenomenal team here with imaging. My colleague, Dr. Joe. There's another colleague, Dr. Jimmy. I can't see him. Sister Betty. She's our mainstay in the lab for the last 20 years. Then Wilson. He's the chief tech. I don't know if you can see him. There's Jim C. I mean, they are the people who have organized this imaging system that we seem to be seamlessly doing very fast.
I think that's an important point. And I'll get to that in my talk a little bit later today too. But if you do imaging well and you do it routinely, this is what you can do with it. And I think the problem that many people have is it's hard to get to that step. But I think when you do it this way, you can almost say, why would you ever do it not this way? So thanks so much for showing that. Thanks again, and stay safe, everybody there. Really a fantastic demonstration of a very tough case, to be honest. That you made look simple.
Thank you, everybody. Thank you very much, Dr. Srinivas, for letting us be there. Thank you.
Thank you, sir. Thank you for doing it this tough times. Excellent demonstration. And we can break from LISI Live, and we'll go on to the, we had, for the sake of benefit of the speakers in this session, I would like to mention that we have some lectures left over because the case was ready. We have to move in immediately. We'll finish those 2-3 lectures which were there in the previous session. Then the present lectures would start. I request Ajay to continue. Anyway, I was chairing the other session too. The first presentation was supposed to be from Ghulam Azam from Bangladesh, managing GI bleeding post-complex PCI. I request all speakers to stick to your time, please. We have 8 minutes of presentation and 2 minutes discussion. And Dr. Ghulam Azam, can you get him as a speaker?
Yeah. Am I audible to you?
Yeah, we are able to see you and hear you. Share your screen to get the slides.
Okay. Okay, I'm sharing my screen. Is it okay? Is it visible?
Yeah, perfect. Go ahead.
Thank you, Srinivas Kumar. It's my honor and privilege to be with you. Dear friends and colleagues and distinguished panelists, wonderful audience. Eid Mubarak. Today our greatest festival, Eid Mubarak. Today my topic is managing GI bleeding post-complex PCI. You know, in present situation, identification and management of high bleeding risk patients undergoing PCI are the major challenge. And if you look at the complex PCI, if you treat 3 vessels, more than 3 lesions, multiple stents, if you go for bifurcation with 2 stents, if the total stent length more than 60 millimeters, CTO, calcified lesion, of course, brain graft are almost the complex PCI subset are very much vulnerable to develop complications as well as their high risk patients. If you look at my case, 65 years diabetic smokers present to us CS class 3 angina, his global LV function was 60% and baseline hemoglobin was 12.4 gram per DL. If you look at his angiogram, if you see the left main LED, OM, also RC also involved, that means left main triple vessel disease. Definitely it is CVG is the best option, but repeated declining, we go for stage PCI first from left main to LED and OM. And as our approach, we preloaded by aspirin 300 milligram and clopidogrel. If you look at this PCI, we just stented OM first by resolute integrity, then go for LED, mid to distal LED by 3 into 38 resolute onyx, and from proximal to LED, proximal left mid to proximal LED, we go for resolute onyx 3.5 into 34. Then finally we go for kissing impressions and go for port, and this is the final result. But this patient was discharged by typical ecosprin and clopidogrel. After 2 weeks after patient discharge, patient presented to our emergency department with pain with repeated black H2 for 2 days, and his initial blood pressure was 85/55, and he is found anemic and his pulse rate was 120. Seems to be shocked, and he admitted in our hospital for further management. So, dear panel, actually, what is the culprit of this bleeding? Due to DAPT or due to local GI cause or due to others? You know, if it is due to DAPT, what is the minimum duration of DAPT after such a complex PCI? Clinical criteria are identified as a major or minor criteria according to the VRC 3 or 5 bleeding risk at more than 4% at 1 year should be considered as a major. If it is less than 4%, should be considered as a minor. Among them, 14 are major. There are 6 are minor criteria. If we have a 1 major or 2 minor, we should consider definitely say it is a high bleeding risk patient. In our patient, found 12.4 milligram initial hemoglobin level. If you look at this year, that should be considered as a minor, and he had a history of operational NSAIDs. So we can consider as a 2 minor as a high bleeding risk patients. Other factors are really increase the chance of bleeding after PCI, like age, advanced renal disease, kidney disease, liver disease, if you have active malignancy or stroke, bleeding diathesis, if history of oral anticoagulant, and clinically found anemia or low platelet count. So look, how we manage this patient. We manage initially by resuscitation in the emergency department, giving pantoprazole and considering blood transfusions. Our critical decision was to stop DPT for the time being and make a medical board. If you look at the hemoglobin, it is dropped 7 gram per day from the baseline. It is significantly rise. So what is the recommendation from the ESC? If you have significant come down of hemoglobin with clinical scenario with the pressures of shock, we should consider it as a hybrid risk patients with active bleeding. Then we immediately discontinue all antithrombotic drug and considering after cessation of bleeding DAPT or SAPT, which was preferable. Regarding blood transfusion, we transfuse to achieve 10 gram per DL by 3 unit of transfusions, and we transfused based upon clinical situations, not only just hemoglobin. If you risk estimation from GI bleeding, pre-endoscopic risk estimation by GI bleeding by local score to estimate mortality prior to endoscopy, our patient found 3 score, that means 11% mortality prior to endoscopy. Then we go for Glasgow Blackford score to urgent, how urgent we should go for endoscopic intervention. If it is more than 0, we should intervene immediately. So if our patient get 3 score, 2 score, more than 2, so we go for an urgent endoscopic intervention. And we did accordingly to find out the high risk of endoscopic stigmata. If it is found active bleeding, then we should go for endoscopic intervention. If you look at this, look at this endoscopy, the duodenal bulb apex is erosion of the duodenal bulb and oozing, that means active bleeding. It is the endoscopic findings of high risk of stigmata, and locally injection of antidote is given to stop bleeding. If you look, our patient already getting 2 dual antiplatelet therapy and found by endoscopically high risk stigmata, but recommendation from this European consensus from the European Society of Thrombotic Group, at least 1 antiplatelet drug should be continued. Regarding second antiplatelet should be decision taken by this cardiologist. But finally, we manage our patient by espadrille therapy and start clopidogrel on 2nd day, and every day we're going for OBT, and on 4th day when negative, then we go for start for ecosprin and discharge the patient DAPT, PPI and gastral fat. During the discharge, we assess rebleeding risk, and we found it is around 14% rebleeding risk in our case. So our issue is, and controversies, either we should go for dual antiplatelet therapy or SAPT, and which one is appropriate, we should take the decisions. If you look at these multiple guidelines, there are a lot of recommendations, but DAPT management in post-PCI GI bleeding, no guidance from randomized clinical trial, there are consensus from the guidelines. So we have to balance to reduce the bleeding events and try to reduce the ischemic events. If you look at my case, we find thrombotic risk is very high, as because the presentation after 2 is our PCI, so it should be categorized as a high risk thrombotic group. If we look at this prestige baptist score, how shorter DAPT we should advocate in our case, it is easily only predict bleeding complications in patient undergoing stent implantation and subsequent dual antiplatelet therapy, but not evaluate the thrombotic risk. So if we scoring from 0 to 100, if it is more than 25, definitely we should consider shorter DAPT 3 months to 6 months. But in case of our case, it is found 47, so we should consider for shorter DAPT regime. If you look at these multiple bodies recommended from ACIHA or ASC, they also recommend as a hybrid risk, at least 3 months we should continue. And if we look, as our case is complex PCI, we used already Resolute Onyx. If we look at the Onyx global study, showed Resolute Onyx DES was safe as effective with superior acute performance in highly complex hybrid risk patient with 1 month DAPT followed by SAPT for 1 year. It may give us further confidence to shorten our DAPT regime. And this is, if you look at the Onyx one clear, I think, I know Ajay also, principal investigator of this study, he knows very well. And this trial also extends the finding of the Onyx one global randomized clinical trial to hybrid risk patients treated with 1 month DAPT in the United States and Japan, and meets its primary endpoint, which favorable rates of ischemic outcome from 1 to 12 months after DAPT discontinuation within a high-risk population of hybrid risk patients. So, dear colleague, if I conclude my case management summary, upper GI bleeding post-PCI patient, aggressive resuscitation, urgent lab should be done, and evaluation of risk assess comorbidity with pre-endoscopic by Rockwell score and Glasgow dashboard score, involve gastroenterologist, cardiologist, and hematologist. Restrictive blood transfusion should be considered to achieve hemoglobin 10 gram per DL. Blood transfusion should be considered. PPI infusion, temporary cessation of antiplatelet therapy for the time being to make a judicial decision. Assess the risk of stent thrombosis, assess the cessation of bleeding risk, and assess the risk of recurrent GI bleeding by post-endoscopic Rockwell score. If you think it is a high risk of stent thrombosis, restart clopidogrel as soon as possible, and restart aspirin as soon as bleeding is controlled, preferably within 3 days. So, last but not the least, my take-home message: guidelines will be the guidelines. No case is the same in this universe. Every case is unique in this world. Every patient conditions and clinical judgment is paramount to decision-making process. That finally, I would say feasibility doesn't miss indications. Thank you all panel and serving on the front line of this pandemic. Stay strong, stay safe. Thank you very much.
Thank you, Dr. Azam, for presenting this approach. I think Dr. Ajay is there here as a chairperson. Many of us, when we face high-risk bleeding, though we advocate single antiplatelet drug, we are more comfortable withdrawing aspirin and continuing clopidogrel or ticagrelor, whatever you are using. But there are some studies which are saying now that even the other molecule, only aspirin also can be continued, stopping the other more potent antiplatelet, which we clinicians are a little uncomfortable here. What are your thoughts on it?
Yeah, I agree. I think especially for GI bleeding, one could make the strong argument that the aspirin that's more likely to be causing the GI bleeding than the other agent. So I think that has often been my strategy, and I've been doing much more monotherapy with dropping of aspirin. Many patients get confused sometimes because they all think they need aspirin for their coronary disease, but I think there's more and more evidence that it is probably not needed. The only thing I worry a little bit about in the Indian population or South Asian population is resistance to clopidogrel. And so these are scenarios when I'm dropping aspirin that I do often check the reactivity just to be sure. And if not, then we might use a different agent. And not necessarily, for instance, ticagrelor 90, but maybe at a 60 dose, not prasugrel 10, but maybe at the 5 dose in those types of cases.
Thank you. I see Dr. Sushil also joining now. Welcome to the session, Sushil. As Greg has to leave, Sushil has some time, I request him to join. And we'll go on to the next case. This is another challenging case of PCI being presented by Dr. Wazira Senaratna from Sri Lanka. He is a cardiologist of high repute and seniority there. He is a cardiologist for all the top officials in the government, Prime Minister, President. We are happy that he gave us some time. And we'll listen to him. Meanwhile, connect Dr. Wazira, let him share the screen. The challenging PCI in an elderly man with critical LMCA and ostial RCS stenosis with hostile aortic root. Hostile aortic root, that reminds me, Sushil is joined. We see a lot of problems of aortic root in Tower. Let us listen about this problem from this doctor, Dr. Wazira Senaratna. I'm happy that we are able to coordinate from these various countries across in South Asia and requested them to join. Can you unmute your mic, sir? You have to unmute your mic. Yeah, go ahead.
Congratulations from Sri Lanka, Dr. Srinivas.
Yeah, we are able to see your slides, sir. Go ahead.
Yeah. My case is actually challenging PCI in an elderly person with critical LMC and ostial RCS stenosis in a hostile aortic root. And he's 70 years old feeble man, actually presented with this time with non-cellular MI and post-MI angina. He's a non-hypertensive, which is under control, and non-diabetic, and only ex-smoker. His ejection fraction normally has moderate aortic stenosis and moderate aortic regurgitation. He has a grossly dilated aortic root. I did a CT angiogram which revealed 6.33 centimeters dilated aortic root, and renal functions are normal. And this scenario of his fever, actually, I referred for surgery. Actually, this happened 1918 January, and the surgeons refused, and they warned that patient might have a death on table if they operate. So decided to manage on medication, and recently, last year, November, he came back with severe unstable angina, and his son actually is a junior doctor under me, and he wants something to be done about the patient. And this exactly shows the state of the problem. Huge dilated aortic root, really difficult to engage the guiding catheters. This is how I was trying to do all the guiding catheters was difficult. While I selected IR, guiding catheter just came near the ostia, and next moment I faced the guiding catheter to face the RRC ostium and just able to cross with the wire, and that's how it just engaged the catheter. Then I did the post dilatation with compliant balloon and later with high pressure 275/12 balloon, and then this is how I positioned the stent to cover the ostium, and then I deployed the stent. And then I withdrew the balloon to spray the stent, the osteal lesion. And then I was trying to post-dilate, and this is what has happened exactly. You can see the guide and wire came out. So it's a really difficult thing because the stent is jutting out to the lumen 1 to 2 centimeters. So I had to make a loop, and it was lucky I was able to cross the stent and enter the vessel. And dilate the ostium, and that's how I do the post-dilatation of the stent. And then this is the final result. So it was really difficult right coronary artery anatomy. Then I had to move to the left system, and this is the angiogram done 2 years ago almost. You can see critical 99% distal LMC lesion and with proximal LA deletion. And there are no catheters reaching the ostium. Then I was able to just get the field XT wire near the, while keeping the guiding catheter around, I was just able to push the wire into the LMCN to the critical lesion to the LAD. While keeping that wire, I was able to push another wire to the LAD, and you can see I'm just able to nicely cross the LAD lesion with the field XT wire. Then I'm quite confident that I will be able to do this case. Then I did a dilated LAD with 2.5 compliant balloon and high pressure balloon 2.8. Including the left main. And that's how I dilate the lesion. And this is able to get a stent down. Actually, there's some calcium there. Fortunately, you can see here the ostium is clear of disease. So it's a one stent procedure, luckily for the patient and for me. And I was able to push the 275 28 stent to cover not up to the proximal LMC to LAD and deploy the stent. This is deployment stent. And you can see still the stent is under deployed. It's really tough lesion because it is a chronic lesion. And you expect these sort of problems, elderly patients who always torture vessel, calcific and fibrotic lesion, difficult to completely deploy. I didn't have a cutting balloon, unfortunately, but I managed with the high pressure balloons. This is the LAD with 275 8 millimeter balloon, and left main with the 375/8 balloon, and I was able to achieve a reasonable result for this elderly gentleman because he was so symptomatic. And these are my final results. And now I think I reviewed him last month, latter part, he came almost after 1 year of the procedure. He is totally symptom-free and doing very well. So my points here is actually is a PCBA is a viable option in elderly patient with critical coronary disease who are not fit for surgery or who are refused surgery by surgeons. And in challenging case, we should try our best to maximize the utilized available resources to bail out patients' lives. And the prior counseling to these patients of and relatives of paramount importance because there's always a risk of complications and failed procedures, and therefore it is always very, very impressional to highlight the problems to the patient and the relatives. Thank you.
Thank you, Dr. Wazira, for showing this case. And we have Dr. Sushil also, fortunately, with us. He'll be talking more about approach to coronary artery disease in patients of TAVR with such dilated roots. But before I give it to him, many of the times if the osteal disease of RCA or left main is there, we keep trying. We think that it is because of dilated aorta and other stuff, but catheter may not go properly, engage properly because of osteal nature of disease also. We should be careful not to poke around too much because you could end up dissecting. Luckily, you didn't have a problem, but for sake of learning, I'm just telling. So many of the times, once you do the procedure, you see the watch the right. Once the procedure was done, the catheter could engage well and you could get a good picture. So part of the problems or sometimes could be also because of the osteal nature of the disease, which do not allow the catheters to seat well, apart from the dilated aortas and other things. Sushil, do you want say any comments?
Yeah, I think it's a nice case. It's a very challenging case. The things I would say is, especially in someone with aortic valve disease, this is the type of patient you want to make sure they're optimized before the case. In general, I do a right heart cath, measure filling pressures in patients with valve disease. And if anything, if they need to be volume optimized, you want to do that beforehand. The issue in terms of technical things that I think is a nice demonstration, things that can help in scenarios like this with aortas, and here's what Ajay and others think. I generally tend to use a long sheet to get you into the thoracic aorta. That it gives you more support because a lot of the issue is guide support. And that will take, because you lose a lot of guide length in these patients with tortuosity. If you get a long sheet, you have more, you don't lose that as much, and you have guide support and able to reach. Other things are once you engage a guide extender, guide liner, or whatever is available, if it's in terms of what's available there, can allow you with the mother-daughter technique to get much more support because to Srinivas's point, you want to make sure you're not flipping around and compromising the aorta. So I think those type of things can help. And I think it's a nice example of a PCI, and it's all about goals and expectations. You want to minimize the risk of the procedure. This patient's mortality is probably going to be limited by his frailty and by his ascending aorta. You're trying to get rid of the ACS picture. If you can do intravascular imaging, I think just to optimize, but again, it's more catheter exchanges, more things, and more risk of things popping out. But just optimizing the proximal with the 375 is good, and provisional and minimizing the interaction. But I think it's a very nice example of a complex case. But these are some other tips and tricks that I think you can consider in a scenario like this. And I think the question I asked for the people on the panel, who are much more experienced with radial, do they think this would be easier from a radial and you'd have more support from a radial, or do they think it would be higher risk? And I'm curious what others think.
I think Ajay would have imaged this and dilated that portion where it looked a little underexpanded with more Opian type of balloon, which is available now to optimize the result. But anyway, elderly patient, what we try to do is the best. Because of lack of time, I think we'll proceed further. I requested Dr. Ong from Myanmar. He was trained with us in care, fortunate before. I requested him, and he also has a primary PCI to do. Rahul Gupta is again a good friend, consultant from Apollo. They've agreed to stay away, and then without presenting, thanks to them. And now we go on to Dr. Shamlal Umesh, my good friend from Mauritius. He's the president of Cardiac Society, Mauritian Cardiac Society, and is quite a senior cardiologist there of high repute. I requested him to present a case, interesting case which had post-bypass surgery. Can you get him on to share his screen while I'm introducing? So post-CABG, patient landed up with acute MI and he had bradycardia and shock. We'll hear more of this from Dr. Shamlal. Mauritius also had a tide of COVID cases. Now it got under control, I believe. Thanks for joining us in these tough times also, Dr. Umesh. Over to you.
Can you hear me, sir?
Yeah, go ahead. We can see you and see your slides and hear. Make it full screen.
Yeah, is it okay?
Yeah.
You can hear me, right?
Yes.
Okay, thank you. So, so I have a case presentation. It's a challenging PCI on a CABG patient who came with acute coronary syndrome in my consultation. So I'll give a brief history of the patient first of all. It's Mr. E. He's 70 years old. He came to see me 4 days back, means before he did his MI. He's a diabetic type 2. He has done a CABG in 2007. I don't know which vessels because he didn't have any report with him. So I consulted him on 26th of June 2020, so last month. He just came as a casual visit for a checkup because his treating doctor, his treating cardiologist was in quarantine after a visit to India. So this is how he happened to come to me. Physical examination was normal. The blood pressure was slightly high on 160/80, his pulse 70. Chest was clear, no signs of right or left failure. His ECG was normal sinus rhythm, around 70 per minute with a normal axis. Just we had a PR interval which was around 240, 280 milliseconds. He already had Q waves in inferior leads, maybe most probably due to all changes. His echo, the left ventricle was not dilated. He had a hypokinetic anterior septal wall. His ejection fraction was around 50%, 50-55. Transmitral flow was normal. He didn't have any valvulopathies. The inferior vena cava and the pericardium were normal. So this is an ECG that I got on the consultation. So we can see he has PR interval which is prolonged and Q waves from maybe old changes of inferior wall MI. It's because the patient was completely asymptomatic. So I sent him on a treatment of aspirin, statin, a sartan, and a metformin. I discharged him and I told him, okay, 2 weeks after, we are going to see you with a full blood investigation. So on 1st of July, he calls me at noon. He started having, in fact, the wife called me. The patient was having back pain, jaw pain. He vomited twice. He had severe weakness, and the blood pressure was down to 90/50. He wanted to consult me immediately. He was 30 kilometers away from me, but he managed to come quietly with no pain, stable. He was the third patient waiting on my waiting room. So when I saw him, he was stable, no chest pain. The blood pressure was up to 180, 110/80. Pulse was 75 per minute. His chest was clear. He didn't have any signs of failure. I reassured the patient, and I thought maybe he was adapting to the new medications. And since the PR interval was prolonged and he's 70 years old, I thought maybe he might be going into intermittent heart block, but maybe giving him the vertigo. So I did an ECG, and this is what I find. So on the ECG, I see that he was in fact doing an inferior wall MI, which was giving him the back pain, radiating to both jaws. We can clearly see 2-3 AVF, which is up with mirror images. So I took him to the cath lab immediately without knowing which bypasses were put on him. So this is my first image. When I injected, these are the remains of the left system that I have. I can call them remains because I can see there are almost nothing. So fortunately, the blood pressure till now was okay. We can see a faint line of the LED. And then I tried to take more pictures. And this is what I find. And the right coronary artery is completely occluded from the proximal mid, you can see. So then I tried to look for the grafts, and unfortunately I couldn't get any. So when I did the Lima, so fortunately the Lima was still here, which was irrigating the LED, and most probably the OM graft was blocked and it was being taken by the LED. So then I decided to go, I injected to see if I'm missing anything. I couldn't see any of the grafts. Then I decided to do the PCI of the RCA. Since my patient was stable, I introduced the wire. So this picture you're seeing when I have already introduced the wire. As soon as I introduced the wire, the problem was that my pressure crashed down to almost flatline. My heart rate was around 30 and the blood pressure was almost unnoticeable. So what I did in this case was I had to remove my wire immediately. I had to disengage my catheter because the blood pressure crashed and then heart rate was 20 and the patient started feeling dizzy. He was unstable on the table. He was not having chest pain. When I removed my wire, I decannulated. I let the RCA reperfuse and breathe a little bit. The anesthetist was here. He gave some ephedrine. He bagged with ambu and oxygen. And the BP and heart rate somehow picked up. So I recannulated the patient. I tried to rewire again. And this is what I got after one injection. So then I tried to put my wire again. I started pre-dilating. So pre-dilatation again. So this is where I see the whole of the right coronary artery sort of is diseased. I started a pre-dilatation on the distal lesion because there was distal lesion there. And I thought I'm going to reconstruct the whole of the RCA because I had no other option. I had no grafts. I had only one lima which was perfusing the whole thing. So I took an all-zero stent because that is what I was having in a long stent. It's a 2.5 35. Then I blew the stent, 2 dilatations, and this is how it was, perfectly open. Then I managed to put another stent. This one is a Xience 2.75 33. I inflated my stent. I was trying to fix it well, first of all, and then here we are. So dilatation up to 16 atmosphere, 2 dilatations, and then my blood pressure was all right. I gave a little bit of 50 micrograms of nitro, glycerol trinitrate, and this is what I got as a final result. So the RCA, which was looking very small, we can see it's a very big RCA. And then I was thinking whether I should post-dilate the middle part here or not. Then I thought, since my patient crashed, it's an acute MI with lots of thrombus. I just left it alone. I was having a good result. My patient was stable. So I stopped the case here. Then this is a ECG post PTCA with Q waves which are already present, but we can see the ST elevations have gone down. We don't have the mirror images. This is an ECG 1 week after for the patient. And I let the patient go on aspirin, Brilinta, rosuvastatin, Astatin, metformin. He's stable and he has taken up his duty as a contractor. His blood pressure is well maintained. His pulse was, as we see, 70 per minute. And I saw him today, and the patient is doing perfectly all right with a blood pressure of 110/80. His echocardiography has picked up. He's having 50% of ejection fraction, and he's completely stable 1 month. Today is 1 month after his procedure. So I thank you for your kind attention. But in discussion, I wanted the expert panels to discuss and give me any advice of whether should I have removed the wire and let the coronary breathe because my patient was crashing, because we know wire in a vessel which is occluded is our lifeline. We shouldn't lose it. But here, since my patient was crashing, I removed the wire. Whether I should have done a post-dilatation on the middle part of the RCA, because we don't have any sort of imaging in my lab, no IVUS and no OCTs, or were there any other form of strategy that could have been better here? So kindly advise.
Thank you, Dr. Umesh, for presenting this. I think we should appreciate Mauritius and all other countries they're slightly behind India in this doing all this high-tech work, but you should appreciate that they're doing life-saving work. That's how the life is saved. In India, in more experienced centers, probably would not allow the wire to be going out. Fortunately, in spite of us, patients do all right. God is great. After resuscitation, he got his pressure back and probably flow better. But generally, we try to avoid not to lose the wire. Sometimes a spasm around the wire is there. You tend to give some vasodilators and others. Post-dilatation is a different story. Generally, in acute settings, we tend to avoid post-dilatation because we tend to get into more slow flows. But if you, again, individual decision, if the stent is grossly underexpanded and where you feel it has to be definitely expanded, you take a chance and do it. But by and large, you tend to avoid post-dilatation in acute MI or acute ACS scenarios, as we were discussing in the previous case. I think Ajay is
the one thing I would just add, Srinath, is that I agree. I think this is a tough case. Very sick guy who came in with a large infarct with really just the lima that's open. I think I agree. You don't want to lose the wire. The one thing I would say, this is typical of reperfusion of the right coronary. And when he became sick, I would have gotten venous access. In a case like this where the patient is sick, maybe get the femoral venous access and put in a pacemaker. Because I think a lot of it was bradycardia related to the reperfusion. And so putting in a temporary pacemaker would have given you some time. And also, working with your anesthesiologist to try and maintain blood pressure support. And again, a lot of these infarcts, it's a big right infarct, are going to need a lot of volume. And so making sure giving adequate volume, putting a pacemaker, and then resuscitating as you did, I think are the only things that you can do. In terms of post-dilating, it's tough. I mean, it looked like there was some calcium there. It's hard to see on the thing. If it's thrombus, you don't want to, if it didn't expand, it's probably some calcium, but it's all risk-benefit. He just arrested, so do you really want to embolize thrombus? I think it's a very reasonable concern. But it's important to keep in mind in these acute MIs, these vessels are they're spasm. So this vessel is probably a 4 vessel. And so it's going to be very underexpanded. It's a risk-benefit. As risk as restenosis, I don't think you're going to thrombose this stent, but I think those are the considerations. But it's a tough case, a nice example, but those are my only thoughts in terms of the questions that you asked. But thank you for sharing the case. Very nice case.
Thank you.
Very nice. Case, yeah. So just I wanted to have a lateral view actually. Finally, lateral view would have been a little better to delineate the mid-RCA part. That's what.
Yeah, I think I was a bit too happy to get out of the cath lab because once my patient was crashing, I got a good RCA with the blood pressure which is controlled.
Very nice.
I had a case like this, which I post-dilated, and then I ended up with a no reflow. So that was a lesson for me. So from then onwards, I never post-dilate an acute MI case with thrombosis.
Yeah, many of us
Congratulations.
experiences.
Thank you, sir.
Finally, you saved the life. We should congratulate you. The patient would have been dead without that.
And the patient came in my consultation today. He is so happy, and he is a mason. He is a contractor. And his son is telling me he is taking pockets of cement upstairs now. He is climbing stairs and everything. I told him, wait 2 weeks, he has to wait more, and then he continues his normal activities.
Excellent.
Thank you, Dr. Srinivas and the panel for giving me the opportunity to share. I'll be available whenever you need to present cases. Thank you so much.
Very nice.
That's what gives us happiness as interventional cardiologists, saving patients' lives, and we feel good about it. And now we finished the last session's talks now. Now, Dr. Vijay Kumar also joined. I think he's supposed to chair along with Ajay and Ajit sir. Ajit sir has some issues. He's not able to join. Vijay Kumar sir and Ajay can take over the proceedings now for continuing this imaging session. And the first talk is by Dr. Ziad Ali. Over to you, Ajay.
That's great.
Okay,
and we keep on this link, right? We don't have to switch the links?
Yeah, you need not. I asked them to join here.
Okay. All right. So let me see if everybody is on. Is Ziad ready to go? I don't know. Okay, perfect. All right. Well, I think, this is actually really nice. We were supposed to lead this session off with a live case, But we saw the live case before, and what's great about this when it works out this way is that what you see in the live case, we can then hear explanations of in the talks. And so, we have a great session, great panelists, and great speakers. And we're going to kick this off with Ziad, who's going to talk about a new OCT algorithm called MLD Max.
Thanks, Ajay. Are you guys able to see my shared PowerPoint screen?
Yes.
Okay, so let's get started. So I think one of the problems with imaging in the past has been that it's not being algorithmic or protocolized. Everybody uses it differently. Some people use it pre, some people use it post. And what I wanted to do was try to make something very simple that could be remembered by everybody about what the goals are of imaging-guided PCI. And the title of this talk is Get MLD Max, an algorithmic approach to OCT-guided PCI. So I think what's meaningful is to start with a case. Unfortunately, this is not playing. Just bear with me for 1 second, guys, while I go to a different screen. Okay.
So while he's loading up, I think it's important to mention that the imaging technologies are great, and it's just a matter of simplifying these so that they can be applied to everybody. So
there we go.
There we go. Go ahead, Z. Keep going.
Okay, good. Sorry about that. So we're going to start with a case. This is a patient of mine with multivessel disease. Clearly, there's significant disease in the right coronary. There's a bifurcation lesion in the circumflex and a proximal left anterior descending lesion. As is usual in our lab, for these patients, we take them off the table and consider the benefits of bypass versus PCI. This patient's syntax score ended up to be 22, which where PCI and CABG have been shown to be equivalent, and the patient elected to undergo PCI. So let's think about how we want to do this PCI, and this is title of this slide is OCT Made Easy. We're essentially going to divide the procedure into two separate segments. Pre-PCI, we're going to be looking at the morphology, the length, and the diameter. And post-PCI, we're going to be looking at medial dissection, apposition, and expansion. Why these 6 steps? A, they're simple, and B, they are evidence-based that they make a difference to the patient's outcome. I purposefully won't engage you in the evidence for each one of these steps, but rather provide you a very technical and practical approach to apply this in your cases immediately. And this concept is known as MLD Max. So setting up an OCT-guided PCI can seem daunting or seem to take a lot of time, but actually this is very easy. You essentially connect the syringe that comes with the box. You flush the catheter with whatever flush you normally have, whether it's saline, and you're doing a saline injection, but for the vast majority, it will be contrast to maintain the same flush media that goes in the artery goes into the catheter. You then purge the catheter, as you just saw, and you ask your assistant to drape the dock. Please don't hold the catheter from this black tube, which has $100,000 of fiber optics in it. And then you connect the catheter, and what you'll see is all the steps are quite simply displayed on the screen itself, and that's how long it takes to set up. Once you've actually set up, there are 4 things to do prior to you actually acquiring the image: positioning the catheter distal to the lesion, purging the catheter lumen. That means to get blood out of the inside of the catheter that may have accumulated as you pushed it through the guide and into the artery. Puffing to evaluate the clearance. That's to make sure your guide is engaged and you'll actually get a good picture, and then performing a pullback, as you can see here. So what you can see in the last sort of 90 seconds is that it is not difficult or time-consuming to perform an OCT-guided PCI. There are 2 pullback types. We touched on this on Ronnie's case. There's a survey mode, which should be used in the vast majority of cases, and the benefit of this is that you get a lot more artery than you do with the high resolution. It's also faster, which means you use less contrast, which is a little counterintuitive. But the take-home message is you should be using survey mode acquisition for the vast majority of your pullbacks. The proximal vessel is missed in the high-resolution acquisition because it is a shorter run but of higher resolution. What are the clinical utility of these situations was shown beautifully today by Ronnie. For bifurcation recrossing in complex cases to know exactly where your wire is passing through the bifurcation, whether it's the proximal or distal cell, and also for assessment of stent fracture. This is the user interface that you'll have on your OCT system. On the top left-hand corner, you'll see the angiogram. The angiogram is co-registered in 3 places. This white bar, which is provided on the OCT, co-registers to this cross-section, and also on the longitudinal on this white and yellow and blue line. That means you're looking at the artery in sort of 3 different planes at the same time, so sort of true tri-registration. The OCT provides you automatic measurements. This is the difference between OCT and IVUS. The reason it can provide you automatic measurements is that the lumen is very dark, but the wall is very bright, so it's easy for the computer to determine this. The OCT has the L mode and lumen profile, which is critically important. We're going to talk a lot more about the lumen profile. And we have all of the usual features of what you would see on IVUS, including being able to measure area, length. And I think an important feature that you should understand is the zoom out feature. When OCT first started, we were only able to image sort of 2.25 to 3.5 millimeter vessels, and we're now commonly doing left mains, and colleagues of mine are doing the superficial femoral artery and the carotid arteries. Okay, so let's start our case. We're in the pre-PCI zone. We want to look at the morphology, length, and the diameter. That's the goal. We're starting the case. It's 12:30. So let's recap morphology. This is the human right coronary artery. And what you'll see on the innermost layer of the artery is this structure called the intima. The intima feels like a hard sponge, something like your dish sponge that you'd wash your dishes with when it hardens after being out of the water. That's what the intima feels like. Just inside of this is this sort of banded appearance. This is the internal elastic lamina. It is indeed a rubber band made of elastin and feels and behaves like a rubber band. Outside of this is the media. The media is sort of like a soft rope, something where you have sort of 3 tines in a rope that you can separate easily. This is why when you're doing CTO PCI, the knuckle will travel in specific spaces such as the media and not leave the external or internal elastic lamina. It's very easy to split the media. Outside of that is the external elastic lamina or your second rubber band, and finally on the outside is this adventitia, which we like to consider as the mesh. So why is it important to analogize these common structures? And the reason is because you're able to see all of these structures on the OCT with explicit detail. The innermost layer, which is bright orange, is in fact the hard sponge. Outside of that is this darker black line, which is the media, and we call that the rope. And then outside of that is this mesh-type material, which we call the adventitia. Why are those things important? Because they form the fundamental basis for how to interpret your OCT image. If you are able to see that rope, the media, and the adventitia or mesh anywhere along the artery in any segment of the cross-section, the artery is either normal or fibrous. That's important because you can very safely land your stent into normal artery or fibrous plaque. If in any segment of the cross-section you are unable to see the rope or the mesh, there is a pathology. And the signal change, you need to then determine whether it's in the lumen or the wall. If you see a signal change that's occupying the lumen and all of the light is being absorbed, meaning this infrared light, which is what OCT is being absorbed, then that object is high attenuation. And that means it's got to be red thrombus. In the lumen, if you see low attenuation where the light is refracted but not completely absorbed, it's white thrombus. And when you have the same process within the wall, when you have complete high attenuation, this is lipid. And when it's low attenuation and you're still able to see behind it, this is calcification. If you're ever not sure whether something is low or high attenuation, if you can draw an outline around the signal change, that is a low attenuation signal. Let's spend just a second more on this because it's critically important to image interpretation. Let's take this analogy where we have a flashlight and a floating bowling ball. So here's a floating bowling ball that's black. We shine the flashlight onto it. Naturally, everything that's behind that bowling ball you cannot see. This is high attenuation. On the contrary, if we take a crystal ball and shine it in front of this flashlight, the light will hit the crystal ball and refract, which means we'll be able to see behind it, but it will not be completely clear. So when you have no attenuation at all, and you're able to see the mesh and the rope, the artery is either normal, as in this case, or it's fibrous, as in this case. Here you can see some pathological intimal thickening, but you'll notice that there's no signal attenuation. You're able to see the mesh and the rope all the way around the artery. But in this situation, you are able to see this mesh and a rope from about 12 o'clock to 8 o'clock, but from 8 to 12, you really can't see anything. There's complete signal attenuation. This is the floating bowling ball. This is lipid because it's in the wall. When you see something where you have light being refracted, where you can see behind a highly well-demarcated object in the wall, sort of like somebody punched something out with a cookie cutter, this is low attenuation, this is calcification. On the same token, when you have complete attenuation within the lumen, this is red thrombus, and when you have low attenuation within the lumen and you can see behind the structure, this is white thrombus. Why does it matter if you're white or red thrombus? White thrombus is organized, very difficult to aspirate, and usually needs to be stented or ballooned to move it out of the way. Why do I tell you this? What does it matter? It matters because the lesion preparation strategy can make your procedure more succinct and more efficient. If you have fibrotic or lipidic lesions, stent expansion is not difficult. But once you start to see this low attenuation cookie cutter type appearance in the coronary artery wall, it starts to become more difficult to expand your stent. And in this situation, more heavy duty vessel preparation is required. Practically speaking, the only type of morphology that's really concerning, where you might get into trouble and get stuck, is severe calcification. One of the advantages of OCT over IVUS is the ability to look also at the thickness of calcification as well as the arc and length. And we came up with this very simple rule to help remember when you need to perform atherectomy or advanced lesion preparation. When your calcium is 0.5 millimeters thick at its thickest section, when it's 5 millimeters or longer in length, and when it's 50% of the vessel arc, certainly 75% of the vessel arc, you will lead to stent under expansion, and one should consider more advanced lesion preparation. Here's an example of such. You'll see that this is more than 50% of the arc. It's clearly more than 0.5 millimeter thick, as based on the 1 millimeter markers on the OCT, and you can trust me that it's longer than 5 millimeters. Here we perform atherectomy. You'll see the atherectomy works in a wire-biased manner and basically shaves down this coronary calcification, and high-pressure balloon dilation then fractures this calcium, allowing you to have complete stent expansion by separating these fractured segments away from each other, providing you a very large luminal gain. So this is how to do OCT-guided morphology assessment in practice. You basically take your marker and quickly scroll through the vessel. You're looking for normal or fibrous edges and severe calcification that's greater than 180 degrees, 0.5 millimeter thick, or 5 millimeter long, the rule of fives. So that's morphology. The next thing you want to know is the length of your lesion. So earlier on, I told you the critical importance of the 3D luminogram, or the automated measures luminogram. Essentially, this is the most expensive coronary angiogram you can get. The reason is it is in fact a CT scan. It's a tomograph of the coronary artery. That means you can look at the artery in every direction without needing to take multiple views. This is a potential advantage of OCT, that you do not need to perform multiple projections, and you can save on contrast by performing a single angiogram if you've identified a target lesion. If you now believe that this is the most accurate angiogram, you then convert to using this indeed as your angiogram. And what you're going to do is scroll your vessel markers from the normal OCT angiogram to a part that's nice and fat, just like you would normally do on angiography, and then look at the cross-section to determine whether or not it's a normal artery. Here you can see mesh and wall all the way around, the rope and the mesh. This is a normal artery distally and a beautiful place to land your stent. We need to do the same thing in the proximal segment of the artery. We scroll out of the vessel wall and look, but here you'll notice that even when we're looking for the best cross-section, there is a segment of heavy lipid, and we realize that about 60% of the artery is normal and 40% is diseased. This may be the best normal segment that we can get prior to the left main. Now we have a small issue. This is 35.2 millimeters, and we don't have a 35.2 millimeter stent. So normally the assessment would be to quickly either jump to a 33 or 38 and then basically place the stent. But remember, your OCT is in fact a ruler. And so what you can do is adjust your more normal segment, in this case the distal reference, and pull it into a commercially available drug-eluting stent size and allow you to perform precision PCI. So thus far, we've learned that we had a lesion that had very little calcification, and the lesion length is 33 millimeters. We also need to know how to do this in practicals. So what we do is scroll into the lesion and then out of the lesion to a normal segment. Again, we scroll into the lesion, and now we're looking in this heavily diseased segment for the best possible place to land. And that's how quickly you can see we're at 35.2 millimeters, and we pull in order to get a precise measurement. So we need a 33 millimeter stent. But we don't know how big right now. So how do we choose our stent diameter? Well, this is the OCT algorithm for choosing stent diameters based on Illumian 3 and Illumian 4, and we've purposely simplified it. If you can see the rope, the external elastic lamina, and measure them at least one quadrant apart from each other, you measure the wall, the rope to the rope. If you can't see the rope in more than one quadrant apart, you use the lumen. When you use the lumen, you upsize your device. When you use the EEL, you downsize your device. This is at the distal reference. You do exactly the same procedure separately at the proximal reference. And what you're doing here is you're deciding on your stent diameter, post-dilation balloon distally, and post-dilation balloon proximally all at the same time. And so let's see how we do this practically, where you remember we've already marked our length. We go ahead and measure the artery wall, which is 3.01 by 3.06. And we know as a result, measurement of EL to EL rounded down is 3 millimeters. So we need a 3 millimeter stent and a 3 millimeter post-dilation balloon. Proximally, for those of you who are comfortable, you can measure the EL, that's 4.3, but some people may not be comfortable making that measurement, in which case we would use the mean lumen diameter at 3.0. So if we were to summarize, at the distal reference, we know we need a 3.0 millimeter stent and post-dilation balloon. And at the proximal reference, if we were to use the EEL, we'd use a 4.0 post-dilation balloon. But if we were used to use the lumen, we would use a 3.5 millimeter balloon. So why is this helpful? Essentially, and I'm glad Sushil's on the call, we're turning this into a TAVR. We have everything that we need before we start. So all of your equipment is in the room at arm's length. You don't have to open it and waste the money, but it's all in your hand. You're going to place a 3.0 by 33 millimeter stent. We're going to direct stent because there's very little calcium. We're going to post-dilate distally with a 3.0 and then post-dilate proximally with a 4.0. And this can make your procedure markedly efficient. So you can see that we've gone ahead and planted our stent. And it's now 13 minutes since we started, including our OCT. And now we're going to be looking for the post-PCI OCT guidance, focusing on medial, not medical dissection, apposition, and expansion. And so one thing you need to know here is that, as shown by Ronnie, the angiographic co-registration can be exquisitely helpful because it allows you to look at the artery from both the inside out and the outside in. And here you can see us scrolling through the artery and identifying the lens marker, which will co-register to your angiogram within a standard deviation of 1 millimeters. So here you've got a long lesion, and you can separately mark on your OCT what size stents you want, and then basically use these markers to implant in a co-registered technique. So it's important to understand there are some fundamental differences between the pre-PCI OCT and the post-PCI OCT user interface. The key feature that you'll see is the stent is now basically pasted in for you, and the OCT will automatically detect the distal stent edge, the proximal stent edge, and the expansion and minimal stent area. So you'll notice we have the normal features. We'll have stent expansion. We have an apposition indicator, which is this white bar. We have the rendered stent, which is the stent obviously within the angiogram. And we have all of our automatic measurements. Again, you don't have to make any measurements themselves. That's the apposition indicator. This is the rendered stent. And as Ronnie showed you earlier, we have advanced features to be able to look very closely at the artery in 3D, all very, very quickly. So you can see that we're a couple of millimeters from the ostium. We don't have any stent struts jailing the circumflex, which was the goal of this procedure. You're also able to look at this and peruse it from the outside to look at the relationship of the stent struts over other branches. You'll notice these red dots on the automated measures. The OCT automatically identifies any branch that is 1.5 millimeters or greater and tags it for you. So let's look at medial dissection. So there are 3 different types of dissections which you need to understand. The first is an intimal dissection, where the dissection tears into the hard sponge, which we talked about before. These are very, very safe. The reason is it is impossible for blood to penetrate in an intimal dissection to the media, and as a result, it is impossible to get an intramural hematoma. These almost always heal. However, when you have a tear of the intima that reaches the medial artery wall, it is easier for blood to track in this space and create an intramural hematoma. Our recommendation is that when you have a dissection that's greater than 1 quadrant in arc from the center of the vessel and penetrates the medial layer, particularly distally, that you consider additional drug-eluting stent implantations to tack that dissection. Here's how easy it is to look for dissection, because OCT automatically identifies the edges. You basically grab your edge and take a very quick look, and you want to see whether it's greater than 90 degrees and penetrates the media. And while we do penetrate the media in this situation, you'll notice that it's really a very short dissection and proximal, so we can manage it conservatively. The next thing to look at is apposition. It's important to understand the difference between expansion and malapposition. Quite simply, if the stent struts are in contact with the artery wall, the stent is touching the wall, the stent is opposed. And we recommend dilation with a semi-compliant balloon at low atmospheres when you have proximal malapposition that may interfere with rewiring, or gross malapposition for long segments greater than 3 millimeters identified on your automated malapposition indicator. Earlier, I mentioned to you that there is a bar that's present on the OCT which automatically identifies malapposition. You can determine the malapposition parameters. You can see that less than 200 is in white, greater than 300 is in red, and intermediate would be in yellow. And so here you can see in multiple different planes. On the angiogram, there's malapposition. On the cross-section, there's malapposition. And in the proximal vessel segment and automated lumen measurement, as well as the rendered stent, there is malapposition. This should be treated with a semi-compliant short balloon. What is the consequence of not paying attention to malapposition? Situations like this. Here, the operator lost the wire, rewired what they thought was the normal reference lumen. The wire went in and out of the stent, and now you can see that the proximal segment of the stent is crushed up against the wall, and the malapposition has a direct consequence for the patient. Finally, we're going to move on to expansion. Please understand the difference between the malapposition and expansion. If the stent is expanding the lumen, holding the lesion close to or greater than the normal reference segment, the stent is expanded. This is a beautiful example of a completely opposed stent. All of the stent is touching the artery wall. However, the reference vessel is considerably larger than the stented segment. So this stent is grossly underexpanded, but completely opposed. And we would strongly recommend post-dilation with a non-compliant balloon at high atmospheric pressures when the minimal stent area is less than 90%, here it's 52%, and at least to achieve 80% as an acceptable goal. There are multiple ways to determine expansion. We are moving towards this method called the tapered reference. What the tapered reference does is it allows the OCT to automatically determine how big you should be based on the number of branches and the understanding that the artery naturally tapers in human health. So here you can see the display of automatic taper expansion. You see that the white bar shows that we're greater than 90% expanded. And right in the middle, you'll see segments of yellow where we are underexpanded. And you'll notice that this is between 80 and 90%, and the expansion is automated here at 87%. Remember, the OCT automatically detects your region of interest. It automatically displays your stent expansion. So how do we use this information? Earlier, you remember we post-dilated based on some key data that we determined early on. But 40% of the time on your post-PCI OCT, the artery will grow. And that's because the distal vessel is now seeing blood for the first time, and this is flow-mediated dilatation. We now use the same algorithm on the post-PCI OCT. If you're able to see the external elastic lamina or the rope, at least one quadrant apart from each other, then we use that to determine the vessel diameter. If the EL can be visualized, we round down to the nearest balloon size. If not, we use a lumen and round up. And you can see in this situation where we've now remeasured the artery where it was previously 3.04, the artery has grown by 1/4 millimeter because it's now got blood flow, and thus we'll be using a 3.25 millimeter balloon for post-dilation. Because the OCT can mark exactly where your underexpansion is, you basically place your marker on that and do a targeted post-dilation at the area of underexpansion. And what you can see is by performing that targeted dilation, you can eliminate that segment of underexpansion and now get to the situation where your stent is 100% expanded. So this is all targeted and precision PCI. So what you'll probably also notice is it took me longer to talk to you about this and to actually do it. It need not take long to follow these important steps. You can see in the pre-PCI, we used morphology, length, and diameter. In the post-PCI, we looked for medial dissections, apposition, and expansion. And this is the goal of optimal PCI. Thank you very much.
Yeah, that was great. I think, as you said, when Ziad talks about high pressure non-compliant, what we're really talking about is 1-to-1 size balloons at basically, pressures that can be, at least 18 millimeters of mercury and even higher. So we'll often go to 22 millimeters, 24 millimeters of mercury, but you do that because you're comfortable because of the sizing. The second thing, maybe a comment about the Indian population specifically, with lots of diffuse disease. There is a tendency to rely more upon the lumen measurements because, especially if it's lipidic plaque, you can't see the EEL. In those cases, do you think that perhaps we ought to, not round down so assiduously, but kind of try to round up a little bit more? How do you look into that? Instead of rounding up a little bit, maybe round up a little bit more because it's hard to actually see sometimes.
So great question, Ajay. We used the Illumian 3 data to determine what was safe. In Illumian 3, we actually rounded down from the lumen as well, but we realized that led to significantly underexpanded stents. So there's two inbuilt advantages to using the lumen and rounding up. One, if you have such diffusely diseased vessel, you really can't land the edges of the stent into normal tissue. And so if you oversize too much, you're at significant risk of developing an edge dissection and sort of chasing your tail. But at the distal reference, we typically say rounding up to the closest size. But if you saw on the algorithm slides, when you're at the proximal reference, we actually say between 1/4 to 1/2 millimeter. We actually know that the difference between the lumen and the EL at the distal reference, mean difference is 0.67 millimeters, and the proximal reference, the mean difference is actually 0.97 millimeters. So, and when we look at the ranges of those, we think that using 1/4 size up distally and up to 1/2 a size up proximally is actually very safe.
I think great points. And also remember to look again at the end, because if you get better flow, it may be bigger. And that way, especially with diffuse disease, you can try to get an optimal result. Any other questions, or should we move to the next talk?
Yeah, I think excellent talk, Ziad. As such, imaging compared to iOS, many of us feel it is simpler. You try to make it more simpler and more user-friendly, operator-friendly, and so that more users can adapt it. Thanks for making it like that. We'll go to the next talk, how I incorporated OCT in my practice, Dr. Deepak Davidson. As you understand, many of our labs are just getting into this imaging. Abbott is doing a wonderful job by making it more available, and also helps us in doing the technology training and sends people to labs. So let us hear from Dr. Deepak Davidson how he incorporated OCT in his practice. Over to you, Dr. Deepak. You can see your slides.
Good evening to all of you. It's indeed my pleasant privilege to be with you all this evening. I bring greetings to you all from the southernmost part of our country, the God's own country, the smallest state, Kerala. Let me take this opportunity to thank Dr. Srinivas Kumar for having given this opportunity. And over the next 12 minutes, I shall share with you how OCT helps me in coronary interventions. Now, these are the areas wherein I would like to go through. It helps me to do a perfect angioplasty, helps me to do a precision angioplasty when I'm in dire straits. OCT helps me out when I'm lost. OCT helps me out. It helps me in decision making, identification of complications, and it also makes me improvise my techniques in coronary interventions. I'll start with the case history of a 35-year-old priest who presented with an influval myocardial infarction to a nearby center. He had an occluded right coronary artery. You could see that he underwent angioplasty for the right coronary artery. It was a 2.75 millimeter stent that was implanted in the right coronary artery with a reasonably good flow in the vessel, and I was happy seeing this result. However, the next day, this particular patient, he developed complete heart block chest pain. He was intubated. He was taken to the cath lab. You could see that the stent has got totally occluded in the proximal segment. They tried to wire it. They were easy. It was easy for them to wire the lesion, but then it was not possible for them to get this balloon across the stent for dilatation. Now they tried multiple times, and ultimately he ended up having a thrombolytic therapy, and then he was referred to us. You could see that there is TB3 flow at the end of the day, and following that he was intubated and he was referred to our center. And this was the first angiographic image that we took on that day. You could see that the vessel is flowing well. However, you could see that there is something rugged in the proximal portion of the vessel. We started off with an optical coherence tomographic imaging. You could see in the cross-sectional image that the stent is crushed in the proximal portion. You could see that it's free floating in the mid portion of the vessel. As you scan through the longitudinal image, you could see that the struts are all lying, it's floating on the vessel, inside the vessel. So you could easily understand that it was probably a malposition to start with, and following that, when they tried to rewire it, the wire would have gone beyond the stent, between the vessel wall and the stent, and then that was the reason why they were not. As you scan through the longitudinal image, you could see that the struts are all lying, it's floating on the vessel, inside the vessel. So you could easily understand that it was probably a malposition to start with, and following that, when they tried to rewire it, the wire would have gone beyond the stent, between the vessel wall and the stent, and then that was the reason why they were why they were not able to do that. So we know that the reason for stent failure in this particular situation was it was just a malposition and the stent was not opposed to the vessel wall, and that was the reason why he developed a stent thrombosis. So it is easy for us to manage this particular patient. We had to implant a second stent in the proximal portion and dilate the stent in the rest of the portion, and we did multiple dilatation with much bigger balloons, 3.5 millimeter balloons. Those are the 3.5 millimeter balloon dilatations, and proximally we dilated with a 4 millimeter balloon. And following post dilatations, we did a OCT run. Again, we were surprised to see that you could see that the stent is not well opposed to the vessel wall. It's still free floating in the proximal portion of the vessel. So we had to again go with a 4.5 millimeter balloon proximally and then post dilated. And finally, we were able to achieve a good results. Now, we were happy at the end of the day that a 2.75 millimeter stent was implanted in the stent, and that led to stent thrombosis. We were able to make out that the stent was not opposed well. We post dilated it. Again, the OCT made us aware that we were not touching onto the vessel wall. Again, we went ahead with the 4.5 millimeter balloon, and finally we could achieve a good flow and good result, hoping that this particular patient would do well in the long run. This was another patient who had a stent implantation 3 years ago, present with acute anterior myocardial infarction. You could see that we wired the lesion, we did thrombosection, and following thrombosection, that was a sort of image that we could see. Normally what we would have done is we would have dilated there and we would have deployed a second stent in the distal portion of the first stent. But however, as we did optical coherence tomography, what we understood was, again, as seen in the first case, you could see in the longitudinal as well as the cross-sectional view that the stent is free-floating in the vessel wall. There is only very minimal neointima formation. As well, you could also see in this particular second image that the stent is underexpanded. The MSA was only 4.13 millimeter in the proximal left angiodescending artery, which is totally inadequate for us. So finally, we thought of not putting in a second stent. We just ended up doing further post dilatations with bigger balloons, and finally we were able to achieve a good result in this particular patient. But for this particular imaging modality, probably we would have gone ahead with a stent implantation in the distal portion of the stented segment. Now, OCT also helps us in precision angioplasty, as mentioned by Dr. Ziad. You could see that this particular patient, 72 years, LV dysfunction, acute coronary syndrome, a left main bifurcation disease, and a dominant circumflex artery. We wired both the vessels, LAD and the circumflex. We dilated both the vessels and we stented the left main into the circumflex because the circumflex was a dominant vessel. That is a 4 millimeter stent, and following stenting, now the next thing that we need to do is we wire into the left angiodescending artery. While wiring, we need to keep in mind that it's always good to go through the distal strut as mentioned by the speakers earlier, and this would definitely help us for a proper scaffolding of the ostium in the side branch. So that's what we need to try to achieve. And how does OCT help us? It will identify where exactly the wire has gone in, whether it has gone through the distal cell or the proximal cell. If you look at the longitudinal image, you could see that the wire has gone through the distal cell. There are two cells seen clearly there, and the wire has gone through the most distal cell into the left angiodescending artery, and this could also be identified with the help of the 3D image of the bifurcation. You could see here that the wire has gone through the distal cell. You could see multiple proximal cells as well as distal cell. The wire has gone through the distal cell, and following that, we could do a precision angioplasty. Tap stenting was done, the balloons were pulled back, further kissing was done, port was done, and finally we were able to achieve a good flow in the left angiodescending artery as well as the circumflex artery. Now, OCT also helps me out when I'm in dire straits. You could see that this is a left main trifurcation stenosis. Because the circumflex ostium was looking good, we considered it as a bifurcation stenosis and started doing an angioplasty for the LAD as well as ramus, and we decided on DK crush technique in this particular patient. So we wired LAD, we wired the ramus intermedius, pre-dilated and stented the ramus, and following stenting of ramus, we removed the balloon wire, crushed the ramus stent, crossed through the proximal struts, did a kissing balloon dilatation, then stented the left main way into the left angiodescending artery, and then following that did a proximal optimization. And following proximal optimization, we tried to recross through the proximal cells, which was recommended way back in 2018. So we went through the proximal cells into the ramus branch. The challenge there beyond that was we were not able to track any of the balloons into the ramus. Now, so because we were not able to track any of the balloons into the ramus, we tried to do an OCT to image what exactly was happening there at that point of time. You could see here that the wire has gone through the eccentric cell over there. You could see here that there are good cells low down there. However, the wire has gone to a very eccentric cell, very proximally, but then it was an eccentric cell, and that was the reason why the balloon was not tracking through the small cell through which the wire has gone in. Finally, we had to take another wire and rewire the ramus intermediates, and then following that, we were able to do the kissing balloon dilatations, proximal optimizations, and then the final result like that. Now, this is how an OCT would help us when we are in dire straits. Now, it also helps me out when I'm in a loss situation. This was a patient who presented with a acute coronary syndrome, a tight critical LED lesion, balloon dilated and stented the proximal portion. And following the stent implantation, we could achieve a perfect flow in the left-hand descending artery and as well as the diagonal branches. However, we wanted to post-dilate it, and that's a post-dilatation being done. In the second image, you could see that following the post-dilatation, there is some haziness at the roof of the left knee. You could see that it looks like a dissection. It was persisting for some time. We were not sure what exactly was happening there, whether we need to go ahead and stent the left knee. We were not sure. We went ahead with an IVUS evaluation because we were hesitant to do a OCT evaluation because it seemed like a dissection. We might extend the dissection. So IVUS evaluation did not give us any information at all. So we went ahead with an OCT evaluation. You could see in this frame that the LED stent has landed exactly at the ostium, the left antidescending artery. And in this image, you could see that there is an intramural hematoma at the proximal portion of the left antidescending artery inside the stented segment. And if you could carefully see this cross-sectional image, as I'm scrolling from the distal LED into the proximal LED at 4 o'clock position, you can see there that there is a dissection inside the stent, and the hematoma is seeping into the vessel wall from the stented segment into the wall, which is extending proximally. You could see here that as we are reaching the left main, this particular hematoma is actually coming way back into the left main. Now, so the origin was in the proximal left antidescending artery, and it's actually seen seeping into the left main bifurcation, and this was the reason why we had some haziness that was seen at the left main bifurcation. So finally, the reason for this particular problem was we went back and saw that as we did the post dilatation, there was a rupture of the wet balloon, and this rupture finally led to a small dissection, and the pinhole rupture led to contrast extravasation into the intramural space, and that was tracking back into the left main. So finally, we did not do anything for that. We waited for some more time, and that seemed to settle down, and so we stopped doing anything for that. We did not stent the left main. Now, the next situation where an OCT would help us would be in decision making. Like in this particular patient, he had an angioplasty for the left antidescending artery almost 3 years ago. Now he presented with pulmonary edema. He has a left main bifurcation stenosis with a very critical ostial circumflex stenosis there. Now, you could also see here that the stent is extending well into the left main. It's actually free floating inside the left main, as you see in this particular cartoon. Now, the challenge here was what exactly do we need to do for this circumflex ostium management, for this bifurcation management? Should I go through the side of the, should I go through the struts of the cell and convert it into a mini culotte, or should I go through the side of the stent into the circumflex artery with a wire like what is seen in this green image, and then convert into a crush technique, a DK crush technique? So what should be the strategy like? So prior to that, we did the imaging, and we made out that that's how the imaging would look like. You could see here that in the longitudinal image, the stent is floating inside the left main. It's not touching the vessel wall. You could also see that there is a lot of new intima inside the cell that is inside the stent that's floating inside the left main. And you could also see here that those are the frozen images of the new intima that's formed over the floating cells. And this is the image that shows us that the wire that we tried to go into the circumflex artery from the left main. So our plan was to go into the circumflex artery through the stent cells and convert it into a mini culotte. The reason for that was we felt that if we try to crush it, this new intima might occlude the left antidescending artery ostium. So that was the reason we decided that we would convert it into a mini culotte technique. You could see here in the OCT that the wire has gone through the initial stent and then through the stent cells into the side branch. And then further, it was much more easier for us to manage. We dilated it, we stented it from the left main into the circumflex artery, did kissing balloon dilatation, proximal optimization, and then we were able to achieve a good flow in the left-hand descending artery as well as circumflex artery, and we could also see in the OCT images that we could achieve a good-looking carina. The ostium, the circumflex was looking good, as well as the left anterior descending artery also was looking good. I think I'll stop with this case alone. This was a patient who presented with effort angina. He had undergone angioplasty to the proximal LAD long back. You could see in the second image that there is significant amount of calcification at the site of critical stenosis of the left anterior descending artery. We were working with a 7 French guide through the radial approach, and then we did a rotablation with a 1.5 millimeter burr, and that's a rotablation being done at 180,000 RPM with a rotabur, a 7 French guide catheter. And following that, we tried to dilate it. It was at 24 atmospheres with a non-compliant balloon, 26 atmospheres with a non-compliant balloon. We were not able to open the lesion. So that was the reason why we went ahead and did imaging of that particular vessel. You could see that there was significant calcification. You could see that at areas the calcification was almost 1 millimeter in thickness. We heard from Dr. Siad that anything 0.5 millimeter extending for 5 millimeter length, it's going to be a trouble for us. So finally, what we understood from this OCT was it was a significant amount of signature calcium. So we decided on going with a OPN balloon at 40 atmosphere. We were able to open the lesion with an OPN balloon, and finally we were able to again do an OCT imaging wherein we found out that there were a lot of fractures in the calcification over there. Even it was more than 500 microns in thickness. It was all fractured by the OPN balloon, and finally you could see that we could deploy a stent, and we were able to achieve a good flow in the left-hand descending artery. So based on all these cases, I hope you understood that OCT would help us to get our percutaneous intervention done in a better way. And I'll stop with that. I'll avoid continuing with the next presentations. Thank you so much.
Thanks so much. That was a fantastic talk with covering a lot of different areas and a lot of different scenarios, but illustrating how these things can work. I will tell you that you have to be really good and doing it a lot to be able to interpret these images the way you have interpreted them so well. And so sometimes people get frustrated, and I've seen people who sort of in the beginning, they say, oh, I'm only going to use the OCT when there's a difficult issue. If you do it that way, you don't know what you're looking at. So if you use it more frequently, then you can do the type of things that you've done. So thanks so much for showing it.
I think, thank you, Ajay. COVID is making us do wonderful things, it looks. You are educating as well as exercising. It looks great.
Yeah. That's common for Columbia staff.
Okay, great.
I'm about to go upstairs.
So please stay till this session is over, Ziad, because we need, because I had some...
I'll be there. I'll just be on the treadmill at the same time.
Yeah. Okay. Then we'll go on to the next talk, Advancements of PCI in Calcified Lesions, guided by OCT, by Dr. Balbir Singh. Dr. Balbir is one of the senior consultants here, and has a lot of expertise in OCT. He started advocating OCT very strongly, and you'll show some very good, extremely good case examples, which angiogram looks the same, but OCT gives us a lot of different images. I think we are eager to hear you, Dr. Balbir. Please, over to you. I think he's logged in. Yeah. Go ahead, Dr. Balbir. Yeah, please go ahead.
Dr. Srinivas, can you see my slides?
Yeah, we can see it. Go ahead, sir.
Right. So my task has actually become much simpler after Ziad's talk on basics of OCT and how calcification looks like. So if we understand calcium is the biggest enemy for interventionists, and all of us we agree, but can imaging help us get over this is the question. So if we look at how calcium can influence PCI, we look at these images, we look at instant restenosis. What happened here was a post-dilatation balloon. You don't want to see this. This is horrible. Now you have nothing to do. You may say, oh, you can use an OPN balloon, but they can't do it. And what you end up is this kind of result. What you missed was this big chunk of calcium just behind the stent. You can see a huge chunk of calcium, which was missed at the first intervention. This is another miserable situation that you have stented, again a calcific area, and achieved just a stent area of 2.1 with adjacent area of a stent area of 7.7. You will be in serious trouble. So if you can see, if you can predict that this lesion is going to give me trouble, you could potentially have a favorable outcome. So calcification can be superficial, as in this diagram, and Ziad very clearly pointed out what high attenuation and low attenuation means. That if you can draw a line around that area, it is calcium and not lipid. So clearly you can see this calcium here, and you see a nodular calcium here. So calcium nodule. Let's look at an example of a 60 years old lady, angina class 3, diabetic, PCI to LAD, which was patent stents, both of them, and now comes with RCA disease. Now, everybody will say that you fluoroscopically, you can see so much calcium. So what is the big deal? OCT is going to help us look at this. So we don't need to see OCT because you see so much calcium. But let's see the OCT images. So first, we took a 2.2 millimeter balloon, dilated it, and so look at this expansion of this 2 millimeter balloon, hardly expanding. And then we pushed in an OCT probe to look at the morphology of this lesion. And this is how it looks like. So there's some dissection areas. Now look at this calcium, circumferential 360 degree and very thick layers of calcium. Now would this, many people would have said we saw so much calcium, a rotablator is going to help. But how is a rotablator going to help in a big vessel with calcium to the degree that you see? So this is the pre-OCT analysis showing you a normal area. So this, as Ziad pointed out very clearly, is the landing zone. This is the arc of calcium, 360 degree. This is a thick layer of calcium, hardly any lumen area there, very thick calcium and very thick intima. So then you find the landing zone proximally. So you understand clearly where you have to start, where you have to end. And this is also very important. Now, looking at these layers and sheets of calcium, looking at this diagram, we know how we have to treat. So we straight away know from this diagram that if you have a large arc of calcium, if you have large thickness and large length, this patient has all these points. So if you have 1 point here, 2 points here, and 1 point here, you have 4 points. You have very high chance of underexpansion. With that in mind, this patient, we calculated the length, and length came as 54 millimeters. And we took an IVL balloon and based out of the sizing that we had done. So the proximally, the vessel was 4 millimeter and distally 3.5. This is an IVL balloon at 4 atmospheres. And you can see it opened. So the entire region, an IVL balloon was used. And this is the IVL balloon, 3.5. After that, we did a OCT run to look at the cracks with the IVL balloon. You would see this is a crack there, this one, the clear crack with the lithotripsy balloon. And this is at the point where you can see 2 more cracks there. And after that, we took in a high pressure balloon dilatation with a 3.5 Ho balloon, then took 2 stents, one 3.5 distally and a 4 proximally, and then post dilated with 3.5 and 4 millimeter balloons. This is the first stent, then the second stent, and after the stents, and again 3.5 and 4 millimeter balloon dilatations. This is the end result, but this is the OCT result that you see here. So there were areas of underexpansion. It wasn't 56% as it shows, but we couldn't get to a perfection in this case, despite whatever we did, IVL, despite that. But the lumen areas at many places was between 7 and 8. At one point, it was 5.86, which was not happy, but we tried very high pressure dilatations, couldn't do it any better. So this is, you can see that planning so well, choosing right diameters, we have no malopposition, reasonably good expansion. I won't say perfect expansion. It was really impossible to get the perfect 80% or 80 to 90% at areas. There were very small areas which we did not get it. But this is how we proceeded in this patient. I will show you the final angiographic results. So this looked good, and the patient has done well in the last 3 months that we have followed up. So if we look at the expansion, reasonably good on eyeballing, but I would agree this is an area 10.3 proximally where we had dilated with a 4-hour balloon, 8.68. So reasonably good, but I said some of the areas were not perfection. Like this area is not perfection at all. Despite doing so much, so many balloons, did not think that I could have done more than this. So this tells you how difficult it is to treat calcium, despite being ready with everything, despite imaging, high pressure balloon and everything. So how does a calcified nodule behave on OCT? Let's look at an angiographic picture. So this is how a calcium nodule looks like. So it is angioscopic picture. You see a chunk of calcium protruding into the vessel. So what is the problem that happens? First, it obstructs the lumen, so there's luminal narrowing because of calcium nodule. Second, on top of that, there could be fissuring between the calcium layers. There could be some normal areas and an acute MI. So this is what calcium nodule does, is defined as a cluster of calcium nodular protruding into the lumen wall with or without disruption of the wall and thrombi. So it is observed in 2 to 4% of lesions, usually in the ostial RCA or mid-RCA, more common in CKD with hemodialysis, associated with additional arc of calcium which we close by. So this is how a calcium nodule looks like. This is after atherectomy, and this is post-ES. So you have to be prepared for such cases, identifying a calcium nodule, looking at the thrombi, and trying to treat it as well as you can. So this is an algorithm which is basically helpful but not perfect. You can see the deciding factor is the calcium arc, the calcium length, and the thickness. In this study, more than 270 degree was given 3 points. The previous study had given it 2 points, so it has up to 5 points. So if there is 1 to 2 points, high pressure or very high pressure balloons could result in a good result. With 3 to 4 or 5 points, you could use lithotripsy. If lithotripsy balloon doesn't cause rotablator followed by balloon dilatation. Or if you do not get optimal balloon expansion, go back to lithotripsy. Stent, OCT, and IVUS optimization is essential in calcium-related lesions. So my showing of that case was that despite planning, despite using lithotripsy, despite using high-pressure balloons, perfect sizing, we still had a small segment which was not to our happiness, despite my trying several times with the balloon there. So calcium nodule has another problem of fissuring and causing thrombi formation on top of it. And you could see that calcium nodules can occur in many places, but ACS is a common presentation in many of these calcified nodules. So we have heard stories of patient presenting with acute MI, lesion was crossed, but the balloon didn't grow, and had to resort to rotablator or cancelling the whole procedure, just opening and restoring flow is because of many calcium nodules which rupture and cause ACS or MI. This is an example of a circumflex lesion. You can see heavy calcium in this area. It doesn't look like very bad, but if let's look at this OCT image, you will appreciate a nodule coming out in this area and thick layers of calcium, and see this nodule which comes out. So calcium nodule can cause fissuring and thrombosis. I will go to last case before we. So this is a right coronary artery, and these are the pictures. This is a RCA. Fluoroscopically, not much calcium. However, we were not able to cross with the balloon. This is what it was, not much calcium. We chose to take a right guiding, but then it didn't cross. We took a Guidezilla. The balloon still didn't cross. Took a rotablator, 1.5 bar, was able to cross, and then an OCT image. So this is after we've done ROTA of this. So you can see a calcium nodule which has been cut by the ROTA ablator, and also a very thick layer of calcium. So in patients who have calcium nodules also tend to have arcs of calcium and also have thick layers of calcium. And this, fortunately, we were able to do a good dilatation and a very well opposed stent. Again, a 4 millimeter stent was used with a 4 millimeter balloon, which vessel looked like 3.5. After balloon dilatation, you would see this is the image. This is the image that you get on OCT. This is the expansion of the stent, which was quite good. So this is what we expect to see if we plan and do very well these cases of calcium. OCT is the greatest tool that we have to detect calcium and to plan our strategy. Thank you very much for your attention, and I tried to finish on time. Thank you, Dr. Srinivas.
Thank you, Balbir, for finishing on time. And as we are slightly behind the schedule, and Dr. Ajay also has other commitments because it's Saturday for them morning, we can enjoy a little more because it's evening time for us. And then I requested him anyway. He agreed to deliver his talk after Dr. Selvamani's talk. Role of OCT in stent failure and ISR. We have seen very good pictures of instant restenosis from Selvamani before. I thought it is a greater audience, bigger one to benefit from it. We'll see good pictures of ISR from Dr. Selvamani. Can you join Dr. Selvamani here? And they do extremely good work in the south, Jayad, again from a lot of things are being done more and more aggressively down south in be it the primary PCI section or in the imaging. They have a lot of experience in their hospital. Dr. Selvamani will share those with us. Thank you. Over to you, Selvamani.
Perfect. We can see your slides. Just unmute.
We can see your slides and go ahead.
The only thing we can't hear you, so you may be on mute.
Yeah, fine. Thank you very much, Srinivas Kumar sir, and then the organizers for calling us here. I come from Madurai, as Srinivas was saying, that the southern part of Tamil Nadu here. And it's easy for me, like after Ziad Ali and Deepak and Balbir sir spoke on this. So I'll try to highlight whatever possible in a very quick way here. See, my topic being stent thrombosis and ISR, it is very important. Like you look at the ESC guidelines. See, this OCT was given a class 2A indication for ISR or probably stent failure right from the beginning. But now it has been upgraded for almost most of the lesions where you can use this. So if possible, I think we should try to make use of this, especially for stent failure. It's a great tool to diagnose and to produce good results. As you know that stent thrombosis, you call it as acute stent thrombosis, subacute, late stent thrombosis, and very late stent thrombosis, depending on the time when it occurs. And keeping this in mind, what are the reasons for stent thrombosis is very, very important. One is patient thing, which we have no other control. But of course, device, we can try to select whichever is the most ideal device. And procedure, that is expansion, apposition, and runout. This is one thing which we have a control where we can produce better results when you use better imaging techniques. So by doing this, probably most of the time we can get rid of this stent thrombosis. And one more thing you should remember is, when it's a very early stent thrombosis, these are some of the reasons like under-expansion, age dissection, residual plaques. And very late reasons are delayed healing and uncovered struts. And very late is probably neoatherosclerosis. This is one of the important reasons where imaging has extensive role, that too with new updates and algorithms. And we have studies which have shown that the main reason for stent thrombosis is being low lumen area. And of course, we have optical OCT studies where they have shown that in subacute, it is basically uncovered struts and under expansion, which is a very important reason. And very late, it's predominantly neoatherosclerosis and uncovered struts here. And by improved deployment, and then of course, once you study patients who come with stent thrombosis, we can treat them extremely well using OCT. So this is an example. This patient, he had an anterior wall MI somewhere in 2018, and he was stented with by a BVS at the time. He comes to us 3 years after the index procedure with again a stent thrombosis of the BVS in the LAD. And this is the angiogram at that time. So he lands up somewhere in the middle of the night, and then this is the angiogram which I have. And there's a BVS here which was deployed 3 years earlier. And he had a BVS in the circumflex also at that time, but that was circumflex was all right. At that time, what I did is I had just done a thrombosection there, and this is what we get. And patient got stabilized there in the middle of the night, like we did not do any imaging, and the patient was also not ready for further treatment. So with this stabilization, he was shifted to the ICU, he got stabilized, and patient came back to me 1 month later. And this is the angiogram 1 month later after this thrombosection. So generally on angiogram, what do you think? Most of the time, this looks like a borderline lesion, and he had an MI for which we did a thrombosection 1 month back. We would have just left it like that. So when I did an imaging for him, when I did a OCT, so this is the OCT run of the circumflex, a 3 years old BVS, and where you see that excellent endothelization and the BVS is very good and well patent. When you see the LAD here, you have a clear-cut reason for a stent thrombosis. There are exposed struts which are not endothelized. It is hanging there right in the lumen there. Probably this was one of the reasons why he had a stent thrombosis. And when you look at this, see here, most of the areas it is endothelized, but in areas, especially in the proximal segment, when you come here, there are struts which are not endothelized and then well exposed here. So that is what passed away there. And there was in almost around 60% area stenosis. Now, whether to stent it or not, it's very difficult, but anyhow, there was uncovered struts and then overhanging struts which were left there, and FFR was positive there. So I went ahead and did a angioplasty stenting there with a regulating stent, a long stent there. Advantage of imaging is here you see that you can document that the struts are well opposed. And I have prepared it well so that you don't produce a sandwich between the previous stent and the new stent. And well exposed stent can be made out, and angiographically it was very good. And this is another patient who came to me with a late stent thrombosis. He had undergone angioplasty elsewhere near Madurai. He visited Madurai, and at that time, this is 1 year post-stenting, he had a stent thrombosis or anterior wall MI again. He was seen in a small hospital nearby, and then he was thrombolized there, and he was sent to me there. He comes to me around 3 to 4 hours after thrombolysis, and this is what is the angiogram. Angiogram is completely, probably it's a recanalized stent thrombosis, and then you see this is the angiogram after thrombolysis in this patient. So generally what we would have done is we would have just put them on medication and sent them home. But when we did the OCT, you see here, what happened is there were areas of neointimal growth, malapposition, as well as under expansion in this patient. So clear-cut areas of malapposition, and there was probably a thrombus there where the endothelium has grown. Probably that was the reason for stent thrombosis. And when you looked at the MLA and the expansion, it was clear under-expanded stent. And what I did is I just post-dilated with the NC balloon and made that apposition well. But of course, I did not treat any under-expansion here because patient was not willing for further stenting there, and produced better results. Probably he will not have a stent thrombosis again, hope so. And imaging gives a clear-cut idea what is the reason for a stent thrombosis. In this case, where Balbir has already highlighted, this patient came with stent thrombosis. When you do an angiogram, there is an area of clear-cut under expansion. So when you angiographically, nothing is seen there. But when you do an OCT, you can demonstrate, see there is a significant calcium in that area, probably which was not recognized, and the patient was just stented like that. So this patient, again, we did a stenting, and after stenting, even if after dilatation with the NC balloon up to 28 atmosphere, we couldn't produce adequate expansion here. And if it was now, probably I would have used a IVL or an OPN balloon. This case was done some time back, some 4 years back. So at that time, with whatever possible NC balloon, we couldn't expand it properly. But we had done an imaging previously itself. Probably we could have treated this very well now. So imaging clearly shows, OCT shows that calcium very clearly, and thickness of the calcium, and we have a calcium scoring now. Keeping that in mind, we can go ahead and treat adequately. And this patient, he had an acute anterior wall MI. The previous night, he underwent primary angioplasty stenting. The next day morning, since it was a primary angioplasty at the middle of the night, no imaging was done. And now he comes back with again stent thrombosis in the same area, reocclusion around 8 to 10 hours after the stenting. So this is the angiogram, how it looks. So we really couldn't make out what was the real reason for his stent thrombosis. So when I did a OCT, there was a clear demonstration that there was areas of malapposition, significant malapposition, and for a significant length also. So in the night, in presence of the thrombus, or probably we have undersized the stent and not dilated properly. And this was the reason probably for a stent thrombosis. Again, what I did is only very simple, just dilated the stent with an adequate sized balloon and produced a good results. And after this, he has not had a problem at all. So without imaging, many times you cannot make out what is the cause for stent thrombosis. And you will have to imagine the reason, probably whether it is under expansion or malapposition or dissection. It's very, very difficult. But in presence of the OCT, you can clearly define what is the reason and treat the patient accordingly. And this is an interesting case. One of my friends was treating this patient, and he had an inferior wall MI for which the circumflex was stented. And he had again a stent thrombosis 5 to 6 hours after the primary index angioplasty. He did thrombosection and he couldn't make out what was the reason for stent thrombosis. And patient being a VIP, he was sent to me for imaging and further workup. So I take up this patient for an angiogram. Angiogram of the circumflex after thrombosection looks completely normal. So I was thinking what to do now. Now when we did a OCT, it clearly shows there is significant distal dissection there, almost major dissection producing a false lumen. And there are areas of malapposition here in this area, clear-cut malapposition. And then areas of under expansion also there. And there was an area of proximal dissection also, which probably I will not put it here. Now look at this. This is the proximal area. When this here also he had a dissection. One single case where imaging clearly demonstrate what was the reason for stent failure here, stent thrombosis. Distal dissection not seen on an angiogram, under expansion, malapposition, and as well as the proximal dissection. And finally, I had to just put a stent there covering the dissection, expand the areas which were under expanded, and oppose the area where it was malapposition. And he is doing now very well. This is almost more than 1.5 to 2 years now. This patient is extremely doing well. And coming to another, as Deepak also showed the similar case, this patient had a stent thrombosis, and then we did not know angio was looking very normal. Look at this OCT here. There is a stent which is opposed to one side, and the opposite side there is nothing there. So when we did a 3D reconstruction, it is a clear-cut stent has been probably when they were rewiring, the wire has been abluminally wired and dilated in this area when they were doing part. Probably the stent has got opposed that to one side. And what we had to do is just put a one stent here and treat it out. So angiographically, you cannot make out what is happening there, but OCT clearly gives what is the exact reason for your stent thrombosis. Coming to instant restenosis, of course, this is angiographic classification. We have this Mehran classification. And you should always know what is the reason for restenosis. Predominant, it is presence of thrombus, underexpansion. Underexpansion is one of the important reasons. And of course, non-overlapping of the stent when we are putting a two-stent edge dissection. And if you land up in a plaque which is more than 50% plaque burden, again, restenosis is high. And these are the causes for, again, instant restenosis. So to make out all this reason, imaging is very, very good. And we have a new algorithm for ISR to treat this algorithm also. For this, it is very, very important. I will just highlight this part there. So OCT or IVUS, predominantly OCT is very, very important. You make out to where the ISR is. And once it is a stent body ISR, you should assess the type of neointima, like whether it is homogeneous, heterogeneous, layered, calcium or lipid. And depending on that, you can treat whether to use a drug-eluting balloon or a drug-eluting stent or whatever. If it is a calcified, use IVL or probably a rotablator, you can take a decision. And at the same time, if it is at the edge or it's an overlapping stent, we can definitely make out, or if there is a stent fracture, clearly OCT tells us that. And this is how you make out whether it is homogeneous, layered, or calcium-rich on a OCT, and you base your therapy for ISR on this. This is a new algorithm, and this is the outcome study which was presented in last TCT also. And this is for multi-layered stents, like we have multiple ISRs, like when they have 2-3 stents. Probably you can use a DEB or brachytherapy. Probably brachy is not available in India. It's done in few centers in US there. And this is an example of an homogeneous stent restenosis there. Look at the intima, look at the growth there. It is completely homogeneous. Usually seen in a bare metal stent, but it can occur in few drug-eluting stents also. And look at the OCT. It is a significant ingrowth, focal growth at this area. Rest of the stent, it is okay. It is a focal ISR with homogeneous morphology. And this patient, what I did is we have treated with a drug-eluting balloon here, plain drug-eluting balloon, and dilated at that area with excellent angiographic result. And OCT post-procedure also is very well there, very well expanded and with adequate lumen gain there. And coming to the next important thing is it's a heterogeneous ISR, multi-layered ISR in a patient in proximal LAD there who had undergone angioplasty almost 1.5 years back with an proximal LAD ISR. And look at the morphology, it is an heterogeneous thing, and naturally we'll have to put a drug-eluting stent to treat this patient. And while doing that, one important point is you should try to attain the maximum lumen gain before you take a new stent. To know that imaging is very, very important. You can use a cutting balloon, scoring balloon, use whatever device you have. And one important thing is before you take a new stent, you do a imaging so that you know that you have gained an adequate lumen. If you don't do that, many times angiographically you cannot make out what is the lumen gain because it gives a similar effect whether the lumen is gained or not. If you put a second stent before that, you will produce a sandwich. That is, there will be a big neointimal growth or material in between the previous stent and the new stent, and you will not get an adequate MSA after that. So to do that, to achieve a better result, use imaging, use OCT, make sure that you have attained an adequate lumen gain before you take a second stent and go ahead with your procedure. See here.
I think, Selva, you can go on till tomorrow morning also. You have excellent cases. Thanks for showing a lot of them. Can we have your last thing?
Plain with, with, just plain with angiographically, it is very, very difficult. You will have to go with imaging guidance to produce this excellent result. And to conclude, you know that the cause of free stenosis, you keep it in mind to make out all this. Yeah, OCT is extremely helpful. And again, to treat, to make out whether it is homogeneous or heterogeneous, whether to use DEB or DES, OCT is extremely very, very important. And it is recommended today, if possible, for all stent failures, it is ideal you do an OCT imaging. And as I already told you, in the new algorithm, OCT is important to treat ISR, depending on the type of neointimal growth what we have. Thank you very much.
Thank you, Selva, for showing excellent cases. I think you have a lot of collection. Thanks for that. And you have a lot of information. A lot of us, we get confused how to tackle this instant restenosis problem. Sometimes doing drug-eluting balloon, sometimes stent. Obviously, you showed the algorithm, but many more information is also coming up. Recently, we reviewed one CCA article where they said if more than 50% of the plaque, residual plaque is persisting, stent will benefit. Otherwise, you could do only by drug-eluting balloon. So many more things are happening, and this makes it very clear. Now we'll go on to talk by Dr. Ajay Kirtane. Many of the people who have logged in are also waiting for your talk, Dr. Ajay. And this is keynote address for the 10 commandments of imaging and physiology in CHIP cases. I didn't put too many CTO or CHIP type of talks. I thought this one is good enough to cover most of it. So I requested Ajay to share his experiences of CHIP imaging and physiology. Over to you, Dr. Ajay.
Thanks, Srinivas. I just also wanted to say that I've been sort of struck by watching the session imaging that started with the live case and then from the prior session into this one. But honestly, I really feel proud that what's being shown here by my Indian South Asian colleagues. It's really the type of PCI that we want to be doing these days, and what we often try to tell people they should be doing, but so few actually do. But to see case after case of thoughtful techniques and using imaging to the best of your ability, not because you want to use it, but because you want to actually help your user. I've shared that with the world. I put that on Twitter, but I think that the reality is that it's really, really great to see. Ziad and I were talking that this has really changed in the last 5 years. Ziad also mentioned, which I agree with, that more and more now physicians are starting to work together in groups as opposed to being in silos. And so some of these changes that we see going on outside the United States are super inspiring to us. And I certainly feel that, in the US, we may be left behind soon. That's okay. I think it's an international focus and perspective that all of us share. And so with this, it's just really nice to be able to present in this session. And for those that can't make this, these sessions will be available online on not only the TCT India site, but also on TCTMD. So I just want to talk briefly about imaging and physiology tips, my top 10. I've divided them into 10 separate areas. I will talk beyond OCT, and actually purposefully, because I knew all the talks were going to be on OCT, I'll show more IVUS and physiology so as to round things out as a whole. Basically, I have institutional funding from a variety of sources. So tip number one, we don't really talk about radiation as something important in the imaging space or physiology space, but it is really important, not just for your patients, but also for you. And I think that it's something where optimization of settings is not something that many labs look to do. They sort of just get the device and they use it until it's about to break. But it turns out that if you actually optimize your device, and this is a paper that was published from our group in our lab, you can basically see with iterative technology over time, but more than just the technology, even tweaking the settings of the technology, you can reduce your dose of radiation. You can you do longer cases, and contrast may not change a whole lot, but yet you can do longer cases, more complex cases with less total radiation. So from the CHIP perspective, these are going to be complex and difficult cases, and it's important to maximize these settings so that you don't start hitting into targets or causing radiation burns or exposing yourself to unnecessary radiation over time. Now, the other thing that I want to talk about is there are also some technological innovations that allow you to look at things in a way that we didn't look at them before. So, for instance, when you optimize your radiation settings and decrease the dose of your radiation, you sometimes can't determine that balloons may be underexpanded or stents may be underexpanded. And so that's sometimes why you end up having to cine, especially as we rely more on store fluoro. But with certain technology enhancements, this is just one by Volcano, for instance, Philips Volcano, where you can see that this is an image taken on fluoro alone, and there is clear underexpansion of a balloon in this case. This was before we put the stent in. I completely agree with the last speaker when he said that you want to, before putting in stents, make sure you've expanded. In this case, we had to go back and do rotational atherectomy because this was a high pressure NC balloon that did not expand the lesion. So radiation, real. Nux, number 2, use physiology when deciding to revascularize. It's interesting, but people often view the CHIP space as one where you sort of say, well, we're just going to treat. And it turns out that especially in the complex patients, the decision of whether to treat or not to treat is one of the probably most important decisions you can make. And it also impacts how to treat, whether you're going to treat with medical therapy, whether you're going to send a patient for surgery, or whether you're going to do PCI as appropriate. But what I often find people have confusion in terms of is when to use physiology. And so the way I like to think of it, there are kind of 3 inputs that we normally have in the cath lab. And we're going to generally talk about stable ischemic heart disease or not the ACS culprit. Non-culprit is fine. You have a clinical scenario. What is the patient presenting with? Chest discomfort, atypical symptoms, no symptoms. You also have non-invasive testing oftentimes, and then you finally have the coronary angiogram. And these 3 things can all be correlating with each other, and they should be looked at together to formulate a clinical perspective and picture of what you're trying to do in the cath lab for the individual patient. So where does physiology fit into this? Well, if you have a patient that has typical symptoms, their non-invasive testing shows an ischemic defect, and their angiogram shows a significant lesion, and they've tried medical therapy, then you don't need to do physiology to sort out or even potentially confuse what's going on. So what I like to think is when there's incomplete data or when there's missing data, that's when you need to use physiology to figure out what to do with the clinical patient. So this is a typical what we call Bayesian approach, come up with a pretest probability, do a test that will change your post-test probability to then determine how to treat the patient most effectively. So here's a case example. This is a case of a patient that has what looks like a pretty straightforward, nasty right coronary artery lesion, looked a little bit calcified, and so we began calling for the atherectomy device. That's because I'm only looking at the angiogram and I'm only looking at the lesion. It turns out this patient actually came to us because he actually had negative stress testing, but a CTA that showed some calcium, and he wasn't satisfied. It was only, and now you see this lesion. So I actually did physiology on it, even down to the PDA, and the FFR was 0.87. We actually didn't treat the patient because he was asymptomatic, normal exercise tolerance, normal stress test. And it turns out that 2 weeks later, he had a retinal detachment and he had surgery that would have been completely off the table and he would have lost sight in his eye. I'm not kidding. This is a true story. Had we treated this patient and put him on dual antiplatelet therapy. So all's well that ends well. He was able to get his surgery, and 4 years later is still completely asymptomatic and has normal exercise tolerance. So reason to do it in this case is because there was a discordance between the symptoms, the pretest imaging, and what we saw in the angiogram. And I like showing this slide because it shows you that our eyes can deceive us. These lines look bent because of the dots in them. In reality, all of these lines are straight. So what am I trying to say here? What I'm trying to say here is our judgment gets clouded sometimes when we interpret the angiogram on the basis of the clinical story. So I presented that first rubric as 3 independent things, but sometimes what we see or what we call changes. We're not as objective about it based upon the initial presenting symptoms. The way I like to put this is that if you give a patient, you take a solid 60% lesion on angiogram by QCA, and you present to an interventionalist a patient that comes in with classic GERD symptoms, the interventionalist is more likely to call that a 40 or 50% non-obstructive lesion. On the other hand, if you take the exact same angiogram and you tell the interventionalist this is a patient with crescendo angina and you show a picture of him clutching his chest, the interventionalist is more likely to call that same 60% lesion an 80% lesion. So our eyes can sometimes deceive us, and physiology can take out the subjective when we look at the angiogram. And it's not just to prevent you from doing cases either. I think in some cases in patients with legitimate symptoms, but yet an angiogram that doesn't look that impressive, this is an example because of a long lesion where the FFR is actually 0.71. And I'm not saying this needs to be treated. You have to treat it based upon what the patient is coming to you with. But in many ways, it can be a little bit more objective if you use it in the appropriate scenario. So beyond physiology being used to decide what to do or what not to do, people don't recognize that it can be used to plan the PCI approach itself. I think we saw an example of that in the live case earlier, where the plan of how you're going to do or what you're going to do was based upon what physiology showed. This is just another example of it. This is a live case we presented about 5 years ago at TCT. Lots of diffuse disease, surgical turndown. What are you going to treat, where are you going to treat. You can see there's multiple bifurcations involved, and there's left main involvement with a restenosis stent and the proximal osteo LAD. What was done in this case is I actually did an IFR pullback, and it turns out that there was a large gradient in this OM here, but the bifurcation was not involved. Why is that important? Well, it avoids me from having to do a bifurcation stent procedure at this bifurcation. We're going to have to do it at the left main. We're going to have to treat this OM and this OM, but at least we can make the strategy simpler by doing physiology. And this was an IFR-based pullback, which delineates exactly where the drops and pressure loss are along the course of the vessel. Now, beyond that, how else can we use imaging to plan our strategies? We've seen several cases of how we changed our strategy based upon imaging, not only within this session. I'll just show you this example, and this is a classic slide from Gary Mintz that basically shows you that many of these left mains, some of these are really old images. You can see the negative, the way it looked on old cine film, where the left main looks significant, it's not significant by IVUS. It doesn't look significant, it is significant by IVUS. And so on and so forth. And particularly in the left main, which, by the way, is the prognostically important vessel. It is the vessel that was used as an exclusion in the ischemia trial. So if we're going to look at patients and try to prognosticate, we got to get the left main right. And it turns out that more often than not, or not more often than not, but very frequently, the left main can be misclassified by angiography alone. So this will help us determine whether it should be treated or not and what the strategy should be. Similarly, we've heard reference to this, and this is that the LAD, when it's involved osteally, often has plaque extending back into the left main. And the same is also true for the circumflex, but that's not always true. So before just looking at the angiogram and saying, well, I think this needs 2 stents, it's really important to image in both directions and see what you're dealing with. Be careful when you do this imaging, because if you just push a catheter through and it's very severely stenotic, you can make the patient ischemic. So you have to be sensible about how you do it. But just yesterday, we had a case of a trifurcating left main, and I imaged in all directions. I thought the distal left main was significant, and it turns out that the distal left main was fine, and really we just needed stents at each of the origins of the vessels, not even extended into the left main, to get a great angiographic result. So all of a sudden, with third brand to a much simpler case just because we did the imaging up front. In addition to doing the strategy, you have to optimize your results as well. And when you optimize, you can use this rule of thumb 5, 6, 7, 8, or even 6, 7, 8, 9, depending on patient size. And essentially, if you do that, your outcomes over long term will be better. Remember, surgery is the gold standard for left main disease. I'll say it again. Surgery is the gold standard for left main disease. That having been said, many patients come to us who are turned down for surgery, who failed surgery or otherwise. And so if we're going to get a good result, we have to do it in the best way possible. And this is one way of doing it. In addition, there's really important data from the Kiko Mahara on the IVUS substudy of Excel showed that there was actually acute stent deformation at the proximal edge of the stent that happened not infrequently, 7% of the time, and was associated with a greater incidence of TLR. That's from our guide banging in and out onto the stent. So image at the very end, make sure you don't have this. If you have it, then you should treat it. Now, beyond using imaging to plan left main bifurcations, what about imaging to plan calcium treatment strategies? And we've heard several talks refer to this. I'm not going to go to it in detail other than to emphasize one important point, and that is that in order to expand a stent in a calcified lesion, we have to fracture the calcium. It's not about just getting your stent to the vessel. With that exophytic calcium you saw in the angioscopic image, yeah, it's going to be hard to get the stent there. But it's worse to get the stent there and not expand it than it is to not get the stent there at all. And the way you expand stents in a hard box is by cracking the box. And that's what fracture is, and that's associated with a greater minimal stent area. Ziad went through this. OCT is very useful for this. There are IVUS-based approaches as well, but suffice it to say that it's the thickness, the length, and the angle of the calcium that can then decide if a balloon is going to crack. Now, beyond calcium, this is another bookend from the last talk. Image all stent failures. If your stent fails, particularly a drug-eluting stent, but frankly any stent, you need to figure out why by doing imaging. And the reason is that it's not just this. This is a classic example of an IVUS image of neointimal hyperplasia. I think you can appreciate where the stent is, where all the neointima is here. And basically, this is why everybody, when they see an ISR, they just say, we're going to put another stent in and that's going to be fine. Sure, that'll be fine if it's neointimal hyperplasia and you can expand the stent. But what if the reason it's restenosed is this? This isn't neointima. What this is an underexpanded stent. In fact, it's 2 layers of underexpanded stent. Now, putting a 3rd layer in, the only thing that's going to do is shrink the lumen even further. And so you need to figure out, is it neointima? Is it underexpansion? Is it neoatherosclerosis, or is it something else? And that's really important and why you need to image. Now, why should we image? I'll put the summary slide up. Well, here's another logical argument. Current stents and PCI are safer than ever. So if the PCI fails, we have to figure out why. For our own sake and knowledge, certainly if you're the patient, the first question you'd ask your doctor is, well, why did my stent fail? So they need to know well. And then finally, we'll treat differently the failure based upon the mechanism. Because if it's underexpansion, we need to treat that. If it's neointima, we need to treat that. If it's neoatherosclerosis, we need to deal with that. And sometimes, if it's just recurrent and there's nothing we can do, we might treat with a completely different strategy, such as CABG, for instance. So it's really important to know this. And then finally, once we treat, we want to make sure, especially this second time around, that we do the best possible job we can. So optimizing our results, especially if they failed because they're at higher rate for recurrence. So beyond imaging stent failures, how do we get good at this, and how do we know how to do this? And I've been talking about this throughout this entire session. If you're going to use it in the toughest cases that are hard to see and hard to figure out and hard to differentiate it, the only way to get good at it is to do it in the non-tough cases or non-complex cases. You've seen pictures like this of what these different morphologies and phenotypes are. If you look at these images many times, you just see it and you know exactly what it is. If you're doing it for the first time because you heard these talks and that sort of thing, it's not going to be that easy. So there are help vehicles out there, but the more you do it, the more comfortable you get at it. And what's really nice also with especially the internet, even in the pandemic, but even before that, is there are a lot of examples of cases and the like. And you can go back, for instance, go back to these sessions. There were so many good cases shown, and look through those cases and see if you can understand what's going on so that you can get better in your own practice. And the reason for that is otherwise it's going to be very difficult to figure out what's going on. This was a case that we had where there was a stent thrombosis due to a stent fracture and also malapposition with an aneurysm. Time figuring that unless you're really used to these images. Here, see the distal stent is underexpanded. Here, there's no stent at all, so that's where the fracture point is. Proximally looks good, and this is an aneurysm formation because the vessel here is much bigger than the vessel at other parts. So, but that's how we figured it out because we were used to seeing these things. Now, what about stent optimization? Do we need to do it all the time? Well, I think there can be a very compelling case made now that yes, especially for complex disease, you do need to use imaging. Now, there are trials ongoing at this point in time to try to more definitively examine that. Ziad's leading one. There's an IVUS trial as well. But in the other studies that have been published, this is the ultimate trial looking at angiography-guided versus IVUS-guided PCI, there is a reduction in cumulative proportion of target vessel failure seen with an image-based approach. Now, many people will look at this absolute risk reduction and say, it's not that big a difference. It's 2 out of 100 patients. But listen, if you're those 2 patients, that's a problem. And I'll show you another reason, just an empiric reason why, after I show you kind of how to do it with IVUS. So you saw the algorithm for OCT, so I'm not going to go through that, but the IVUS algorithm is not dissimilar. The principles are basically the same. You look at the vessel, you look at the lumen, and you try to get what the size of the vessel is by not looking at the lumen, but looking at the vessel size. And based upon that, you can size it a variety of different ways. Now, there can be increasingly aggressive ways. So the least aggressive way, the most conservative way, is just to take the size of the lumen and size according to that. But your stent's going to be undersized if that's the case, because you're sizing to just the lumen and not incorporating the plaque in the vessel. Now, if you go to the vessel itself, though, you're going to oversize, especially because IVUS tends to oversize a slight amount relative to OCT, for instance, or even what the true vessel is. So most of the times what you'll do is do media to media and discount just a little bit so that you basically are sizing appropriately. And that's exactly the strategy that's used with OCT. It's just not media to media, it's the EEL to EEL. But so it's the same principle irrespective of the imaging modality. Now, why should we do it? Well, this is sort of the empirical evidence. I sort of posed this poll on social media and just wanted people to answer the question, because when I ask people how often they image, most people don't really raise their hand. On the other hand, if your dad or your father is having a PCI VLAD and you're assuming that the operator knows what they're doing with PCI and imaging, if I ask people, would you want your father to not have imaging? Nobody raises their hand. They all want it for their father. So if you want it for your father, you should really want it for your patients too. And so if you don't feel comfortable using it, and cost is not an issue, because I do understand that, especially, India, South Asia, cost can be an issue. That I understand. But if you would want it for your father, you should have it for your patients. And that's why if you're not comfortable with it, you should learn how to be. So let's look now at a few final things. I think one is IVUS-guided low contrast PCI is game changing. I don't use that word game changing a lot. It's kind of a marketing term that is used a whole lot. But for this particular scenario, it is actually game changing. And that's the reason for that is because this is a nice study by Amit Amin from here in the United States, where he looked at what happens with contrast volume and what happens with acute kidney injury. And we know that more contrast causes more acute kidney injury. But what he also looked at is you could predict the rate of acute kidney injury based upon clinical parameters. And based upon that rate, did physicians change the amount of contrast they used based upon their risk? And it turns out they kind of did in this highest decile here by about 10 to 15 cc's. In my opinion, that's completely crazy. If you know that your patients have a higher rate of acute kidney injury, then why are you only minimally adjusting your contrast amount, especially when contrast is clearly associated with kidney injury? And there's some controversy as to whether it's directly the contrast or not, but I think most people, sensible people right now would agree that more contrast is bad for these types of patients. And so for these complex patients, the CHIP patients, you can do something that can be called zero contrast PCI or minimal contrast PCI. In our institution, Ziad has really kind of led our program in this in terms of writing the papers and sort of refining the techniques, because many people, Jeff Moses, Paul Tierstein, Dimitri, Karmpaliotis, and others have been doing this for a while, but I think the techniques needed to be elucidated and refined, and for that we have Ziad to thank. And the reality here is that you can do these cases with minimal contrast. You can do diagnostics. I did a diagnostic cath yesterday in a patient with 3 grafts with 20 cc's of dye, and I was actually mad because I could have done it with 15 using a variety of techniques. And the PCI similarly can be done with very, very minimal dye using imaging guidance, and that's the only way you can do it is and potentially physiology to determine what to do. So I do feel this is game changing. It allows you to treat patients you wouldn't otherwise be able to treat, and therefore it really is something to learn about. A few other words: don't overreact to physiology and imaging findings. So here we've been talking about imaging, and physiology, but we want to make sure that the tool is used in the way it's supposed to be used, not as something that makes us do things we don't otherwise want to do. So first, with physiology, just recognize that there is a continuum of risk. This is not something where the IFR is 0.89 equals treat, or the FFR is 0.81, no, don't treat. There is a continuum of risk, and over time, that if you think about patients in that way, you'll do better for them. So I have patients, for instance, I have a woman I just saw in the office on Thursday who basically has a diffuse calcified LED that has an FFR of 0.74, and her symptoms are well controlled with medications. In order to treat her, I'd have to do atherectomy and put in 2 long overlapping stents. So why would I treat her? I'll treat her medically and she's fine. I don't need to send her for surgery either because she's fine and has minimal symptoms with medical therapy. And similarly, I think that you have to think that way. What are you trying to accomplish for the patient rather than just think, oh, it's positive, I'm going to go ahead and treat. That's important. And similarly, on imaging, and Ziad went through this, what dissections need to be treated? Remember, in Illumian 3, dissections on OCT were seen very, very frequently, 30 to 40% of the time after these PCIs. And yet, they don't all need to be treated because we never treated them before. Some of them may need to be. And so the idea here is to hold yourself back and understand what impacts outcomes and what is something you can just observe. And that actually prevents this whole diagnostic therapeutic cascade that can be the bane of modern medicine in a sense. So just think about what you're doing and don't overreact. So to sort of summarize with imaging and physiology, and this is also important because I know so many of the other talks around OCT, I think personally you need to know how to do everything. I know Ziad shares that philosophy. That's the philosophy in our lab. And the reason is because different techniques are good and better or worse for specific indications. And so in this slide, you can see if you're assessing lesion severity, it's really going to be based upon physiology. In the left main, you can use IVUS. If you're looking at culprit lesions, OCT is going to be the best way to do it. And for things like stent failure, OCT and IVUS are good. OCT may have some benefits. Calcium, OCT may have some benefits. And overall, there are different uses for each of these imaging modalities, which is why you need to be good at all of them. And it's only in the cath lab do we, if we don't include imaging, look at a single modality such as angiography to answer all the questions. And so this is a quote from Gary Mintz. It's a legacy of coronary angiography. And I don't mean to throw the angiogram out. You have to be a good angiographer, but think of it as one tool in conjunction with other tools that you can also use to help your patients. So how do you do this? And this is the final slide also from Gary that shows you how to do it. And I think all the prior speakers, in my opinion, have clearly done this. It was really, really nice that Ronnie Matthew showed his whole team, and he talked about his whole team and how they were able to do this, because that's really what you need. It can't just be one person. If you're really committed to imaging and you call for an imaging catheter every case, but no other person in your lab does, then what happens? Everybody groans when you call for the imaging equipment. What you have to do is get the nurses, the techs, even fellows, everybody integrated. You have to explain to them why you're doing it. And when you do it, as you get more and more good at it, it becomes faster. People start pointing things out. It's great to have another set of eyes point out, hey, look at this. Did you see that? That makes me happy. I don't get upset at that. That makes me a better interventionist, because that's less that I have to think about during the case when I know other people are going to point things out for me. And so it's important to do it systematically. And then the final thing I'll leave you with is really important to gather the data and then to use that data prospectively, especially when you collaborate with so many others like yourselves, like folks that have been presenting these cases, to then inform research and push the envelope forward in terms of the research. Because still, imaging and physiology is used in a minority of cases worldwide. So if you're using it more frequently, and then you can show data that this is actually beneficial, if it is, which we think it is, then that will change the world. And that's what this is all about. So thanks so much for listening to me. And again, it's an honor to be a part of this session. Thanks, Srinivas, for organizing this. I can't tell you how much tireless work he's done to get TCT India South Asia up and running, particularly within a pandemic. And so for that, he really should be commended. Thanks again.
A great talk, Ajay. We all enjoyed it. We love it. And it fitted perfectly in our session also here, because not much discussion was happening in IVUS. Everything was around OCT, and you covered that well. And your last point of not to overreact too much to the findings is also a learning for youngsters. And I don't know whether you're aware, yesterday Antonio Colombo proposed a new theory, concept, which actually, when we went back, surprising. What he said was a lot of dissections, even if they're leaving it, and unless there is flow limiting, and pressure gradient he mentioned is unless it is more than 10 mm. In the long term, patients are doing fine with plain balloons, and especially regulating balloons also being available. So we need to see more randomized data, but that was his hypothesis, which is said, because instead of putting very long stents, many of the questions came up in the chat questions also yesterday. I think we need to have more, hear more from him and understand the physiology and concepts what you mentioned. That was talk was on his approach to diffuse atherosclerotic disease, which we see in some diabetic patients in India. But great talk. I am very happy to share with you. Don't think it is getting too delayed. I got the news that still there are 700 doctors logged in. In Arena 1, we had 1892 doctors, and Arena 2, we have 793 doctors who have logged in. So totally we had 2,500 plus logins now. Even this is what gives me happiness, even at this late time, and still there are 793 doctors still logging in this hall. I don't know about the other hall presently, we will find out. But thank you very much for your great lectures. And if you have something, I think we will manage with Ziad and others, and we have Dr. Kirti's talk left after yours. It's up to you, Ajay. Thank you very much for all the cooperation and help what you extend to our meeting. And anything you have to say in the end, or you will stay, whatever you say.
No, go ahead. Well, you guys go ahead with let Kirti give his talk, and then we can go from there. But thanks again.
Again, he needs no introduction, but as a formality, and he's a good friend of me. And whatever nuisances we do in the conferences, he always takes it positively. We were shifting him from that room, this room, still he agreed. Thank you, Kirti, again. We'll hear from him, because many of the times we were thinking OCT is not useful in STEMI, but this man gave a talk before OCT in STEMI. I think Ziad also mentioned in some of it. let us hear, and the graphical representations in his slides and all is wonderful. So let us hear to him. Can somebody keep sharing Kirti's laptop meanwhile? Over to you, Dr. Kirti. Yeah, we can see your slides.
Srinivas, first of all, I take great honor in just being here, being invited by you, and I do consider you one of the best organizers for these kind of meetings that I've ever seen in this country, really. And I commend you for your immense skill at this organization and this amazing
Thank you, Kirti.
organization.
Can you just
really.
make it full screen, Kirti?
I will do that. So,
thank you.
I am going to talk about imaging in STEMI and my approach, and how I'm going to do it is I'm not going to talk about data, but I'm just going to talk about a spectrum of cases which will cover from one end to the other most type of cases that we probably see in our cath lab on a day-to-day basis. This is garden variety, an inferior MI, which is 47-year-old gentleman who's hemodynamically stable. And here we have him come to the cath lab. He's got a lesion which is quite discrete in the mid-LAD, which is 70%. And this RCA shows that there's a large thrombus, there's TME204, and there's diffuse atherosclerosis in that RCA, even though it's a large artery. So the question is, what most of my colleagues asked, how is imaging going to help me here? I'm just going to go and put in a stent and I can be done in 5 minutes. In diffuse atherosclerosis, is it important to identify a good landing zone? Any residual thrombus, is it important, and does it impact and change how I do things, the size of the arteries, and how do I optimize? And is it even important to optimize, especially the edges? So to answer these, when I look at these questions, here I run the OCT, and believe you me, when you have these kind of lesions and you have the OCT catheter in, often enough you will see that you have no flow, and you still do this run. And when you do this run, even though you don't see anything beyond the culprit occluded artery, what is important for you is that you've seen a large part of the proximal artery, which gives you a great idea of what's happening in the artery, and that's important. I don't do these runs, but I've actually incorporated this run just to show you that if you don't have flow, you're not going to have any images, and if you don't have images, you're not going to see. So clearing up an artery to have good flow distally is very important to be able to visualize these arteries, and it's a lesson to learn quickly and early. So here we are, we've done a thromboaspiration, and once we've done a thromboaspiration, what do we look at these images? Even though these images are incomplete, you don't see anywhere before after the occlusion. When you look at this section of the artery that we visualized before, you realize that this is a very complex lesion. There's another lesion which is kind of fibrotic, a little closer to the 45 millimeter mark. And when you look at the landing zone, it's a landing zone which is far away, which almost extends to around 25 millimeters proximal to the target lesion. And that's where you can see the EEL, and you can see that there's nothing in between there you can actually land your stent in. Important. Once you've done a thromboaspiration, you can see that the flow is better. Now you have a better visualization. And what is important is that it allows you to assess your landing zones at both ends. It gives you a great size concept of this artery, and it also tells you what lays in between, which is thrombus. And so if there's a lot of thrombus, then you know you have to work on it. You probably need to prepare that region a little better with a few more runs of thromboaspiration, or maybe sometimes I also use in our younger patients often use intracoronary lytic 2.5 actylase along with apsizumab, and that has helped us a lot. I don't have the time to kind of show you the data on all that, but and we also recognize the spectrum of lesions, which all can be covered, all are nasty. None of them make a good area to land a stent, even though the lumens are good, as Ziad has mentioned off and on. And therefore, when you have this OCT coverage, you know that you can predictably land your stent in these 25 millimeters, and you're going to be safe. And of course, post you've done that, this is your final run, which actually confirms that you've got a great result. You're well expanded stent, not malopposed. And so it gives you the confidence that you just finished your case, and you don't have to do too many pictures, just one picture, one view, and one OCT run helps you just finish and conclude this case. What do you do with the LAD? Would you go and image it? Would you do an FFR at this time? Would you kind of discharge him and get him back? I mean, we all talk completeness of the procedure, complete revascularization. In our practice, all this while, when I see these kind of lesions, what I've done is I've discharged these patients and got them back, and in 8 weeks, you see a nuclear stress imaging, which is without any significant ischemia there, and I think this man is doing well, and I would continue treating him medically. It was interesting, and it's provocative to see this article in the Circulation Interventions published the table issue with the non-cut lesion morphology with ST elevation, myocardial infarction, and when you divide it into obstructive and non-obstructive lesions, you can see that there's a significant proportion of them which are what was initially defined as vulnerable and now as TIGFA blocks which are present. How do you compile this data into changing your intervention? I don't know. But this is interesting data, it's provocative, and it is actually thought-provoking and futuristic, I believe. I think somebody mentioned about diffuseness of disease in this country, and I think Ajay mentioned that. And we often face these kind of elderly patients who come in with an infarct, they're diffusely diseased, they're calcified, and there's no area of landing zone, and if you were to chase a landing zone based on plaque burden, you'd be chasing the top end of the artery to the bottom, and you'd be stenting in the entire artery. And so here, I think once you've even though it's a STEMI, you ending up doing a rotational atherectomy, because one of the important things that you really recognize is that it's okay to recognize calcium once you've done an image and then define whether you need to have a rotablator. But most of the times, if you can't put your imaging catheter in, then you have to, by default, do a rotational atherectomy to be able to do some kind of an imaging data. Here we did a 1.25 burr, followed it with a 1.5, because you need to have some kind of a lumen to clear up the contrast and have great OCT images. And here is an OCT image, a run after that. And you can see that this is a heavily plaque burdened artery. It's difficult to see any EL anywhere in this artery. But what do you do in these circumstances? Do you just stent? When you don't know where to land your stent on either side, I think it doesn't matter. You just choose a good lumen on both sides, and the lumen has to be, and the landing zones have to be fibrotic. They have to be non-calcified nodules. They have to be non-lipid cores, and that is exactly what we did. You can see that the distal landing zone was fair. You could see the EL, but the proximal landing zone was not, because there was these protruding calcified nodules. So you kind of shift your target a little bit, get a better location, and then put in a stent which appropriately fits in, and these imaging helps identify a safe and keep it simple strategy to kind of conclude these cases with a great result. And this patient's doing well. What was interesting to find that most of these times calcium is often associated in its neighborhood with these thin cap atheromas, making rotational atherectomy an issue, because you need rotational atherectomy to be able to land your devices and expand them. But you also be careful, because often enough your biases is very close to these very lipid necrotic plaques, and these patients can have very high slow flow situations when you use these kind of devices. And it's important to recognize that. Again, in a 69-year-old anterior MI for more than 24 hours duration presented to our EMS, and this is a creatinine. Most people wonder, this is a right coronary artery, which is normal. And if I talk to my colleagues, they say, why do you need to open an imaging catheter? So expensive. I would just go put in a 3.5, 18 stent and be done with it, and I'll be done and be home within 15 minutes. So here's why I do it. Once we've established flow and we get a great image, I think it's important to kind of understand this image and pull it through properly. And this is what we get. Right in the middle is at the 26th mark is the target lesion. Beyond that, you can see the diagonal branch and the septal branch that's beyond. What would most people do is land a stent just before the bifurcation, try to avoid crossing the bifurcation, and put in a 15-millimeter stent. Now, if you do that, what happens there? First of all, your ostium of the LED is right here. Your landing zone distally seems good, and I think this is your landing zone distally. The question is, this is your area just before the bifurcation in that area, which shows a good lumen, but it's not a great place to land a stent. The plaque burden is good. I don't see much of the EL on any of the sides. This is the target lesion, no question about it. But the question is, what do you do with this area? Where do you land a stent proximally in this area? Angiographically, most people would land it just about anywhere. It depends on what size of stent they choose on the shelf. So when you have a closer look at this area, you realize that there is no suitable area, and this is what I'm playing. This run that I'm playing here is that area, and what I recognize is that not a single, not any landing zone is. When you look at safety, when you address so in this particular patient, it was important for me to extend the stent all the way to the ostium, and so I did. So this is what we did. Put in a stent all the way to the ostium, covered the entire area. Now, how does it translate? How do I optimize the stent? I mean, way before, I think we learned, just divide the stent into two halves, the distal half and the proximal half, and just go and blindly stent, dilate it using balloons in the proximal and the distal half. If you use a 3.5 stent, then your target is around 9.5 millimeters square is your target area. And if you divide your areas in the mid-LED, in the proximal LED, and the ostial LED, then this is what you've achieved. You've achieved these diameters and these MSAs. The question is, if you just look at it as diameters, then what you realize is that, I need to take this away from here. So what I do is I identify the branch and I separate those arteries down beyond the branch and before the branch. And if that and wherever the artery is long, like in the proximal segment over here, it's almost extending to around close to 20 millimeters, then you kind of divide that into further two halves. But what is important is, if you look at the diameter and the MSA over there, you have a 2.6 millimeter artery distally. You've got an MSA of 5.3. In the proximal segment, it's a 3.2 diameter, and your MSA is around 803. What you really need to look at is how do you dilate these arteries? If you look at the reference vessel diameters in these areas is around 2.9 and 4.3. So essentially, you would look at an expansion index of around 89 or 90% in the distal part. So you really don't need to dilate that beyond the diagonal branch at all, but you do need to dilate before the diagonal branch, and that's what you should do. So we divide our balloon dilatation strategy according to our OCT in this fashion and conclude the case. So that's how that's how it helps. So what looked like a very simple, straightforward case, which most people would put in a short stent and finish, for us it was something that we did, and it was important for us to stretch the stent out to the ostium based on the images, and also optimize it based on what we think is important, and take into consideration the vascular tapering that happens after a moderate or a significant branch. And I think Ziad has mentioned this as well in his talk about the tapering concept. I go on to this next case, which is a young man who's had a long story. You can see the story started 20 years ago when he was doing his residency in the US with a cardiovascular thoracic fellowship. And he had angina, had an angioplasty to the RCA, followed by gamma therapy for a restenosis. In 2004, when he got back, he had a restenosis again, and he got 60 millimeters of Cypher stent placed into an RCA. That's when in 2006, when he had an inferior STEMI from avoiding antiplatelets for a week or so for a gastroenteritis. He developed a stent thrombosis, came in with an inferior MI. We did a thromboaspiration of POVA. In 2015, he had unstable angina, and this time, this was the unstable angina reason. We did an IVUS-guided angioplasty that was simple, but we looked at the right coronary artery, and this right coronary artery was patent. However, there was a tight stenosis in the mid-segment, which we used a Flextone balloon, dilated it, and that is it. But we did an IVUS at that time, and this IVUS are these IVUS images. If you see these IVUS images from the distal end to the proximal end, it tells us a story. This is the area where the stents are. And this is the area of where he received gamma therapy in the past, in the year 2000, 2001. Now, when you look at these IVUS images, it tells you that there's almost a loss of architecture of that vessel in the areas which have the drug-eluting stent as well as the gamma therapy. And there's still lots of malapposition and floating stents. The story doesn't end. In 2017, he came back with an inferior wall MI, with an ST elevation inferior wall MI, and this is his angio. We've done our stuff 45 minutes into the chest pain. He received a little bit of alteplase and apixaban into the coronary artery. We did some thromboaspiration, established flow, STs had settled down. But we could see a whole laminar layer of that thrombus in that RCA. So what do? You go ahead and you just wait for your pharmacotherapy to work, and you can see that there's dissolution. We've done nothing at this present time. And when we do an OCT, this is the OCT, when the thrombus was there, you can see that thrombotic areas, you can see the entire cross-section, you can tell nothing. And after that whole thrombus had dissolved with the pharmacotherapy, you can see this is the underlying structure. We just went and did a gentle dilatation using a standard 3.5 balloon and left this artery without any stents. What it tells us is that this artery has absolutely no vasculature. OCT and the IVUS images together tell us that in spite of whatever we do, this man is condemned to life to having these kind of clinical syndromes with the right coronary artery for as long as he lives. Hopefully, he will just live through all of them. And with this, I'm going to close without concluding, because I feel that the only conclusion I can draw is that wherever we can image, we should, because when we do and when we use those images and we react to them appropriately with a rational kind of a background, then I think we're going to make a difference. And the question is whether we'll be able to show that difference in a clinical trial is another question altogether. Thank you very much.
Thank you, Dr. Kirti, for showing another dimension how you are using OCT in STEMI cases. I think the discussion will go on and on, but we are already behind the schedule. And not to disappoint the various chat questions which came onto my WhatsApp, if possible, I'll request you people to take 5 minutes to address this, not to disappoint all these chat questions. A lot of about 15-20 came, out of which I'll pick up and choose appropriate speakers for it to answer. Ajay, you showed a lot of CHIP and interesting high-risk cases. He wants to know in which are the subsets of patients you are using pulmonary artery wedge monitoring while doing CHIP cases. What is your protocol?
Yeah, in general, if the ejection fraction is down, if they've presented with heart failure, then those are types of cases where we'll do a right heart cath at the beginning, and then we typically leave the right heart catheterization in to monitor pressures during the case with a separate transducer. Another population is the chronic kidney disease population of patients. Ziad actually has some good expertise on this, and it's interesting. We use hydration protocols for patients at risk for chronic kidney disease or AKI due to CKD. But if you get into the range of patients with really, really bad GFRs, those are patients who, if you hydrate them beforehand, they'll be in pulmonary edema during the case. And so for those cases, we'll do right heart caths in the beginning or even EDPs at the beginning and then titrate the strategy that way.
I think you prepare the patient well and again do proper therapy with IV decongestive therapy, then get them. It will be also safer if patient can remain stable. Obviously, in such sick patients, as you said, we'll monitor. Another question for probably Ziad can take it. They read about zero contrast PCI. Dr. Anil wants to know, is there any role for carbon dioxide imaging?
Sorry, Srinivasa, I missed that.
CO2 imaging.
So, to the best of my knowledge, the tests of CO2 in animals in the coronary arteries do exceedingly poorly because it creates profound ischemia that doesn't quickly clear. So I've never seen any clinical use of CO2. Of course, it's used commonly in the leg. At least in animal studies, there is a very high propensity towards ventricular fibrillation in the animals. So there's no clinical program of CO2 at the moment. I think what Ajay mentioned about ultra low contrast or zero contrast is important. I think you don't need to do zero, right? You just need to be mindful of the dye and learn the techniques of how to lower contrast use overall. Certainly when you are an expert in imaging and physiology, you can feel comfortable and get to the point where you do zero. But there are a lot of tests, puffs, checks that we do during our procedures which are really unnecessary. When you're putting in your first stent, which is sized to the distal reference, you can't oversize the artery. So taking a test after that is largely of little utility. So, and when you have an imaging catheter to allow you to determine all of those checks in between, we can quickly minimize the amount of contrast that we use.
Yeah, thanks for sharing the tips for minimizing contrast use. One other utility where we found carbon dioxide CO2 utility usage is in renal artery stenting. I think sometimes when the patient had two bad kidneys, we did some cases carbon dioxide usage, in renal artery stenting. It was reasonably okay. We did have about 3-4 patients we did it. But that's a periphery. I think coronary, as you said, it may not tolerate ischemia. One last question from Dr. Ramdev Yadav from Delhi. Does underexpanded stent dilatation with drug-eluting balloon or without drug-eluting balloon, will it be different?
Yeah.
Hypothetical
If
question.
possible, if possible, I think we should use a drug-eluting balloon. But if it is within first 3 months after a drug-eluting stent implantation, even a ordinary non-drug-eluting balloon like NC should be sufficient. But beyond 3 to 6 months, if you feel that the drug will be gone, probably then the DEB might have a role there.
Yeah, the only thing is most DEBs are you're not going to get big expansion with a DEB. So what you might do in that situation is expand it first with an NC and then finish with a DEB.
Yeah, DEB should be used like a stent rather than like a balloon because they tell you emits the drug. You prepare the bed well and then use the DEB for the drug elution. I think that's the right way to. And one last question, Ziad, when you are using OPN balloon with very high pressures, the question doubt expressed is whether you use the same sizing with OPN or you will slightly undersize because you are going too much high pressure there. What are your thoughts?
So first of all, we don't have the OPN balloon, unfortunately, in the U.S. I have some experience from outside of the U.S. To the best of my understanding, we still use a 1-to-1 size balloon. What we should be attempting to do, especially in under expansion, is to stay within the stent margins. But I think the likelihood of fracturing the calcium with an undersized balloon is going to be lower. But I'm guessing. I don't know the exact answer.
Kirti, you want to take it?
Actually, the guideline says OPN, for example, for post-dilatation, if you are using, you can use it as 1:1, as Ziad Ali said. If you are using it for preparation, like, for example, before stenting, if you are using it, you will have to undersize by 0.5 for lower size. That is what is the guideline given by the company from OPN.
Okay, thank you. Any final comments for anybody before we close?
Actually, I've actually moved away from using OPN in my practice because when you really have a resistant lesion, when you need it and when you use it, the advantage being that at very high pressures, it does not increase in diameter. But what I've seen happening is it lengthens like a sausage, and that's a problem when it goes beyond the 10 or 12 millimeters that the length is, and therefore it gets into geographical areas beyond. And I think that is dangerous. There's one example that Sai Satish shared with me where the shaft of the balloon in the guide catheter opened up and became a balloon right over there. So we've just actually given up the use of the OPN balloon, especially because we have the lithotripsy now, which is probably, I hope it is safer. Yeah.
Okay, thank you all. I think we have to close for today's discussion.
Thank you, Srinivas.
Thank you one and all for staying so long, and that's how doctors also continue to log in. That gives me a lot of encouragement to continue such sessions. Thank you all the people who have logged in till the end also, and thank you all the speakers. Tomorrow I would just like to recapitulate that session because Sunday, instead of yesterday and today, it will start at 1:30 p.m. in the afternoon and go on till 9 o'clock. We have structural heart interventions, TAVR sessions, as well as congenital heart interventions. For coronary people, there are some talks on imaging physiology and CTO. Dr. Pratap will do a live case. And then you have a TAVR live case coming up tomorrow from Eternal Heart Center, Jaipur. And other continuing challenging cases will continue. And we have another most important session in the end. I kept it because the innovative therapy sessions, where each of these new therapies will be dealt by experts. I think we have Ajay who will be dealing with RDN. We also have a separate workshop-like thing to discuss more in RDN in the other hall. And then the main hall will have innovative therapy sessions where we cover all the newer upcoming modalities like RDN, balloon pulmonary angioplasty for CETPH, acute stroke interventions, and newer heart failure therapy, the beat heart failure therapy, and many others more. And so request all of you, if you have time, please jog in. Ajay, I remind you again, anyway, you're back. Thank you. All others who have time, please log in and make sessions more interesting. Thank you, one and all.
Thanks.
Nice to
everybody.
see you all. Bye-bye.
Thank you.
Thanks.
Bye.
Kirti, I like the beard.
Thank you, Ajay.